Good afternoon, everyone. On behalf of the organizing committee, I welcome you all to the third poster session and Hall C for Fertivision 2020. We have had a wonderful 2 days of academic discussion and beautiful posters. I hope the third day also will be just as great. I welcome our esteemed judges, Dr. Neha Gupta Jain. She's Senior IVF Consultant at Baby Joy IVF Center, Delhi, and Head Consultant at Mother's Care Clinic, Delhi. Dr. Rahul Sen. He's a consultant embryologist and executive member of ACE India. He's also executive member of IFS Rajasthan chapter. Dr. Charulata Chatterjee, she is senior consultant embryologist at Yashoda Fertility and Research Institute, Secunderabad. Dr. Gitanjali Kaur, she is consultant gynecologist at Pal Hospital, Ludhiana. All our judges are experienced in the field of ART. And now over to Shefali. We'll start the poster session.
A very good morning to all the judges and the participants. So we are going to start with our EASE poster session. Now I invite our first participant, that Dr. Balbir Kaur. Dr. Balbir Kaur.
Good noon, respected judges.
I would just like to remind everyone that everyone will have 5 minutes for presentation and questions. So please keep your presentation within 2 minutes, 2-3 minutes. Please start.
Can you hear me?
Yes, please start.
Good noon, everyone. Today is my topic of my poster is the comparison of GnRH agonist and HCG trigger in IVF cycle. So the question arises, does the use of GnRH agonist for triggering the final oocyte maturation in IVF cycle improves the outcome and allows us to set up a OHSS-free clinic? The aim of the primary objective of my study is to compare the oocyte maturation rate, fertilization rate, and number of good quality embryos obtained in the IVF cycle, which are either triggered by the GnRH agonist or HCG. The secondary objective was to compare the incidence of OHSS. So we did a retrospective observational study of 100 women who underwent IVF cycle from January 2019 to September 2020, who were treated with the GnRH antagonist. The inclusion criteria were the age group of 20 to 35 years, BMI 18 to 29, AFC 8 to 16, and we excluded the patient with poor ovarian reserve, PCOS, and recurrent miscarriages. Out of 150 women received injection Ovitrel and 50 women received injection Dupride as an ovulation triggered, and oocyte pickup was done 34 hours later. So result of my study was there was no statistically significant difference between the oocyte retrieval rate, number of good quality embryos, and the fertilization rate. However, the oocyte maturation rate was higher in the GnRH agonist as compared to the HCG group. And there was 3 patients of OHS in HCG group, but there was not a single patient of OHS in the GnRH agonist group. So to conclude my study, the use of GnRH agonist as an ovulation trigger can improve the cycle, the oocyte maturation rate in the patient who are treated by the GnRH antagonist cycle, and it produced the oocyte which are comparable to the maturation rate to the HCG, or even better than those, and it decreases the risk of OHSS. And this our data may reassure the future investigator to produce the larger study on this potentially effective regime to reduce the risk of OHSS. Thank you.
Can I ask the question?
Yes, please, ma'am.
Yes, ma'am.
Yeah, thank you, Dr. Balbir Kaur. I want to know that what are the inclusion and exclusion criteria for your study? First question.
We included the patient who are having the younger age patient with normal BMI with normal AFC count.
So
either they were like normal.
And did you also included PCOS, exclusion of PCOS, or PCOS was also included?
No, PCOS was excluded.
No, fine. So it is understood that agonist stimulates the FSH and LSH, which helps the expansion of the cumulus cells, and ultimately it helps in the maturation of the oocyte. So I just want to know that whether it is a fresh embryo transfer or it was a frozen embryo transfer?
Actually, ma'am, in one patient we gave the GnRH agonist, we went for the freeze cycles.
Went for the
Freeze all cycles. We did not transfer in the same cycle. Yes, ma'am.
So in both the cases, wherever HCG trigger has given an agonist, where both the cycles is freeze all cycle?
Like if HCG, there was a risk of OHSS, those were freezed. Otherwise, fresh transfer was done in the HCG group. But GnRH group, we did the freeze all cycle for.
But that is a bias in the study, no?
That's why we did not go for the clinical outcome for these patients. We just stopped on the oocyte maturation rate and
not only clinical, but okay, fine. So that is because in a fresh, so you never went means fresh cycle in the agonist.
In some cycle we went, but the results were not good. That's why we then we went for the freeze cycle.
So that has to be, you know, categorized in the study. Okay.
Yes.
Thank you.
Thank you, ma'am.
Any other?
Yeah. I would like also thank you, Balveer, for your presentation. I would like to ask you, was the same protocol used for stimulation? Because and AFC also varies so much. What are the protocol used for stimulation in these patients?
Protocol was used same, like FSH was used 150 to 300 international unit, and it was the dose was tailored according to the response. And when the follicles were reached around 14 mm diameter, 2 or 3 follicles, then we started on GnRH antagonist. And then when the like leading follicles were more than 18 to 20 mm, then we gave the trigger, either the GnRH agonist or the HCG. And after 34 hours, we did the womb pickup.
So another thing I wanted to say that the BMI 18 to 29, a wide range of BMI was used. So again, that can easily affect the results. 18 to 29
so
BMI.
We took the we took the patient which were on the normal BMI, not the obese or not the like. So the this won't affect on the our doses of the gonadotrophins.
Thank you.
And the response according. Thank you.
So can we move to another participant?
Yeah.
Okay. Thank you. Thank you, Dr. Balveer.
Thank you, everyone.
Okay. Now I invite our second participant, Dr. Nisha Malik.
Dr. Nisha, please unmute yourself.
Hello, can you hear me?
Yes, please continue.
Good morning all. So my study question is whether the mode of conception influenced the perinatal outcomes among women who conceive after infertility. So our aims and objective was to compare the perinatal outcome among women conceived after infertility according to the mode of conception, whether it was spontaneous, by ovulation induction, or by IVF or ICSI. So it was a retrospective cohort study which was conducted at PGIMS Rohtak for a duration of 1 year. And the case records of 102 antenatal women who conceived after infertility were reviewed, and they were stratified into 3 groups according to the mode of conception. But only those with a singleton pregnancy and who were more than 28 weeks period of gestation were included in the study. So out of the 82 women who met the inclusion criteria, the maximum 46% conceived by ovulation induction, 34% were spontaneous conception, and 20% by IVF and ICSI. So when we see the results, this table shows the demographic and obstetric characteristics of these women. Among all the variables, the age and duration of infertility, they were significantly different between the 3 groups, as age and duration of infertility were higher in IVF ICSI group, and that is understandable. And all other parameters like parity, BMI, POG at delivery and previous cesarean section, they were comparable. When we compared the pregnancy and perinatal complications among these groups, there was no significant difference obtained. But when we see the mode of delivery, the women in IVF-ICSI group, they had a significantly higher cesarean section rate. Among the neonatal complications, there was no significant difference except that a 1-minute Apgar score, a low 1-minute Apgar score was observed more frequently in the spontaneous conception group. So although it was a retrospective study and with a small sample size, but it encourages that the measures to lower down the cesarean section rate must be there in the ART conceived women. Thank you.
Can I ask one question?
Yes, ma'am.
Yeah. Thank you, Nisha. I just want to know that did you consider singleton or a twins pregnancy here?
Yeah.
Yes, ma'am. I included only the singleton pregnancies.
Fine. So there was no twins pregnancy. But
no.
I can see from your poster that in infertility, IVF and ICSI conceived, that's the age and year of infertility is high there. So definitely if age group is high, that is written in plus 35 plus, the chances of other complications also will be there. So that could be the reason for the cesarean, not only the IVF ICSI.
Yes, ma'am, but when the pregnancy and perinatal complications were seen, they were not found significantly different between the group.
You haven't compared ultrasound or Doppler parameters. Nothing that has been compared for deciding on the mode of delivery. So any complicated patients were not taken?
No, it was not like that. But all the patients, some had IUGR, some had Doppler abnormalities also, and some had other pregnancy complications. But all the three categories had these complications, and there was no much difference between the groups.
So these were not taken in the consideration of because they also have a significant bearing on the perinatal morbidity, and so
yes.
that has not been considered in the because mode of delivery, everything's antenatal, all these factors would have made a lot of difference in whatever perinatal things that were seen. More NICU and ICU admissions were seen in the ovulation induction as the group had much more NICU admission. So those very important antenatal factors were not considered in the study.
Ma'am, I have not included the table because it was not significant, but I have mentioned in the results, I compared that, but I mentioned in the results because there was not even a single complication which had shown any significant result. So that's why it was not highlighted in the poster.
Okay, thank you.
Thank you.
Hello, Dr. Nisha.
Yes, ma'am.
I'm Dr. Neha here. I wanted to know exactly what were your exclusion criteria. Basically, what have you excluded?
I have excluded the multiple pregnancies and those who undergone abortions, and so just included those with more than 28 weeks period of gestation.
Any pregnancy
or any other ectopic pregnancy, and all these were excluded.
Okay. Like previous miscarriages and previous bad obstetric history, everything you have excluded?
No, these were included. Only the multiple pregnancies, abortions, and less than 28 weeks period of gestation.
Okay, fine.
So can we move to the another participant, judges? Okay.
Yeah, thank you.
Thank you, Dr. Nisha Malik. So our next participant is Dr. Nahid Farooqi. Dr. Nahid.
Dr. Nahid, please unmute yourself.
Good afternoon, everyone. Can you see my slide, sir? Am I audible?
Yes, please.
My topic is fallopian tube sperm perfusion versus standard intrauterine insemination. And where does FSP stand today? So the research question was, does the fallopian tube sperm perfusion result in better pregnancy rates than standard intrauterine insemination? Our aims and objectives were to compare the pregnancy rates of two methods of intrauterine insemination, i.e. standard intrauterine insemination and fallopian tube sperm perfusion. Our objective was to evaluate two different methods of insemination, which is standard intrauterine insemination and fallopian tube sperm perfusion for pregnancy rates, feasibility, patient tolerability, and any procedural side effects. Our material methods used was our study design was prospective randomized parallel study design. It was done for 18 months. The study location was IVF Center, Department of Ops in Gynae in Vardhaman Mahavir Medical College and Safdarjung Hospital. The randomization technique used was computerized block randomization, and sample size was taken to be 160, 80 in each group. Eligibility criteria in it, we included all the infertile females less than 38 years of age and in where IUI was indicated, and the exclusion criteria was presence of moderate to severe endometriosis, presence of documented uterine factor in the form of fibroids requiring immediate treatment, all the patients with bilateral tubal damage or obliteration on the hysterosalpingography or laparoscopy, patient needing in vitro fertilization. In it we enrolled the patients for induction, and control ovarian hyperstimulation was done. We monitored, we gave our protocol, induction protocol, and then follicle size 18 to 19 it was monitored, and then injection SCG trigger was used. At that point, randomization was taken, and the n number of 80 number of patients was taken in the group SUI and 80 in the FSP, in which the pregnancy was occurred, they were removed, and the other cycle was proceeded with the remaining number of the patients. We used sonosalpingography catheter for the FSP and IUI catheter for the IUI procedure. Our results were promising. An FSP total 23 number of patients conceived, and in standard intrauterine insemination 10 number of patients conceived, which in this p-value is less than 0.05, which was significant, and other parameters like ectopics when pregnancy were not significant. We also calculate the result in unexplained infertility, which was non-significant, but the number of patients conceived percentage was much higher in FSP less than standard intrauterine insemination. So we concluded that FSP or 2 cycles of treatment offers an advantage in pregnancy rate over the standard intrauterine insemination and could replace the standard intrauterine insemination in certain indications such as unexplained infertility. So 3 to 6 cycles of standard intrauterine insemination in non-tubal infected infertility, depending upon age of the patient, is an accepted management prior to resorting to IVF. So FSP in these patients should be done. Thank you.
Nahid, I have only one question for you.
Yes, ma'am.
Yeah, you didn't even include the paternal factors. So I just want to know.
No, ma'am.
So until and unless you have that control on the paternal factors and semen analysis and parameter, how do you say that this fallopian tube is giving a more success rate and IUI is less, because it is also determining factor?
Yes, ma'am, but the only difference in the method of standard intrauterine insemination and fallopian tube sperm perfusion was that we are infiltrating 0.5 ml of the inseminate, and there we are inseminating 4 ml of inseminate. So, ma'am,
that is not the question of quantity; it is a question of the quality and the concentration and motility.
Ma'am, when we go further, like when we enroll patients, we undergo a performa in which we do all the tests for all the prior tests for the patients, like their prior history, or they have taken infertility treatment or not, or they are like SCG, their all the hormonal profile, everything we exclude.
No, I agree, but it should be included, no, that okay, our post was parameter was such and such for the. So it is a control for both the things. Otherwise, it's a bias.
Yeah.
Ma'am, we included post-wash semen preparations, and in both the it was non-significant, ma'am.
No, that has to be
not mentioned.
No, because you only wrote the maternal factors. So
yeah, you have to write it.
Yes,
to be mentioned.
Okay, ma'am. Okay, ma'am.
Moreover, you have to mention the method of semen preparation also.
Swim up technique, ma'am. We use swim up technique for the semen preparation.
For all the patients?
Yes, ma'am. It will, ma'am. It will do bias. Now, if will take another method, like there are density gradient methods also, but for the uniformity, we took swim up technique method for all the patients, ma'am.
In such case, if you have used only swim up, then I can assume that all the man is a normozoospermia.
Yeah.
Ma'am, we took mild to moderate or moderate patients with like all
Actually, unexplained infertility.
Yeah.
You said unexplained infertility was a major chunk here.
Yes, ma'am. In all the previous studies which were done, there was 2 meta-analysis also done over this topic. In them also they have like said ki it in unexplained infertility there are better chances with fallopian tube sperm perfusion. So we should resort to this before going to IVF.
Time is
good.
Thank you.
Thank you.
Okay, thank you, Dr. Nahid. Now I call our next participant, Dr. Shivani Arora. Dr. Shivani.
Good afternoon, everyone. Today I share a poster on the topic Clinical Utility of Inositols, Lessons of Adolescent PCOS. Firstly, I'll briefly discuss what is PCOS and how inositols play a role in its management. Now, as we all know, PCOS is the most common endocrine disorder amongst reproductive age women with a prevalence of 6 to 10%, characterized by the presence of varying features like hirsutism, acne, menstrual irregularities, and psychological problems like depression, anxiety, and poor quality of life, and many more, but these being the most common ones being faced by adolescent PCOS. Apart from an ovulatory disorder, PCOS is also a metabolic disorder. Now, in the past few years, a lot of interest and studies have been going on two major inositol stereoisomers, one being myoinositol and the other dechirioinositol. These are actually second messengers of insulin involved in many insulin-dependent pathways like PCOS and metabolic disorders. But all we need to know today, is that there is an enzyme called epimerase which works under insulin stimulation and converts this myoinositol to dechirioinositol in approximately 40:1 ratio in most tissues. Therefore, it is also known as the physiological ratio. And in case of this deficiency, a relative deficiency of dechirioinositol is a state of inositol imbalance. Moving on, the aim and objective of this study was simply to compare clinical, hormonal, and metabolic effects of metformin versus a combined therapy of metformin with myoinositol and dechirioinositol in adolescent girls with PCOS. It was a prospective study enrolling 153 PCOS adolescents into two groups based upon lottery method in our Department of Obs and Gynae, where group 1 had 75 participants who received tab metformin 500 mg/BD, and group 2 had 78 participants who received the same dose of metformin and myoinositol, a 2 gram OD dose, and dechirioinositol 50 milligram of OD dose, which is actually the ratio 40:1, which is the physiological ratio which is seen in our body. It was a study with 6 months follow-up, and the results made us conclude that under clinical parameters, we had significant results in global acne scores, Ferman-Galloway scores, improvement in BMI and hip circumference in group 2 patients, whereas waist-hip ratio showed no improvement. Under metabolic parameters, there was significant improvement seen in cholesterol levels, postprandial blood sugar levels, and insulin levels in group 2 patients as compared to group 1. There was no improvement seen in triglycerides, LDL, fasting blood sugars, and fasting insulin levels in either groups. Strangely, there was statistically insignificant improvement seen in hormonal parameters in either group, like FSH, LH, testosterone, and DHEAS levels. Now, if we go back in literature, there are approximately 10 to 12 studies already done over a span of 5 years after the International Consensus Conference took place in 2013 on PCOS with inositols and metformin in reproductive age women. And most of them have shown significant improvement in hormonal parameters. However, none are done on adolescent PCOS and inositols. And this is the first study showing that hormonal parameters do not improve significantly with the use of metformin, with myoinositol and dechloroinositol. Thus concluding the clinical and metabolic importance with combination therapy to correct adolescent PCOS concerns, as combined therapy shows positive additive effect and a promising role in adolescent PCOS. Lastly, clinical data of various studies have demonstrated that inositol results are both promising and high yielding in treatments like PCOS or prevention of GDM. By far, this study is the only study concerning role of myoinositol and dichloroinositol in adolescent PCOS. Thank you.
Ma'am, please unmute yourself.
So it was a nice
Shivani?
presentation.
Thank you, ma'am.
Nice presentation. I just
Yeah.
one simple question that did these girls were kept on any lifestyle changes or any other after that treatment?
No, ma'am. Actually, when
During the treatment, I mean to say.
No, ma'am. Actually, when we went into literature, there was already a study which was done on adolescent girls with lifestyle modification. So we did not want to repeat the same thing. We wanted to do something new, which was not in literature. So we kept only them on only metformin and MIDCL.
Good presentation, Shivani. I wanted to ask you, were these girls menstruating regularly, or was something given for them?
No, ma'am, they were menstruating regularly, but not immediately after the treatment was started. But somewhere like 2 or 3 months later, when on follow-up they had come, they were menstruating regularly.
So nothing more was added up for that.
No, ma'am. No, ma'am.
Age, what was the age that was taken for all of the study?
It was 11 to 19 years, ma'am, but they took mostly women, these girls from Uttarakhand, but 11 to 14, we did not really get a lot of girls complaining about all such things of acne and menstrual irregularities and all these stuff. So we ultimately, we had only mostly majority of 15 to 19.
And how was the advice to be taken along with meals, after meals? How did you advise them to follow a pattern and have compliance of? And what was the compliance? Was it 90%, 80%, 70%? How did you ensure that?
Ma'am, we ensured it by the results we were getting from their menses and the way they were improvement. With their results only, we thought they must be compliant because the results were significant. And other parameters which were not significant couldn't define that they were not compliant because of the significant results in their basic scores of Ferriman Galway and BMI and
Time is up.
Thank you, Dr. Shivani.
Okay. Thank you, Dr. Shivani. So now I invite our next participant, Dr. Vidisha Payal. Dr. Vidisha, over to you.
Good afternoon, everyone. I am Dr. Vidisha Payal from Mahatma Gandhi, Jaipur. I am here to present study on feto-maternal outcomes of breech presentation in a tertiary care hospital. First of all, breech is the most common presentation among all the malpresentations. In this, fetus is in the longitudinal lie, buttocks or lower extremities enter the pelvic cavity first. Among all term deliveries, it was seen that 3 to 4% were breech. With the advancing gestational age, it is seen that there is a decreased incidence of breech pregnancy. The chances of breech delivery were at around 28 weeks of gestation were found to be 22 to 25%. At 32 weeks of gestation, it was found to be less than 7 to 15%. And at term, it was 3 to 4%. My study aims at finding out the incidence, maternal and fetal outcome of breech presentation in a tertiary care hospital. It was a retrospective study which was carried out in my department from 1st of July 2019 to 31st of June 2020. Total 82 cases were included in my study. The demographic data like age, parity, gestational age, mode of delivery, and maternal and perinatal outcome were not noted from the record and was studied. The results of this study accounts to the incidence was found to be 2.8% among the patients attending the hospital. 62.1% belongs to age group of 20 to 25 years, while 26.8% were among age group of 26 to 30 years. In the present study, primary gravida constitutes 56%, while multi constitutes 44%. Most of the cases in my study were delivered by cesarean section, which accounts to 74.3%, while the vaginal delivery amounts to 26%. Most of these were associated with premature rupture of membrane, gestational hypertension, oligohydramnios, postpartum hemorrhage, and antepartum hemorrhage, the percentage of which accounts to 9.7%, 6.09%, 4.8%, 3.6%, and 2.4% respectively. Majority of perinatal morbidity was seen to be associated with preterm birth, which accounts to 30.4%, while some were associated with respiratory distress syndrome, 12.1%, and some have IUGR, which accounts to 2.40%. I want to conclude my presentation by saying that breech delivery is a high-risk pregnancy, which is associated with adverse fetal and maternal outcome during pregnancy and labor. The mode of delivery in a case of breech presentation should be based on parity, gestational age, birth weight, sonographic findings, stages of labor, and confounding factors which affect the health of mother and fetus. Cesarean section, it does not totally eliminate the associated maternal and perinatal morbidity as seen by the study. Thank you.
And please unmute yourself.
Sorry. Vidisha, what was the nutritional status of the mother?
Ma'am, they were from middle socioeconomic status. We excluded the poor or higher class women's, and we only included the singleton pregnancies mainly in this study, which were about 28 weeks of gestation.
Thank you.
Was the baby birth weight considered?
Yeah, ma'am. It was considered. Mainly, babies were found to be between 2.5 kg to 3.5 kg.
Okay.
Was the breech presentation, what kind of breech presentation was it? Was it a flex breech or a foot-link breech? Was that also given into consideration?
No, ma'am, that was not given because only 82 patients were there. So we didn't consider the presentation of breech in my study. We only included parity, status of the gravida status, age of the patient, gestational age, and baby weight.
So there was a vast majority of preterm deliveries in the study. So was anything done to avoid preterm complication rate, anything like transvaginal ultrasounds or something that?
Yeah, ma'am, we did TVS among these because preterm is the one of the leading cause of breech presentation. We did TVS and we ruled out the high risk factors. I excluded all the cervical incompetent cases in these study also. And the TVS whose TVS among 16 week were less than 2.5, the cervical length. We ruled out those cases too.
Thank you.
Thank you, ma'am.
Good presentation.
Thank you, ma'am.
Yeah. Okay. Thank you, Dr. Vidisha. Now, our next participant, Dr. Deepika.
Dr. Deepika, please unmute yourself.
Yes, sir. Good morning, respected judges, teachers, and colleagues. I'm going to present a case on study on comparative analysis of the outcomes of IVF ICSI in women with subnormal AMH with respect to age. We know serum AMH has been used as an ovarian reserve predictor and as a predictor of response to controlled ovarian stimulation in IVF ICSI. We find suboptimal AMH that is less than 2 nanogram per ml in women of all age groups who come to the ART clinics. So there was a question in our mind, will age make a difference? So we divided women who had suboptimal AMH that is less than 2 into two groups, that is less than 35 and age group 35 and above. And the primary objective was to find out the clinical pregnancy rates in women with suboptimal AMH between these two groups, young and old. And also the secondary objective was to analyze the other factors which could determine the outcome of IVF ICSI. It was a retrospective observational study conducted over 10 months at Simon Fertility Center, Kochi. And the exclusion, all women who underwent IVF ICSI were included in the study, and the exclusion criteria were recurrent pregnancy losses and recurrent implantation failure. results. Out of 132 women who underwent 136 cycles, 82 entries belonged to the young age group and 54 were of old age group. And the clinical pregnancy rate per cycle was 38 out of 82 in young age group and 10 out of 54 in older age groups. So it was 46.34% in young age group and 18.52% in the older age group, all who had suboptimal AMH. And the statistical significance was, it was statistically significant. The p-value was 0.001. When we analyze the other factors in young, if we look into the tabular columns, in young age group, between a positive clinical pregnancy and those who did not have a positive clinical pregnancy, among all factors like age, AMH, day to FSH, duration of stimulation in gonadotropin, and E2 levels, that is serum estradiol level on the day of HCG trigger, and the number of metaphase 2 oocytes retrieved, and a follicular count were statistically significant in women who had positive pregnancy, and the metaphase 2 oocytes were statistically significantly higher in women who had positive pregnancies. It was 8 M2s and 8 AFCs, which is higher than women who had a negative pregnancy. If we take the women of older age group, there was a statistically significant difference, a higher E2 level, serum estradiol level, it was 1,800, around 1,800, and the M2s was also higher in women who had a positive pregnancy in older age group. So I would like to conclude by telling age is an important determinant to achieve clinical pregnancy in women undergoing ART. Though serum AMH can be used as a tool for counseling the outcome, we really do not base our outcomes and expectations just based on AMH. However, chronological age is more determinant of achieving a success in clinical IVF. Thank you, ma'am.
Dr. Deepika, can I ask one question?
Yes, sir.
Yeah. Can you describe what was the day of transfer, day of embryo transfer?
Yes, sir. In our study, it was day 3, sir.
All day 3 transfers?
Almost all, sir. In one patient alone, we had to go for day 4 transfer. Other were all day 3 transfer.
Okay.
Deepika, you have mentioned the duration of the stimulation, but you didn't mention the protocol of the stimulation. That is question number 1. Question
yes, ma'am,
is that it is in general, we know that AMH is positively associated with AFC. Okay, so it is known. So that's the reason that p-value, you are showing significant the low AFC. So do you think that instead of this, whatever study you have done, you could have done in a 3 category, that group A1 will be normal AFC, normal AMH, group B will be normal AFC, low AMH, and group C will be low AFC and normal AMH. So it should have some, some conclusion to, some concrete conclusion to decide.
Yes, ma'am. Coming to your first question, the protocol was long GnRH agonist protocol, ma'am. In most of the studies, in one patient in young age group, we had to go for mild stimulation, minimal stimulation, and one minimal stimulation protocol. Otherwise, all underwent long agonist protocol. Yes, ma'am, I agree with you. We have to correlate between the antral follicular count and AMH, and then do a, and also I would say that we should do a case and control study to compare the AFC and AMH, ma'am.
Right.
This was just
another thing is another inclusion criteria is follicle versus oocytes. Like you have a dominant follicle, but how many that mature follicles is giving the oocyte and the maturity.
Yes, ma'am. Yes, ma'am.
Right. Thank you.
And another question from my side will be, were all the transfers fresh or frozen?
So most of the transfers were fresh transfers, sir.
Unless
all were fresh transfers, sir. We had, if the EP had been referred, it could have been because of ovarian hyperstimulation syndrome or any other reason. We had not done an elective freeze-all.
I want to ask something. Most of the time, we now take AMH 1.5 as a cutoff. You took 2. Was there any reason for that? Usually now we take low AMH as 1.5.
Yes, ma'am. We had like less than 1 means like we had really lower pregnancy rate. But then at 1 point, even 1.2, 1.3 also, in few patients we had a lesser pregnancies, and around 0.3 also we had good pregnancy rate. But those were like young women. So that's why we found like just to take less than 2, and we tried to find out the difference between less than 1 and between 1 and 1.9. But they were. Yes, 1 and 2. There was no statistically significant difference in this study, but then we want to just continue the study and just find out like with a larger sample, ma'am.
Thank you.
Thank you. Thank you.
Thank you.
Thank you, Dr. Deepika. Okay, now our next participant is Dr. Rabia Zaman. Dr. Rabia.
Dr. Rabia, please unmute yourself.
Good afternoon, everyone. My name is Rabia Zaman. I'm a PG resident at All India Institute of Medical Sciences, Rishikesh. Today, I would like to present my e-poster on a cross-sectional study of women with premature ovarian insufficiency. As we all know that premature ovarian insufficiency is a type of hypogonadotrophic hypogonadism, WHO class 3. It was previously known as premature ovarian failure, and it's characterized by the accelerated depletion of ovarian follicles causing oligomenorrhea or amenorrhea in women less than 40 years of age, and is associated with raised gonadotropin. It's of two types. It can be spontaneous and iatrogenic according to the mode of onset. Now, this was a cross-sectional study.
Dr. Deepika,
This was a study which was done in Department of Obstetrics and Gynecology from year 2016 to 2019. In this, women less than 40 years of age
Dr.
with
Deepika, please mute yourself.
2 FSH levels in the menopause, that is more than 40 million international unit per ml, obtained at least 1 month apart. They were included in the study. 40 patients were included in the study, and we identified the socio-demographic profile, the clinical presentation, and the probability.
Dr. Deepika, please mute yourself.
So coming on to the results, the first one is the demographic profile. In this, we saw the age of presentation, the residence, and the socio-economic status. Age of presentation, we saw that 60% of population were in the age group of 30 to 40 years. 57.5% population belonged to the urban area. 42.5% resided in the rural area. In urban area, pollution can be a factor. 42.5% rural area, hilly area, the high altitude, the ultraviolet rays can be a contributing factor. Socioeconomic status, according to the Kuppuswamy scale, we saw that 42.5% population belonged to the upper lower class, and around 30% were in the lower middle class. Then the presenting symptoms, we saw that 60% females who reported to us were in the duration of amenorrhea was around 1 year to 2 years. So the initial period was missed because they reported to multiple consult doctors, and then they reported to our center. Then coming on to the symptoms, we saw that around 75% females were infertile, out of which 57.5% were primary, showed the primary infertility, and 17.5% were secondary infertile. And they showed 25% females showed the hypoestrogenic symptoms, out of which the vasomotor symptom was a major concern. Then the etiology, we saw that around 62.5% cases remained unknown, idiopathic. 12.5% showed the environmental factors can be the causes. Iatrogenic, the ovarian surgeries for endometriosis or ovarian drilling, which we saw that 10% cases of that. Then in first degree relatives, we saw that 3 people were having family history, and 3 were autoimmune thyroiditis, and 1 with radiation exposure given for the radiation lymphoma. Now, coming on to my conclusion part, that premature ovarian insufficiency is a life-changing diagnosis. It causes emotional distress and impaired self-esteem in women. So patients should be evaluated at least annually, and psychological counseling should be offered. Hormone replacement therapy should be given for symptomatic relief and to strengthen the bone, cardiovascular, and the sexual health. So a detailed study of genetic evaluation could not be done in our center, should be done. And for the immunological factors on a large sample size, which can be beneficial for a targeted approach to prevent the disease-related complication that it's better understanding. Thank you so much for your patience.
Rabia, it was indeed a good presentation. From my side, I don't have any question for you.
Good presentation, Rabia. I just want to ask you about the environmental factors and something that can be done for it for the future generation. Would you like something for that to comment on those? Because
thank you so much, ma'am. Thank you so much. Thank you so much for your patience.
Yeah. I would like to know about the environmental factors that you enumerate and
Ma'am, I couldn't hear you. Please, could you please
environmental
repeat the question,
factors. Yeah, am I audible? Hello.
Yes, now audible.
Yeah, I just want to know about the environmental factor. Can you elaborate on that? And
Dr. Rabia, please unmute yourself.
Sorry, ma'am. I think I have some internet connection problem. Hello?
yeah. Do you want me to repeat my question?
Yes, ma'am. Yes, ma'am. Please.
Yeah, I would like to know about the environmental factors. What all factors did you come across in this study? Because you said that in an urban area, it was much more. The incidence was more in the urban area. So could you elaborate on that?
I think she can't hear you, ma'am.
I think we
Thank
can type in chat box, ma'am.
Yes, ma'am. It was like smoking was one of the factors. Then, ma'am, smoking. Can you hear me, ma'am, please?
Yeah, we can. Yeah, we can. Please continue. I think you are off the grid again.
Smoking was one of the factors. Then environmental toxins.
Ma'am, I think we can move to the next as we are running out of time.
Yeah, that's okay. That's okay.
Okay. Thank you,
So
Dr.
do we have
Devi.
somebody else?
Yes, ma'am. So last but not the least, I invite Dr. Parul. Dr. Parul.
Yes. Good afternoon, everyone. Can I start, ma'am?
Yes, Dr. Parul.
Okay. I'm presenting my study correlating BMI with gonadotropin dose required per oocyte retrieved in IVF. This study was conducted at Max Multispecialty Hospital, Panchsheel Park, with the study question of does BMI influence the gonadotropin dose required for maximal oocyte retrieval in IVF, with the aim to assess the impact of BMI on gonadotropin dose required per retrieved oocyte during IVF cycles. This was a retrospective study conducted at our hospital from January 2017 to December 2019, and a total of 311 patients who underwent IVF procedures for various indications were included, and they all underwent antagonist protocol followed by follicular monitoring and titration of doses accordingly. The patients were then divided into 4 groups based on the BMI levels according to the WHO criteria. They were divided into the underweight, normal weight, overweight, and the obese groups. They received trigger with either human HCG or GnRH agonist when at least 3 follicles reached 17 to 18 mm size. And lastly, the gonadotropin dose per oocyte retrieved was then calculated, and the data was compared between the different BMI groups. The study showed that the baseline characteristics like mean age, duration of infertility, and causes of infertility were comparable in all the groups, but they were not statistically significant. Also, the serum AMH was also comparable in all the 4 groups, and the difference was not statistically significant with a p-value of 0.579. The total gonadotropin dose required for stimulation showed statistically significant increasing trend from the underweight to the obese groups, as can be seen from the bar graph on the left side, which shows an increasing trend towards the obese group. And similarly, the duration of stimulation showed statistically significant increasing trend from the underweight to the obese groups with a p-value of 0.035. The number of oocytes retrieved showed a steadily decreasing trend from the underweight to the obese group, although it was not statistically significant. And finally, the gonadotropin dose, which was calculated per oocyte retrieved, showed an increasing trend from the underweight to the obese groups. However, this difference was not statistically significant, which is depicted in the bar chart showed at the lowermost corner. So we finally concluded that BMI is an important parameter which influences the gonadotropin dose required per oocyte retrieved in IVF cycles. And as the BMI increases, the gonadotropin dose required for ovarian stimulation also increases. BMI and oocyte recovery share an inverse relationship. Elevated BMI adversely impacts oocyte stimulation by gonadotropins during controlled ovarian stimulation and hence the final oocyte yield. These are my references. And thank you so much.
A very nice presentation, Dr. Parul.
Thank you so much.
I would like to ask one thing. You have mentioned regarding the quantity of oocytes, the total number of oocytes retrieved. I would like to know about what was the quality of oocyte in all these 4 groups, whether you have any good maturation rate in a particular group or the oocyte defects seen in any other group.
So although when the oocytes are retrieved, these parameters are being noted in the laboratory where the oocytes are kept, and these are being noted, but it was not taken into consideration in my study.
Parul, I have one question.
On oocyte maturation, where have you seen the highest maturation, or where you have seen the lowest oocyte maturation rate?
So,
the number of N2s.
Yeah, so these are the points which I told that these are noted in the laboratory, but I did not include in my study. So I'll definitely include it further.
And good quality of embryo formation.
Yes. So they were the good qualities were mostly found in the underweight and the normal weight groups, and was in the decreasing trend towards the obese group.
Parul, it was indeed a nice presentation. I have one.
Thank you so much, ma'am.
With high BMI and this lean, did you also, what was the inclusion and exclusion criteria? What about PCOS?
Ma'am, I also included the PCOS patients in all the groups, and we included all the patients who were undergoing IVF procedures for various indications. So, and I only excluded the cycles which were undergoing agonist, which were following agonist protocols.
Okay.
All fresh or all frozen cycle, or
so both were included.
Both were included.
Yes, sir.
So, Shefali, do we have any other, or it is all?
No, ma'am. This one was the last.
Thank you so much, ma'am.
So we have finished before 10 minutes. We are good.
Yes.
I think if we can summarize this, any questions or any other points that can be.
Yes. Yes, we can conclude the session. If anybody wants to ask question to the participant, so judges.
No, I think we have done as per the poster, no? So,
okay.
Yes. Thank you, dear judges. Thank you for the wonderful discussion, and it was really informative. And I like to thank from the organizers, all the judges, for giving their precious time to this session. And you can just send the mark sheet on WhatsApp to me only. Thank you. Thank you very much.
Good afternoon, everyone. So now we move on to our next session, session 09, where we have the oral free paper presentations. To judge this session, I would like to invite Dr. Sarappreet Singh. Dr. Singh is Senior Consultant and Chief Embryologist at Artemis Health Institute, Gurgaon. Our next judge is Dr. Nalini Bagul. Dr. Bagul is Director, Bagul Hospital and Nasik Fertility Center. And our third judge for the day is Dr. Akash Agarwal. Dr. Agarwal is Scientific Director and Chief Clinical Embryologist at Hegde Fertility Center, Hyderabad. A very warm welcome to all our judges. At the outset, I'd like to say that Dr. Bishita Bagchi will be unable to join us. She was presenter number 3 because of some health issues. We wish her a speedy recovery. So there will be a total of 4 presenters, and all presenters have been allotted a total of 10 minutes, out of which 8 minutes are for their presentation and 2 minutes are for their question and answer session. So I would like to invite our first presenter, Dr. Rajapriya Ayappan. Her abstract number is 16. The title is Sexual Health is Crucial for Couples and Sexual Dysfunction Can Lead to Interpersonal Relationship Problems. Theme is Miscellaneous. So over to you, Dr. Rajapriya.
Thank you so much. Is my screen visible?
Yes, ma'am. Please continue.
My paper is about sexual health. It's crucial for infertile couples. The Indian data is very limited with respect to prevalence of sexual dysfunction. Talking sex is seen as a taboo. Both from the patient's and the clinician side, it is essential to increase awareness and change our perspectives. Consequences of infertility are manifold, such as psychological stress, decreased quality of life, and disturbed sexual functioning. As fertility clinicians, we must attend to holistic health needs of infertile couples. The aims and objectives were to understand the priority given to sexual health in infertile couples, how much information can be gathered in a busy OPD setting in the first visit particularly, the frequency of sexual act based on years of marriage, sexual dysfunction prevalence in men and women, prevalence of timed intercourse, some lifestyle factors which can affect sexual health was studied. The sample size was 1,693 couples. The time period was from July 2018 up to March 2020. It was at Srinivas Priya Private Hospital's OPD setting. The study design was retrospective, cross-sectional observational data. The intervention was primarily history taking during the first visit about sexual frequency and related history. The study discussion is particularly focusing on reproductive aged couples. Intercourse frequency not only plays a significant role into assessing marital relationship quality and sexual satisfaction, but also in determining the couple's fecundity. However, the focus of coitus becomes solely on conception rather than of pleasure, that over time we realize it is not an effective solution to infertility. Sexual dysfunction could be a consequence of the diagnosis, investigation, or treatment of infertility, and the types of dysfunction include premature ejaculation and erectile dysfunction in males, and in females it may relate to desire, arousal, orgasm, or sexual pain. Now let's get into the statistics. Looking at the years of marriage, the purple column shows that those who are more than 10 years married, right from beginning we understand that they are not very sexually active. But if you look at the 6 to 10 years, the effect sets in that some amount of sexual health is getting a little affected. But if you look at those who are less than 3 years married, most of them are very sexually active. So it's that part of time when the thought is not planted that sexual intercourse is becoming futile. But at 3 to 5 years of marriage, they understand that the sexual exercise is becoming scheduled and unsuccessful in relating into a pregnancy outcome. So that group particularly, if you see, they are focusing only on intercourse during ovulation. So I would like to highlight saying that it is important as clinicians not to keep emphasizing that sexual act should happen only during ovulation. Now, if you look at the incidence of sexual dysfunction, which is picked up in the very first visit, only 48 men out of 1,693, of which 2% had erectile dysfunction, 0.4% had premature ejaculation, and both the problems in 1%. Now, if you look at the various lifestyle factors which were picked up, it was either smoking, tobacco chewing, certain drugs, and type 2 diabetes mellitus. 227 of this men cohort were smokers. So thus 22% had some lifestyle factors affecting sexual act. Now, if you look at further in men, almost if you look at tobacco, it is in two forms, either they smoke it or chew it. Those who were smoking, 4% had sexual dysfunction, but those who were chewing had more sexual problems, 6%. And going into the women, 91 women expressed sexual dysfunction in their very first visit. It was primarily 5% endometriosis related pain, 0.3% had vaginismus, and 0.7% had dyspareunia. Now, so roughly 6% had sexual dysfunction presenting, and if you found the various factors which may relate to it, it may be either endometriosis, pelvic infection, or vaginismus. Particularly endometriosis, almost 80 of the 91 women had endometriosis. Now, looking at the results, the younger men and women obviously had a healthier sexual life, and there was a drop in sexual frequency once they crossed 3 years of marriage. The p-value was less than 0.05. Up to 6% women had sexual concerns, either related to endometriosis pain, 0.5% dyspareunia, and 0.3% vaginismus. So endometriosis, we all know, is a predominant cause for pain and infertility. Up to 3 to 4% of men had concerns, 2% had erectile dysfunction, 0.04% had premature ejaculation, and 1% had both. Tobacco chewing seems to be more deleterious. Now, being sexually active alone doesn't equal to sexual satisfaction or sexual health. Now, what are the limitations of my study? We didn't include a validated scale, particularly like an FSFI, Female Sexual Function Index questionnaire. It was not used. Only routine questions which are asked in the first visit, unlike in a sexual clinic, was asked. The patients of one center may underrepresent the whole issue. Medications and medical history was not analyzed in detail with respect to the cause and effect. Let's go into literature evidence. Acta Clinica Croatica Journal 2019 had an interesting study where it was clearly seen that infertility creates a negative attitude towards sexuality in the couple. Particularly, couples who go through the process of infertility treatment are never seriously evaluated for sexual dysfunction. Now, this paper in Fertility Sterility in 2013 tried to understand coital frequency in men, and the outcome was older patients had 1.05 times higher odds per year of age to have less frequent intercourse. If you looked at the International Journal of Sexual Health, a recent 2020 paper, does infertility affect the sexual function and sexual quality of life of women? A case control study. Obviously, sexual function scores of infertile women were picked up as lower. So Fertility Sterility 2006, this paper shows where 200 couples were studied about alteration of sexual desire and satisfaction. Less than 50% of patients mentioned a reduction in sexual desire and satisfaction after infertility diagnosis. Now, this Middle East Fertility Society Journal 2013 by Dr. Rohina picked up that the act of timed sexual intercourse is a recognized risk factor for the development of situational sexual dysfunction in both men and women. And this is something as clinicians we should start paying more attention. So I would like to conclude my presentation saying that couples who go through the process of infertility treatment are never routinely evaluated for sexual dysfunction, nor are helped if they have such a problem. In case of inevitable infertility, quality of sexual life must be given importance such that it stays the same as before the diagnosis of infertility. Almost 45% have impaired sexual health due to infertility, according to world data. Now, scheduled sexual activity only around ovulation over time can impair the natural sexual activity of couples. Effective counseling, reassurance, and measures to reduce the impact of infertility on marital, sexual, and overall quality of life is essential to give holistic treatment in infertility. Sex therapy clinics within an infertility center will help to address the sexual sensitive health needs. This paper is probably paving way for such a path. Future studies have been planned to address sexual satisfaction. Thank you for this opportunity.
Thank you so much, Dr. Rajapriya, for the wonderful presentation. The house is now open for any questions and comments by the esteemed judges.
Yeah, Dr. Rajapriya, this is Dr. Sarapreet.
Yes, sir.
Very nice presentation. You made some very relevant observations in your presentation. And did you find an increased or a decreased frequency in couples, who work in like shift duties, like, IT cities are coming up and patients will normally come up with that, a female is working in night or
Yes, sir. It was an
becoming more
overall.
common now.
It was an overall observation that occupational history had an impact, especially the night shifts, but it was not focused as a particular relationship with respect to the data I collected.
Okay, but we in Gurgaon, it's an IT city, so we do find an increased, incidence of such problems in IT, profession.
Definitely, sir.
Call center, and those people. Akash, over to you.
Yeah. Hello, Dr. Rajpriya. It was thanks, Dr. Sarapri. It was a nice presentation, I would say. Just a couple of questions. Did you try to find out what is the on what criteria did you get to the diagnosis of ED? Whether any criteria were applied when you said 2% of the patients have. So how did we come to the 2%?
So it was like the first visit, so too much of sexual health history was not focused on. It's just like when they present to us with the problem of sexual dysfunction. That is the presenting history itself. Not they present saying that I have this problem, doctor. So my whole study was trying to point out that in the first visit, how many of them upfront come with sexual concerns?
Okay, so this is like upfront, not like the overall prevalence.
Yes, sir.
Thank you. And how many of them have said that post this counseling and everything, how many more were willing to come forward with the diagnosis, like with helping you with the diagnosis? Anything was done like that?
On the further focus, sir,
Yes,
I found
yes.
almost 25 to 30% of the men continued to stay in more in-depth treatment to follow up the particular problem. But that also would wean up, if it didn't give the necessary benefit, they were lost to follow up after 3 months.
Okay. Dr. Nalini, if you have any questions.
Yeah. Hello, Rajapriya. It's a very nice presentation. And may I am audible? Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah. It's very nice presentation. Just wanted to know that in your study, you have seen that the smoking incident, this tobacco chewers are having more problem. So
Yes,
what might be the reason or is it coincidental?
Ma'am, in Chennai particularly, there's this habit of taking Hans. They call that product Hans and they call another product called Mava. And what was picked up, this is again in the first presentation, ma'am, like in the very first preliminary visit, when we take, once they talk about sexual problems, we make it a point to ask whether you smoke or these are the only history factors which are taken in the very first visit. So what we understood is most of it was related to the type of occupation they were doing, like either they were painters or they were long distance drivers.
Okay.
And civil work or hard work laborers, the skilled laborers. And I guess it's a kind of a stress buster for them to take that long, especially drivers.
And about the female factor, you have seen that 80% of them had endometriosis.
Yes, ma'am.
Yeah. Or you have selected the endometriosis
Ma'am, 80% is not 80%. 80% is not. 80 of the 91 women had endometriosis. So maybe I think that particular 1.5 time period, I was caught with more endometriosis patients.
Yeah.
That's why I said it doesn't represent the whole scenario.
Right. So it was a very good presentation. Yeah.
Thank you, ma'am.
Thank you.
Thank you so much, Dr. Rajapriya and our esteemed judges. Our next speaker is Dr. Satish Dipankar. His abstract number is 19. The title of his presentation is The Potential Association Between Poor Semen Quality and Cardiac Autonomic Dysfunction. The theme is male infertility. Over to you, Dr. Satish.
Good morning. Good morning, all. Am I audible?
Yes.
Yes, Dr. Satish, please continue.
Yeah. Thank you. My topic is the potential association between poor semen quality and cardiac autonomic dysfunction. As we know that infertility itself is a stress. The long-term infertility after marriages, it results in a stress and mental trauma to the couples. Those are not getting conceived after 2 to 3 years of the marriage. So now we see that the prevalence of the infertility has been also going to increase in last 2-3 decades, and this quality of semen is also going to decrease. The main reproductive health is deteriorating due to the deleterious environmental pollutants such as physical and mental stress. And after this World War II also, most of these environmental stress are going to increase, which are going to affect the main health. So we try to assess the semen quality and heart rate variability. Those patients visiting to the andrology laboratory of physiology department and try to go whether there any association between semen quality. So the setting is a tertiary care hospital retrospective. It is a retrospective cross-sectional comparative study, and we included all these male partners of the infertile couples visiting to the andrology laboratory, where all these male partners of these infertile couples were underwent for semen analysis as well as heart rate variability. The autonomic function lab is just nearby to the andrology lab. So simultaneously, after getting semen collected, we tested their short-term HRV for 5 minutes. So up till now we got 237 males, and we entered this data, the semen analysis and heart rate variability data, and we found that most of these male partners, those are having poor semen quality, they have deranged heart rate variability parameters. So we assess the semen by using this WHO guidelines, recent by using Power Lab ECG analysis and lab chart 8. Among the infertile males, we got the lower values of the semen variables, including decreased sperm count, decreased motility, decreased vitality, decreased sperm morphology, like that, and in comparison to the normal healthy fertile males. Also, in these among these infertile males, we got this most of these HRV indices like domain and frequency domain parameters were decreased, and these parasympathetic parameters, while sympathetic parameters were increased, and which indicated that the infertile male group is under stress. Also, we applied this Spearman correlation test, in which sperm and sperm agglutination were strongly correlated with the values of these HRV parameters, of especially sympathetic parameters, and this reflects that this males, those are having poor semen quality, are under stressful conditions, and they should undergo the change in lifestyle. They should do the regular exercise, especially yoga, and they should change the lifestyle, which will decrease the stress and improve their reproductive health. Nowadays, most of these smart watches are available. We can track the HRV and HRV may be a gold standard method which is freely available. Even by understanding this stress and effect of stress on reproductive health, men themselves they can control their fertility potential and vice versa. So, limitation of the study was done. Still, it is going on, and still we have not achieved the uh, mm, number of patients due to this COVID-19 the pandemic, and we have included this short-term HRV to get the full reflection of this autonomic stress. We suggest recording of this 24-hour heart rate variability with the inclusion of all other autonomic tests. So these are the references, few references. Thank you.
Thank you so much, Dr. Dipankar. The house is now open for any questions and comments by the judges.
Yeah, Dr. Satish, I'm Dr. Sarapreet.
Morning,
Very different and very interesting topic you've chosen.
Yes, sir.
And I would like to know the incidence of HRV in general population. I mean, how is it different from infertile population, infertile males? We can't hear you, sir. Satish, you're not audible.
Please, sir.
Hello, Satish, I can't hear you.
I think your internet connection not stable.
Akash, can you hear him?
No, we can't hear him. Dr. Satish, are you there?
Yes, sir. I'm able to hear you.
Yeah,
Okay,
you can just answer.
Now it is
No
better.
problem.
Please
Video is
answer.
not an issue. You can just answer, sir.
Sir, please repeat the question.
I'm asking you, what is the incidence of HRV in general population? I mean, how is it different from infertile population, especially male?
HRV is one of the. It is a tool, sir, to find out the level of stress among the people. It is a one kind of tool. Heart rate. It is a heart rate variability. We are routinely testing the patients coming to the andrology lab.
Okay, so do you think it can be used as a surrogate marker for male infertility?
Yes, sir. Yes, sir. We can use it for males as well as females also. But at present, we are running the andrology lab only. That's why we have focused our participants or patients visiting to our lab only.
Do you
Both the
think
males and females are under much stress. Even my earlier presenter also told that the quality of life, the quality of reproductive life, is going to decrease among these infertile couples, even if they don't get conceived within time, because this Indian society is a little bit different. Even the females of the this infertile males, even though are fertile, females are the quality of life is so much decreased because of this Indian culture and Indian society. If they don't get conceived, if the male is infertile but still female is blamed, so it can be
we
applied
got
in
the
both
point?
sexes.
We got the point. Next, move on to the next question. Does yoga help in prevention and correction of this cardiac autonomic modulation, which you mentioned?
Yes, sir. Go yoga and change in lifestyle will definitely help.
Please.
Yeah, yoga and this change in lifestyle and other exercise will definitely help to improve the heart rate variability.
Okay. Have you published any literature on this?
Not yet published, sir. We are planning to publish it.
Because AIMS New Delhi, they have also been, especially the physiology department, they have been working on yoga for a very long time now.
Yes, sir. Yes, sir. That Yadav, sir, Dr. Rajkumar Yadav, sir, is doing that.
Okay, Akash, you can ask now.
Hello, Dr. Satish. I would say a very apt topic you have chosen with respect to modern lifestyles. Just a couple of questions, you have applied any inclusion or exclusion criteria, there could be confounding factors previous cardiac pathologies, known pathologies, or
Yes, sir.
hypertensive medicines they are
Yes,
on?
sir. Yes, sir. Exclusion criteria was the chronic diseases, patients suffering, or these participants suffering from this chronic diseases, chronic heart diseases, hypertensive patients. We have excluded, especially excluded such participants. And those patients, those participants, those are not suffering from any kind of chronic diseases, or they are not taking any medicine, for example, antihypertensives and other medicines. Those patients only included in the study.
Okay, because yeah. Your voice is breaking, Dr. Satish. I couldn't hear the last couple of lines. Your voice was breaking.
Yes, sir. We am I audible?
Yeah, the last line was audible.
Yeah, sir, we particularly excluded those participants suffering from chronic diseases, especially heart diseases, and those participants taking clearly included participants.
Okay, and like you have presented in the conclusion, I would just like to point out, like you have mentioned that it could be a great gold
That's why we're
standard.
being a little bit part.
I think this
Sorry.
the voice is breaking in between. Is it only
I
from
think
my?
there is a network issue with Satish.
Yes.
So if you're okay, then we can move on to the next speaker.
Yeah, that will be better.
Yep, yep, I think so.
The next speaker is Dr. Aditi Kanwatia. Hello.
Yes.
The next speaker is Dr. Aditi Kanwatia.
Ma'am, am I audible?
Yeah, Dr. Aditi Kanwatia, abstract number 63, and the title of her paper is Cumulative Live Birth Rate per Ovum Pickup in Couples with Male Infertility Undergoing ICSI-ET with Testicular Sperms, a Retrospective Study. Over to Dr. Aditi.
Good afternoon, sir. Today my topic is cumulative live birth rate per ovum pickup in couples with male infertility undergoing ICSI-ET with testicular sperms, a retrospective study. Introduction. Intracytoplasmic sperm injection is a great boon for the treatment of male factor infertility due to severely abnormal semen quality and in azoospermic males. Surgical sperm retrieval from testes or epididymis can yield spermatozoa capable of fertilization with ICSI in non-obstructive and obstructive azoospermia. And this study reviews the reproductive potential of male gametes extracted from the epididymis or the testes. In order to obtain reliable data for counseling patients, this study aims to analyze live birth rates in patients with successful sperm retrieval. These are some articles which shows that the comparison of sperm retrieval and the reproductive outcome in azoospermic males. And these are TESTI-ICSI is an effective option to overcome the male infertility associated with the high DFI. Aims and objectives. Primary objective is to find out the cumulative clinical pregnancy rate and live birth rate per ovum pickup in the infertile couple with male factor infertility following ICSI with surgically retrieved sperms. Secondary objective is to find out the time to clinical pregnancy and live birth with surgically retrieved sperms. It is a retrospective study over a period of 5 years from 2015 to 2019. A total of 96 ovum pickups where male partner underwent successful surgical sperm retrieval. Outcome measures. Cumulative clinical pregnancy rate, which is defined as a visualization of gestational sex with fetal heartbeat on transvaginal scan per number of women who underwent ovum pickup, and cumulative live birth rate, which is number of live births per number of women who underwent ovum pickup. So all the patients are followed till achievement of a clinical pregnancy or a live birth, and all the embryos get exhausted. And exclusion criteria: no embryos were available after ovum pickup, no embryo transfer done, and women who underwent one or more embryo transfers with no successful results, but all the embryos were not exhausted. Statistical analysis using SPSS 22 software. Surgical sperm retrieval done in 105 patients. with successful retrieval in 96 of them. 14 of them met an exclusion criteria where no oocytes were retrieved in 2 patients, fertilization failure in 3, and embryos are still cryofreezed in 9 of them. Total analyzed patients were 82. Out of 82 total patients, 56 of them achieved a clinical pregnancy, where 53 of them achieved a live birth, with a cumulative live birth rate of 64.63%. It's an outcome attempt of embryo transfer wise. 46 patients undergone first in 1 embryo transfer. Out of those, only 38 achieved clinical pregnancies and 36 live births. 32 of them undergone 2 embryo transfer attempts, and 18 achieved a clinical pregnancy and 17 live births. And none of them achieved clinical pregnancy and live birth after 3 embryo transfers. Surgical sperm retrieval with subsequent use of ICSI have provided an opportunity for azoospermic males to have their own biological child. Cumulative clinical pregnancy rate is 68.29%, while live birth rate is 64.63%. And time to pregnancy is only 1 embryo transfer in 46.34% of the patients, while 68.29% conceived in 2 embryo transfers. Live birth rate is 94.64% of all clinical pregnancies. That is, miscarriage rate was in surgically retrieved sperms is less than 6%. Limitations of my studies: female factor is not taken into consideration, and limited data regarding the health of offspring with the use of testicular sperms. Conclusion: it is of utmost importance when counseling patients with male factor infertility who decide to embark upon testicular sperms and eventually ICSI to give a correct and realistic estimation of the actual chances of parenthood. Thank you.
Hello, Dr. Aditi.
Good afternoon, sir.
Good afternoon. I'm Dr. Sarapri. Have you calculated the cumulative pregnancy rates and live birth rate per OPU for severe oligospermic patients at your center?
Yes, sir. In my total study, there were 17 patients with severe oligospermia with high DFI, that is more than 30%, and they have a history of recurrent pregnancy loss. And so in those patients, out of 17, 11 of them achieved clinical pregnancy as well as live birth.
Okay, so it was an elective TISA.
Yes, sir. It was elective TISA.
Okay. It's a good study. It's a very relevant study in present times. Akash, you can ask.
Thank you. Hi, Dr. Aditi. Nice presentation, I would say. Just a couple of queries. Whether any criteria was applied for the patients undergoing TISA, because retrieval rates we are seeing like very high, like 105 patients had undergone TISA and you had successful
Yes, in obstructive azoospermia, almost 97.5% was the surgical sperm retrieval rate. So 40 patients undergone of obstructive azoospermia undergone sperm retrieval, out of which 39 of them have achieved a successful sperm retrieval. And also in this severe oligo, all of them have achieved a surgical sperm retrieval. Only in non-obstructive azoospermia, the retrieval rate was less. That was 75%.
So are you getting better results in obstructive azoospermia cases or severe oligo cases when you go for a TISA?
Sir, it's almost the same results, sir. Basically, the more better in severe oligo with high DFI.
You're better in severe oligo cases.
Sir, it was 100%, and in the obstructive, it was 97%. Not much difference, but.
But the female pathology was not taken into consideration.
Yes, sir.
That's a loophole actually in your study.
Yes, sir.
I think
I was like very
normal.
Sorry, yeah, please go.
I think all normal females you have taken into account, it seems.
No, ma'am, but some of them have a female factor also, but I have not taken that into consideration, like poor ovarian reserve, so that the number of embryos formed were less. So though I have none of the embryos were available for frozen embryo transfer. So that was actually a drawback of my study.
Yeah, right.
Yes, Dr.
What is the regular pregnancy loss rates at the clinic, Dr. Aditi? Like overall, what is the regular pregnancy loss rate?
Sir, I have to go back and look.
Because here it is shown like it is only 6%, right?
Yes,
So I
sir.
just wanted like what is the regular pregnancy loss with IVF patients without any adjustments or overall like cumulative, all the indications, because it is written as 6%, which I would say is really fantastic, I would say.
Sir, I'll definitely look into this also in consideration next.
I just wanted to compare like what is the regular success rate if you see for the overall population of the patients who are visiting the clinic, and whether any comparison was done like patients who have undergone TISA. So is it giving better results in terms of pregnancy rates and in terms of live birth rates?
Yes, sir.
Okay. Ma'am, any questions here?
No, it's not. Over to next.
Move to next presentation. Thank you, Doctor.
Thank you, sir.
Dr. Deepika, please unmute yourself.
I would like to call upon the last speaker of the day, Dr. Poonam Upadhyay, abstract number 50. The title of her study is The Impact of Smoking and Alcohol Consumption on Semen Parameters. Over to Dr. Poonam, please. Dr. Poonam Upadhyay.
Am I audible, ma'am?
Yes, yes. Yes,
Okay.
Poonam.
Just
Start. Yeah.
Hello, respected judges. I'm Dr. Poonam Upadhyay from Origin Fertility and IVF Center. Today, my topic is effect of alcohol intake and cigarette smoking on semen parameters. Now, as we all know that infertility affects around 17 to 20% of the couples, and male infertility play a key role in conceptions. And in 20 to 30% cases, it has been seen that male infertility is a sole contributing factor. And this has drawn an attention to see what the lifestyle impacts on semen parameters like alcohol and smoking. Like alcohol apparently targets sperm morphology and count. Smoking releases certain toxins that can hamper sperm motility. There are certain references that are given below the slide. So my aim of study is to evaluate the impact of smoking and alcohol consumption on sperm quality in male partner of couples presenting with infertility. The study was a cross-sectional observational study. This was done at Origin Fertility and IVF Center. Material and methods. In this, the male partner of the infertile couples with primary or secondary infertility visiting at our center were evaluated. And this study was, the male partner were asked to fill a per detailed questionnaire after taking informed consent. The questionnaire that includes was occupation, any past alignments, alcohol, tobacco consumption, smoking, and etc. For this study, 200 men were recruited. And the exclusion criteria for the study was the male patients with past history of smoking and alcohol intake, tobacco, betel nuts, azoospermia, any type of previous history, which includes mumps, testicular trauma, surgery, hydrocele, vasectomy, repair, and any other chronic medical diseases like hypertension and diabetes that can also hamper semen parameters. In this study, the sample was collected in a sterile container by masturbation after a strict abstinence of 3 to 5 days, and the semen analysis was done after complete liquefaction in our lab, following WHO 2010 guidelines. And 200 men were divided into 4 groups. So these groups were like Group A, non-alcoholic and non-smokers, in which 90 patients were there. In Group B, alcoholic, 63 patients. In Group C, smokers, that were 27 patients. In Group D, both alcohol and smoking, 20 patients were there. This group was further subdivided into on the basis of frequency of alcohol and smoking intake, as occasional was one those who were taking alcohol or smoking once or twice in a week and regular on daily basis. Group B, like alcohol, was divided in B1, B2, Group C, C1, C2, and Group D, D1, D2. Coming to result part, in this graph, we are seeing that in normal zoospermia, that normal semen parameters were more significant in non-alcoholic and non-smokers. Coming to alcoholic patients, only 13% men were having normal sperm parameters. In smokers, only 5%, and in both 5%, only normal semen parameter was seen. This is the table that considered that alcohol intake and its correlation with various semen parameters were. We have taken only 3 astheno, oligo, and teratozoospermia semen variables. And in this alcohol group, we found that oligozoospermia p-value was more significant, followed by teratozoospermia p-value was more significant in this alcohol group among semen variables. This was the comparison between occasional alcohol intaker and regular intaker. In this, we found that 35.7% was oligozoospermic patient, and teratozoospermic patient was 32.1 patient who was consuming regular alcohol. This was a table which shows that smoking intake and its correlation with various semen parameters, in which asthenozoospermia was p-value was more significant in comparison to other semen variables. Now, coming to on the basis of occasional and regular, we found that again, those who were consuming smoking on regular basis, 66.6% asthenozoospermia was seen in the smoking patients. This was Group D, in which both alcohol and smoking intake patients were included, but we cannot see any dominant values on the semen variables. This is the total outcome, in which we can found that 22% of oligozoospermia was seen in Group B, alcohol group, and 22% of patient was seen as a teratozoospermia in Group B, and 54.5% asthenozoospermia was seen in Group C of smoking patients. Coming to conclusion, we found that both alcohol and smoking had bad influence on semen parameters. So as an alcohol Group B, we can found that oligozoospermia followed by teratozoospermia. Moreover, it was more significant in male who were taking alcohol on regular basis. Now, coming to smoking, asthenozoospermia again was predominant abnormality, and in both, no abnormality was particularly predominant over others. So this is the discussion part, in which there was a review literature, Vignera LTL, which found that significant seminal fluid volume and sperm concentration decreases has been reported in alcohol dependence patients, and the alteration in secretion of LH, FSH, and testosterone by causing secretory dysfunction of Leydig and Sertoli cells, which may explain the observed reduction of the seminal fluid plasma volume, which may lead to oligozoospermia, which I already have found in my study. And it also suggests that alcohol has an inhibitory effect on the central component of hypothalamus pituitary axis. So coming to the smoking part, if we talk about smoking impact, then exposure of spermatozoa to the toxins in cigarette smoke probably tilts the delicate balance of reactive oxygen species for the special functions, and therefore increased quantity of ROS results in oxidative stress that has detrimental effect on sperm DNA. Moreover, toxins in cigarette also interact with seminal fluid that causes the reduced seminal volume and henceforth manifest as asthenozoospermia. There are certain references like Albury et al. Found that significant p-value can be seen in heavy smokers and drinkers, and view of low sperm concentration and low progressive motility. Also, they found that cigarette smoking had a detrimental impact on SDF value, that is sperm DNA fragmentations. And Bias et al. 2020, this was a cross-sectional study which also found that alcohol consumption correlates sperm apoptosis and spermatogenesis defects. And there are certain other references also which also found that alcohol adverse effects on semen quality, although most pronounced association was seen in men who consumed regularly. And also Tang et al., this was 2019 cohort study of healthy fertile men, in which they found that cigarette contains many compounds that are known as chemical carcinogens and mutagens in humans. So, however, there are certain studies that says that there are lack of evidence that can just be ruled out. So, like A.C. Martin et al. Found that paucity of evidence seen in regarding possible association between alcohol intake and semen quality. Also, this Jensen et al. Found that there is no effect of cigarette and smoking and alcohol consumption impact on semen parameters. These are two meta-analyses, like Bentham et al. In this 16 studies were included. In this, oligozoospermia p-value was more significant. This is another meta-analysis, RLN, which shows that 15 cross-sectional studies were included, and main result shows that alcohol intake has a detrimental effect on semen volume. Coming to the limitations of my study was that lack of a control group of fertile men, so the study should be on the larger aspect. And moreover, we were unable to evaluate a history of passive smoking and dietary habits, which may influence the oxidative state of the spermatozoa. Second, although data on alcohol consumption were obtained from the questionnaire, exposure misclassifications can be seen. And the strength of the study was that it was a cross-sectional study and not being just retrospective analysis of records. Wherever there was doubt in the full questionnaire, it was clarified with the interview of the male partner immediately. Now, coming to the conclusion part, various studies prove that smoking and alcohol consumption will together affect the sperm parameter in many ways. So our study is also consistent with the above findings. In our study, we were able to find out that alcohol was associated with oligozoospermia followed by teratozoospermia. Moreover, these parameters were more prone in regular consuming patients in comparison of occasional intakers. So as in infertility due to male factor is also equally important while considering the causes for infertility. And since smoking and alcohol habits affect the sperm motility parameters and these are modifiable risk factors. So I think measures can be taken strictly to warn the individuals against the consumption of both so as to reduce the occurrence of infertility due to male factors. Thank you.
Yeah, hello Poonam. That was a nice presentation.
Thank you, sir.
Though I would like to ask you that why didn't you study the effect of smoking and alcohol on volume and DFI? Why was these two indices not studied?
Yes,
which is very easy to measure.
Yes, sir, but in a questionnaire, the thing was that the patient has only mentioned that they were taking occasionally, like in parties or something. They has not mentioned the volume because we were not able to.
Effect on volume of semen.
Okay, volume of semen. Yes, sir. That's I have not. That means
That's
the
a very
overall
inexpensive, index. DFI still costs you a lot of money, but
yes.
And did you counsel the patients on stopping alcohol and smoking? And
Yes, sure. Yes, sir.
Did you find any reversal? And after how much time?
No, sir. Actually, this was the study which were based on basically the couples who have already undergone the infertility treatment or they have taken certain medications or something like that. So we were not able to just see what is the reversal outcome because I have already excluded the ex-smokers and ex-drinkers in this my study.
Okay.
Yeah.
Akash?
Thank you, Dr. Poonam. Nice presentation.
Thank you, sir.
Do you have any, did you consider the dose-related effect, anything, like with respect to packiest of smoking, like you have classified in?
Yes. In smokers, sir, I consider the occasional one, those who were taking 1 or 2 cigarettes a day because the smoking is like a thing which cannot be taken occasionally on party or something like that. This should be an occasional and regular basis were considered who were taking 5 to 10 cigarettes per day. So this was divided as occasional and regular patients.
Did you find any dose-related effect, like more packiest?
Yes. Those who were taking more smoking,
than,
like.
Sorry, just like
yes.
You are divided into just occasional and regular ones, right?
Yeah.
So the regular ones, did you find any effect, like those who are taking more and for whom the duration of smoking was more, so they were affected to a larger extent in terms of the parameters of asthenospermia?
Yes, they were more comparison to other semen parameters. The sthano single parameter sthano was more predominant in comparison. If we see the sthano variables, sthano with other parameters like sthano oligo, so the significantly we were able to see that only sthano was more significantly seen in these smokers who were consuming smoking on the regular basis.
Okay. Dr. Nalini, anything?
Yeah. It was very nice presentation, Dr. Poonam.
Thank you, ma'am.
Yeah. Have you asked about the stress and other lifestyle factors to these patients?
We have asked, ma'am, we have seen the forms, but it was like our main focus was on these two things, that alcohol and smoking, because there were other 2 factors also like stress, BMI, age, which we have not included in this.
Mm-hmm.
So that's like, this was the study main.
Okay. Yeah, that's it.
Okay. Thank you, ma'am.
I would like to thank all the judges for their valuable comments. Thank you, Dr. Sarpreet, Dr. Nalini, and Dr. Akash Agarwal. And it's my request to all the judges to kindly email the score sheets by evening today.
Right.
Okay, we'll do.
Thank
Thank you all the organizers for giving us the chance to judge the wonderful presentations. Thank you.
Thank you, Ritika and Dr. Deepika.
Thank you so much.
Thank you.
Dr. Monica, please unmute yourself. Dr. Monica, please unmute.
Dr. Monica, please unmute.
You're on mute.
Dr. Monica.
He is not muted. I think there's some network issue.
I think Dr. Monica actually wanted to request everybody to send the marks as soon as possible because we have to compile them and announce today evening itself. So it's a gentle request
We'll be doing that.
to all our judges. Thank you so much for your time and patient hearing.
So, hi everyone. I welcome you all to this C7 session sponsored by Cooper Surgical of Fertivision 2020. So, without me wasting much time, I would like to call upon the chairpersons. Can you see my slide?
Ma'am, please try again.
Okay. Now?
Oh, we cannot see it.
Now?
Yes.
Now we can, yes.
Yeah, so the chairpersons for this session are going to be Dr. Swaminathan, Scientific Director at Santhi CRM, Karnataka, Dr. Priya Kanan, Director, Clinical Embryology, past President ACE India, and she's at Garba Raksha Begai, and Dr. Bindu Chimote, Vasundhara Fertility Center, Nagpur. So thank you, chairpersons, for being with us today. And now over to Dr. Swaminathan.
Thank you very much. Good evening, everybody. For today's first speaker, I would like to introduce Dr. Stephen Fleming, who is a well-known figure in Indian context. He is the Director of Embryology for Cooper Surgicals and Fertility and Genomics. He is going to deliver a lecture on KPN vitrification. Over to Dr. Stephen Fleming. Thank you.
Thank you very much for that kind introduction. I'd like to firstly thank the organisers of Fertivision 2020 for inviting me to talk to you today. It's indeed a great honour to be able to participate in this virtual conference. I shall be talking to you about key performance indicators in vitrification. Firstly, I'll review the basic principles of vitrification. Then we'll briefly consider the expectations and learning curve involved. I'll go through the scientific and clinical key performance indicators. And finally, I'll summarize what we've discussed. So let's begin with the general principles of vitrification. There are two main methods of cryopreservation of human oocytes and embryos that have been used in IVF labs for the past few decades: slow freezing and vitrification. Both techniques are based on the principle of dehydration. Slow freezing involves a controlled, slow decrease in temperature, with a slow increase in osmolality around the cells and requires the use of a great controlled freezer, whereas vitrification allows the solidification of cells into a glass-like state. Compared to slow freezing, vitrification requires much higher concentrations of cryoprotectants and a very high cooling rate, which can be achieved by immediate plunging of cells into liquid nitrogen. Although these two methods differ, they allow us to achieve high rates of cell survival and viability. The cytoplasm of mammalian cells freezes at around -10 degrees Celsius due to the salts within the cells depressing the freezing point, whereas water crystallization begins at around -2 degrees C. Consequently, intra and extracellular ice formation presents the greatest threat to cell viability, since cell membranes can be punctured by ice crystals. Cells should be frozen in such a way that little or none of their intracellular water freezes, and should be warmed in such a way that any unfrozen intracellular water remains unfrozen during warming. Cell viability may be further compromised by excessive dehydration should the rate of cooling be too slow. Mature oocytes are particularly vulnerable, since damage to microtubules, the myotic spindle, and cytoplasm can occur. So let's concentrate on vitrification. As already explained, the process of vitrification allows us to cryopreserve oocytes and embryos by bringing them into a glass-like state, thereby avoiding any ice crystal formation that would be detrimental to cell viability. In order to achieve high success rates, the efficiency of the vitrification program must be maintained. Indeed, according to many publications, vitrification is more effective than standard slow freezing for most stages of embryo development, resulting in a doubling of pregnancy rates. Because of the high efficiency of vitrification, various commercial kits and vitrification devices are now available to IVF labs. Cryoprotectants appear in different variations for different purposes. For example, glycerol is mostly used in sperm freezing, whereas propane diol in combination with dimethyl sulfoxide or ethylene glycol are the main components of vitrification kits. All of them do the same job. They drive the dehydration and rehydration processes in the cells. Despite differences in pH buffers, supplements, and slight differences in terms of the protocols, all vitrification kits have happy users and can be optimized for individual laboratory settings. There's still no clear evidence in favor of one or other of the cryoprotectants. However, all cryoprotectants can be toxic if used incorrectly. David Edgar and Deborah Gook critically appraised slow freezing and vitrification of oocytes, cleavage stage embryos, and blastocysts, concluding that although the two techniques may be equally successful for cryopreservation of cleavage stage embryos, vitrification appears to produce better and more consistent results with oocytes and blastocysts. Generally, vitrification is considered the superior technique, though it can be more time-consuming when cryopreserving numerous samples. So let's now consider expectations and the learning curve in vitrification. When implementing a new technique, we usually expect excellent outcomes. However, to get consistently good results, we have to be precise and follow very clear and well-established rules. Firstly, use only good quality embryos. Then, a standard operating procedure, or SOP, for vitrification should be implemented in the clinic to ensure that all the small details are taken into consideration. All operators, regardless of experience, should follow the SOP and a learning curve implemented. To achieve competence and even exceed the benchmark level in vitrification, it's necessary to be consistent in all steps of the procedure and carefully manage the main parameters that can affect your results. Usually, protocols are designed for room temperature or 37 degrees C. However, temperature will affect the speed of the process. The normal distribution of equilibration time will be faster, say at 28 to 30 degrees C in warm labs than at 20 to 22 degrees C. Volumes are really important. Here's our internal data showing the weight loss observed during the equilibration step using different volumes of solution. The blue lines represent a 15-minute equilibration of a blastocyst. As you can see, drop size will affect the evaporation and consequently consistency of the environment surrounding the cells. Ideally, each cryopreservation case should be treated the same way in terms of time, volume, temperature, media, and quality, etc. This way, variation between cases and operators can be minimized and consistency in outcome increased. Clearly, use of larger volumes will make it less likely for environmental changes to affect outcomes. When dealing with small volumes, you increase the risk of evaporation and increased osmolality of the solution. Therefore, it's better to start with large volumes during the learning phase until satisfactory results have been obtained. When we implement a new technique in the lab or train a new person, we need in-house quality control procedures to assess the learning curve of trainees, as well as to monitor and optimize the introduction of the new technique. There are various methods that can be used to determine whether a trainee has reached proficiency. For example, standard practice is simply performing a recommended number of procedures under supervision. Alternatively, a statistical tool, such as this one here, LC-CUSUM, designed to indicate when a process has reached a predefined level of performance, can be used. According to Dissol and colleagues, using LCUSUM, vitrification procedures appear to be easy to learn, even though the trainee was a beginner. The learning process was mostly limited by manipulation challenges. Thus, the learning curve for vitrification in a skilled embryologist is likely to be shorter, and the introduction of this technology in laboratories should be easy. Nevertheless, continuous monitoring after proficiency is required to prevent performance drift, and KPIs will help you to monitor ongoing performance. Let's now consider the scientific and clinical key performance indicators of vitrification. At the Alpha Biennial meeting held in Budapest in 2010, an interactive questionnaire including 16 suggested KPIs for cryopreservation was presented to delegates, and its results informed an expert panel on minimum expected or competence values, i.e. values that any laboratory should be able to achieve, and aspirational or benchmark values, i.e. values that can be employed as a best practice goal, and this was for a range of quality indicators. A consensus was reached with 14 KPIs being recommended for oocyte and embryo cryopreservation via slow freezing or vitrification. According to the Alpha consensus, predictive values for oocyte survival, fertilization, embryo development, and implantation rates favor the vitrification technique over the slow freezing method. Notably, the embryo development rate following oocyte vitrification should be the same as for a comparable population of fresh oocytes in the clinic. These KPIs may be affected by caseload, ovarian stimulation, and practitioner experience. For example, after analyzing 40,000 vitrified oocytes in an oocyte donation program in 2015, Cobo and colleagues observed differential survival rates between donors, or even from the same donors but using different stimulation cycles, 1.4% of cases having zero survival. The Alpha consensus also recommended KPIs for zygote and cleavage stage embryo cryopreservation. Again, the expected cryosurvival rates to achieve competence and benchmark levels are much higher for vitrification compared to the slow freezing techniques. Overall, for the cleavage stage, it was the consensus that the benchmark for the rate of further development and implantation should be the same as for a comparable population of fresh embryos at the clinic. As for the blastocyst stage, the Alpha consensus expected higher cryosurvival and embryo transfer rates to achieve competence and benchmarks for vitrification. As with cleavage stage embryos, it was the consensus that the benchmark for the implantation rate should be the same as for a comparable population of fresh embryos at the clinic. Blastocyst cryosurvival was defined as at least 75% of the inner cell mass and trophectoderm cells perceived to be intact after thawing or warming. The proportion of warmed blastocysts that re-expand within 2 hours was recommended as an extra KPI to evaluate the survival rate. The embryo transfer rate was defined as the proportion of blastocysts suitable for transfer following thawing or warming, and the implantation rate was defined as the proportion of fetal hearts per blastocyst transferred. Another survey, the ESHRA survey, provided information on current practice, such as how many KPIs are measured, their frequency of measurement, characteristics of a reference population, and their degree of importance. This survey was sent to 2,413 members of the ESHRA Special Interest Group of Embryology, and 384 responses were received. In addition, where relevant, published data was collected from a literature search and summarized, although for most indicators, especially in ART, personal clinical experience was integrated into presentation by experts on specific topics at an international workshop held in Vienna. For each indicator, information was presented in a fixed format: definition, rationale, qualifiers, formula, data sources, KPI strengths and weaknesses, and the frequency of data collection and reference values for a minimum expected and target value based on 50 and 75 percentile values, respectively. Based upon increased experience in blastocyst vitrification since the Alpha Consensus in 2010, the Vienna Consensus recommended that the competency and benchmark values for blastocyst cryosurvival be raised to 90 and 99% respectively. Re-expansion of the blastocele following warming seems to be an additional marker of both blastocyst cryosurvival and cryoviability. As can be seen in this study, significantly higher rates of blastocyst cryosurvival in the blue bars and faster re-expansion of the blastocele in the red bars was observed in blastocysts with less blastomere loss on warming. Furthermore, significantly higher positive beta-HCG, clinical pregnancy, and implantation rates were observed following the transfer of blastocysts with a fast re-expanding blastocele, defined as 50% or greater re-expansion within 2 to 4 hours post-culture warming, as shown in group 1 in this table. Morphokinetic analysis of the start of blastocele re-expansion, TRE here for the start, and completion of blastocele re-expansion, TCRE, here in the center panel, reveals that these events occur significantly earlier in those vitrified warm blastocysts that actually go on to produce pregnancies. Furthermore, the initiation, TRE, completion, TCRE, and duration, TRE plus TCRE, of blastocele re-expansion allowed distinction between non-pregnant, beta-HCG positive, miscarriage, and ongoing pregnancy or live birth outcomes, the duration of blastocele re-expansion following warming being shorter in blastocysts that resulted in pregnancies following frozen blastocyst transfer. Now, there are no published KPIs in terms of competencies and benchmarks for most clinical outcomes, but what we can do is compare at least vitrified frozen embryo transfer or frozen blastocyst transfer outcomes with fresh outcomes. And this recent Cochrane systematic review of 4 randomized clinical trials of freeze-all versus conventional IVF ICSI cycles in 1,892 women revealed no clear evidence of a difference in cumulative live birth rate, suggesting a negligible effect of ovarian hyperstimulation on endometrial receptivity. As might be expected, the prevalence of ovarian hyperstimulation syndrome was lower in the freeze-all cycles. Interestingly, however, freeze-all was associated with fewer miscarriages, but a higher rate of pregnancy complications, though the evidence for this was of low quality. So it's useful looking at this study, which is actually quite unique in its design, in that it looked at neonatal outcomes of singleton and twin pregnancies following single center cycles of both day 3 and day 5 fresh and frozen embryo transfers, and these were compared over the same time period. Contrary to other studies, in this study, women could only be included in either the fresh or the vitrified group. The vitrified group, therefore, being comprised of women with a less favorable prognosis, since they were returning for a frozen cycle following an unsuccessful fresh cycle. Despite that fact, singletons born following vitrification showed a slightly higher birth weight and had lower small for gestational age rate compared to fresh embryo transfers. And reassuringly, there was no significant difference in preterm birth rate, perinatal death rate, or in major or total rates of congenital malformations between the two groups. So, what conclusions can be drawn from this presentation? In summary, vitrification is a highly efficient technique for all stages of human embryo preimplantation development, from oocytes to blastocysts, though initial training and ongoing competency evaluations using objective KPIs are essential. Oocyte and zygote cryosurvival competency and benchmark KPIs are 70 and 85%, respectively. Cleavage stage embryo cryosurvival competency and benchmark KPIs are 85 and 95%, respectively, those for blastocysts being 90 and 99%. Rapid re-expansion of the blastocele following warming is another KPI for blastocyst viability. And reassuringly, live birth and neonatal outcomes following frozen embryo transfers are at least as good as those following fresh day 3 and day 5 embryo transfers. Here are the reference to the citations within this presentation. Thank you very much for your attention, and I look forward to answering any questions that you may have at the end of this session.
Thank you, Dr. Stephen Fleming. We will have any questions at the end of the session we can discuss. I would like to welcome Dr. Steve David. He is the Director of Clinical Application for Supersexual Fertility and Genomic Solutions. He will be going to enlighten us on the topic of best practices in embryo transfer. Over to Dr. Steve.
So please unmute yourself.
Yes, it helps if you're not muted. Thank you very much for that introduction. And as my colleague said, it's a great pleasure and honor to talk to you at this virtual conference. My role, as mentioned, is in as a clinical application specialist at Cooper Surgical, and my history is just listed here. Today, I'm going to talk to you about best practices in embryo transfer and try to use as far as possible some indicators that have some data and clinical evidence behind them. I'm going to talk about the lab training, some of the clinical practices, and just summarize at the end with those parts of the embryo transfer technique that we actually seem to have good evidence for, some with some moderate evidence, and those where there is really very little evidence to support those particular practices. Embryo transfer is one of those areas that is a vast topic, and we can only scratch the surface in the time that we have. But hopefully today we will get some insights, some thought-provoking data to help people think about their practice and how to potentially move it forward. So we know that over the last few years we've seen an increase in success rates with IVF, and it's been associated with laboratory techniques, improvements in stimulation protocols to provide better quality oocytes to the lab. But the outcome failures of IVF are generally attributed either to problems with poor embryo quality or uterine receptivity. But we have to bear in mind, though, that most failures in today's embryology setting occur after the transfer of apparently normal embryos, And these have certainly been attributed potentially to the embryo transfer technique itself. So in today's setting around the world, probably about 80% of women undergoing treatment actually get to embryo transfer. But unfortunately, still only a relatively small proportion of these patients will achieve a clinical pregnancy and go on to give a live birth. And this generally indicates that the embryo transfer phase is one of the areas that's actually one of the least successful steps in the whole processes that we employ within our clinics. And this failure that we see may be due to a lack of good quality embryos, although this is generally improving and the culture systems are improving. It could be lack of uterine receptivity, and there is a move now worldwide to do endometrial receptivity testing, etc. But the actual embryo transfer itself and the techniques involved may contribute significantly to that as well. So I'm first going to consider the lab and its role in the embryo transfer and the overall outcome of the cycles within our clinic. And as my colleagues will know, this is a favorite slide of mine that I used, put together by Don Rieger, to try to give an indication of how complicated and how involved the laboratory is in the effective outcome of IVF treatment. And he identified 175 factors that may be contributing to successful outcomes within the IVF laboratory. And I've highlighted two here. I'll talk a little bit about air quality and then, of course, the main subject of the talk on embryo transfer. But you can see in between every step of the way, there are many things that are important to control within the lab to ensure we get good quality embryos for transfer. And the Cairo Consensus in 2018 came up with a very nice statement that said there's only one thing that's important in embryology, and that's everything. So we must take care to look at all our procedures to make sure they're optimized to give us the best chance of producing good quality embryos that then will have a good implantation potential. And if the embryo transfer technique is good, then a good chance the patients will have a successful cycle. So the reason I highlight air quality is that it's something that's generally overlooked within the laboratory, and particularly in the present climate that we find ourselves in. The quality of the working environment is very important. And this is an example of the effect that volatile organic compounds can have on our clinical pregnancy rate in this study, which was significantly improved when air filtration was introduced into the lab. And then in the second study done in Boston, again at the end of the 90s, you can see here that when a standalone filtration system and a standalone filtration system plus an incubator-based filtration system were introduced, the pregnancy and ongoing pregnancy rates were unaffected in terms of significance, but the miscarriage or abortion rate was significantly impacted by the improvement in air quality within the laboratory. And I mention this particularly because, again, in our present climate, there is a move to increase cleaning regimes within the lab. And if we don't carefully select what we use, we run the risk of introducing higher levels of volatile organic compounds into our lab, which can lead to either poorer outcomes in terms of implantation or ultimately poorer outcomes in terms of miscarriage rate for our patients. So what's important in the lab itself and what information do we have? So what transfer media should we be using? The paper here suggests that a transfer media with higher levels of hyaluronic acid might be beneficial. And this, there may be possible benefits of increased viscosity, but also there was no evidence that higher protein concentrations, which is a common practice within embryology, doesn't seem to improve outcome. So the choice of transfer media is important, and certain aspects of it may help us improve the outcome of the embryo transfer procedure. Again, something that's quite controversial, and there seems to be no consensus around the world about what is the optimal transfer volume to use, and there are relatively few studies to help us identify what is the optimal volume. But there are surveys done that show there's a very significant variability between labs around the world. Very low volumes, less than 10 microliters, may actually be detrimental, and large volumes, very large volumes, may lead to expulsion of the embryos in a suboptimal way, potentially ectopic pregnancy or retention of embryos within the catheter when you're taking the embryos up into the catheter itself. So 20 to 30 microliters is more commonly used. And there is a study that shows we get better outcome using slightly larger volumes in this setting where the implantation and the pregnancy rates were better. So controlling the transfer volume is also potentially a critical factor in successful outcome. Again, there's no consensus in embryology about how to best load an embryo transfer catheter. And there's some examples here about regarding some of the methodologies that people might use: a full column of media, a small air gap between the media containing the embryo and a full body, 2 air gaps, which is the most common practice that I've used, and then just an embryo drop on its own with air in the catheter afterwards. And are any of these potentially better than others? Well, there is a study that suggests that air in the catheter is not detrimental, and often it's introduced to protect the embryos during the transport of the catheter between the laboratory and the theatre to do the transfer procedure itself. So this paper showed that between the two groups, there was no difference in implantation rate or clinical pregnancy rate. There was a trend towards higher rates when there was air gaps either side, but not significant. These were day 2, day 3 transfers, and the catheter was flushed before the embryos were loaded. So in preparation for the embryo transfer, there's no difference if the catheter is loaded from microdrops under oil. And this again is something that often embryologists don't want to do. They worry about collecting embryos in this way. And of course, oil is there for a reason. It protects the environment. And just before embryo transfer, we don't want to see huge changes in either pH, temperature, or osmolality. And so using oil may actually be beneficial, but it is recommended, of course, that you clean the tip and rinse the oil away before the embryo transfer. Pre-warming of the catheter is not recommended, and again, a lot of labs do this because the tip is at ambient temperature and will potentially release VOCs. Most, of course, all embryo transfer catheters are made of various types of plastic, and we know that they release VOCs. So again, there's a paper here that recommends we don't pre-warm the catheter. Flushing it through with media is often the practice, but again, there's no clear evidence that this is beneficial. Although, as you can see, the vast majority of responders to a worldwide survey had this as their standard technique. So I'm going to talk about training, and you saw these particular types of assessment of competence and training in the previous presentation. And these are learning curve cumulative summation charts. And what they show is that you can plot in a very scientific way when people have reached confidence. And on the left-hand side of the charts, when the line crosses the bottom solid line, the person has reached competence, and then afterwards, between the two upper lines, this shows that they maintain their competence over time. And you can see for these 5 people, the competence level was achieved relatively quickly, and then over time they maintained their competence, other than this particular individual who over time started to lose their competence, and then it became back within the normal range. And the conclusion from this study that actually embryo transfer, potentially counterintuitively, is relatively easy to learn, and in most cases need less than 20 procedures to achieve competence. So, of course, we need to do embryo transfers in an atraumatic way, so they need to use the right materials and the right catheter, etc., in preparation of the patient. But actually, as a technique, relatively straightforward to learn. But of course, as Steve pointed out in the previous presentation, monitoring performance either by KPIs or other methodologies is important, because this particular paper also showed that if you don't continue to keep up your practice, then it's very easy to lose competence over time. So again, once you've reached competence, it's very important that you continue to practice to maintain that level of competence and of course improve over time. So of course, as you might expect, the lab, the training, very important. And then clinical practices. What do we know is truly important in terms of the evidence that supports some of the clinical practices in embryo transfer? And in this area, there are many myths that have been developed over time, and practice is very variable from clinic to clinic, region to region around the world. So we've determined that embryo transfer is vitally important for the outcome of the IVF cycle, and therefore a careful and atraumatic embryo transfer using the correct tools in a skilled and experienced hand can maximize the chances of pregnancy. And I think we would all recognize that. So there is some evidence that doing an early mock or a trial transfer prior to stimulation is important, because what we're aiming for in all instances is an easy embryo transfer. And so doing a mock or trial transfer may help us identify where a difficult procedure might be predicted. And that then will give us the chance to address any potential problems with the structure of the cervix, whether there's other difficult anatomy, whether there's retroverted or flexed uterus, and potentially the need for administration of antibiotics. And of course, it's also recommended that in these trial transfers, we use ultrasound to help us determine the anatomy and the ease that the embryo transfer will take when we actually come to do the procedure with our clinical material. And so to overcome difficult embryo transfer, there's a lot of embryo transfer catheters available to facilitate placement, and which ones are ideal for use. So you can see here the effects of embryo transfer catheter on the endometrium have been analysed, and there's been many papers published to show that soft versus hard embryo transfer catheters, etc., are of benefit. But you can see the overall ease of the type of the catheter used for embryo transfer generally go hand in hand and are strongly correlated with pregnancy outcome. So as we just mentioned, easy embryo transfers are much more likely to result in a pregnancy than those that are difficult. And so we need to take into account some of the factors that may occur, and this may be related to the type or use of a particular embryo transfer. So whether there's blood or mucus on or in the catheter, the ease of the transfer, the uterine contractility, and then transfundal placement. And we'll talk about placement in a minute. And of course, the catheter needs to be soft with an atraumatic tip, has flexibility and memory to allow you to traverse the cervix in as easy a way as possible without causing any trauma during the procedure. And again, the mantra here is that we really need to do what the cervix wants and not impose our will on the cervix by trying to manipulate it to do things that are likely to cause trauma. So in terms of ultrasound guidance, there's been debate over many years about whether ultrasound guided transfer is beneficial. Many clinics now do ultrasound guided, but they do transabdominal in 2 dimensions. And again, some have issues with it, with the quality of the image that they gain. And again, this may be one of the reasons why we don't get optimal results from ultrasound guidance. But I think we can say from all of the studies that have been done now, ultrasound guided transfer is definitely the way forward. It facilitates the entrance of soft catheters into the uterine cavity. It confirms that the catheters move past the internal os. It helps us direct the catheter inside the cavity again to avoid trauma and hitting the fundus and going too close to the fallopian tubes. We know that a full bladder is helpful in giving a clear picture, and we can visualize the exact location for depositing the embryos, although there is no real consensus yet about what is the exact perfect position for embryo placement. And again, we can see from evidence that the use of ultrasounding can improve implantation rates, ongoing pregnancy rates, etc. So generally a very positive outcome and something that should be considered if applicable in the clinic. And here's an example of 2D ultrasound picture. And again, these have their limitations. You can see the air bubbles that are loaded into the catheter are often visible following the transfer. But there is a trend now to use more advanced ultrasound techniques, and this gives you a much greater insight into where your embryos are actually being deposited, and may ultimately lead us to a better understanding of the ideal positioning of embryos within the uterine cavity at the time of embryo transfer. And that's been described as working out this maximum implantation potential. And you can see here using a 4D scanner, which gives us the opportunity, sorry, a 3D scanner gives us an opportunity to focus and localize the deposition of the embryos. And then obviously over time, we can work out what is the optimal position for placing the embryos. So much so that the guidelines that the UK has, particularly from the National Institute of Clinical Excellence, says that women undergoing IVF treatment should be offered ultrasound-guided embryo transfer because it improves pregnancy rates. And of course, regulatory bodies wouldn't advise these sort of things unless there was sufficient evidence to back it up. So just to finish, I just want to cover some of the myths that have developed over time and where we have evidence and where we don't. So grade A, we have evidence that ultrasound guidance is beneficial. Using a soft embryo transfer is certainly beneficial, and no bed rest following the embryo transfer procedure, although not beneficial, certainly is not detrimental. So there's good evidence that we don't need to keep our patients in the clinic for a long period after the transfer. They can easily get up and walk away from the clinic immediately afterwards. Where there's less evidence, but some evidence to support it, there's very little evidence that acupuncture is beneficial. Antibiotics per se are not beneficial unless they're specifically indicated. Removal of cervical mucus was a bit of an obsession a few years ago, but now there's no real evidence that this is beneficial. The placement of the embryo, of course, there's a significant variation around the world where people are placing embryos, and of course, in many cases, they don't have a very precise measure, so there's a variability here and more work needs to be done. And the withdrawal of the catheter, there was again some feeling that you needed to leave the catheter in for some time and withdraw it slowly. Again, there's very little evidence to support this. And retained embryos, again, we need to work out more evidence of, although not ideal, if those embryos are recovered quickly and replaced quickly, then they're not necessarily a detrimental factor. And where there's very little evidence for of these particular procedures, there's no evidence that analgesics are any better, or anesthesia, massage therapy. Blood on the catheter is something to avoid, but actually the evidence around it is not very convincing. And the speed of injection, again, we need more evidence to decide what's optimal here. And again, is very variable between operators and their relative levels of experience. So we have some data to back up some of the techniques that we use. There's little data for other things, and a lot of myths have been built up around embryo transfer between particular operators. And that's why it's very important to measure the success between operators within a clinic to ensure that everybody's at least trying to do a similar technique so that we can get good consistency across the board. So I hope that's given you some food for thought regarding embryo transfer. Thank you for your attention, and I look forward to answering any questions that people may have at the discussion at the end.
Thank you so much, Dr. Steve, for
Thank
this
you.
wonderful lecture on the very practical tips of embryo transfer technique. We now move on to the last lecture of this session, which will be delivered by Dr. David Morrall. Dr. David Morrall has served as the chair of the UK Association of Clinical Embryologists and was also involved with the HFA expert group on multiple births after IVF. Presently, Dr. Morrall is the clinical head, director of clinical support, focusing on post-marketing clinical studies, laboratory design and turnkey projects, as well as QA complaints and laboratory audits. Over to you, Dr. David.
Thank you, Dr. Bindu, and thank you. This is a real pleasure to join you today to talk to you about risk management that can be quite a dry subject, but hopefully I'll present some guidance and some evidence as to why it needs to be given due attention. We should all be aware that there are risks associated with all stages of the ART processes that we're involved in. Some of these risks are very obvious and some less so. But it's essential that we ensure that we're both aware of these risks and then take steps to eliminate, minimize, or manage them. And we can draw on local, national, and international requirements and guidelines. But the whole process of risk management must be underpinned by good risk assessments. We should set out with the understanding that managing risk may well have financial implications, as the risk assessments could identify the need for greater resources, be that people, equipment, or consumables. We also need to appreciate that staff health and welfare must be factored in. As I said, risk management impacts all areas of ART, as I highlighted here, and Steve Levitt showed the 175 factors that might constitute some of these risks. And we'll look at each of these factors in turn. We can start with the facilities themselves and see whether they are suited to the work being planned or performed. The facility should be as modern as possible and support, this is the key, safe and effective laboratory practices. And ideally what we want to do is keep them as up to date as possible so that we're always addressing risk in the most up-to-date way. And an example would be the control of air quality, which Steve in the last presentation has covered as well in a little bit of detail. So risks are associated with lower levels of cleanliness in IVF labs, and HEPA filtration, whether in the HVAC system or as standalone units, is very desirable. But HEPA alone won't remove the VOCs that Steve discussed. And these are potentially a greater risk to patient success. So we should put in place a raft of additional measures to eliminate VOCs, such as filters using activated carbon, potassium permanganate, or UV light. Risks should also be managed by using standard operating procedures. So these ensure that people perform tasks in a standardized way, and we can test that by auditing adherence to SOPs. And that audit of adherence and assurance that standardized protocols are used makes the audit of laboratory performance, or indeed individual performance, more robust. And significantly, it also helps troubleshooting. It's also important to remember that the SOP should be validated, which means that they themselves are shown to be fit for purpose, and that's backed up with evidence to demonstrate that your choice of procedure and the way you do a specific task is backed up by evidence of efficacy. Staff competence is clearly a vital part of risk management. And first and foremost, we have to ensure that people are trained adequately to perform any given procedure and that this training is recorded. Staff must only perform tasks in which they've demonstrated competence and not work beyond their scope of practice. So conversely, supervisors or managers should not ask staff to help out with tasks if the individual is not already signed off as trained. This all feeds into developing a system, and this is a quality and a risk issue, that you develop a team with the appropriate number of staff with the correct skill mix. And ideally, people who are not yet signed off as trained and therefore competent as supernumerary. In other words, they don't contribute to your overall staff numbers when you're thinking of capacity planning. And I know that's not necessarily commonly practiced, and it's sometimes difficult to do, but that would be the ideal that we aim for. Also worth remembering that, of course, that competency should be revalidated and individuals should go through continuing professional development. And you've seen this already. Demonstrating competence is a whole subject in itself, and it traditionally relies on keeping a logbook of activities, doing split cases, checking KPIs as an individual, and comparing them with more experienced personnel. But as already highlighted by my colleagues in the earlier presentations, the use of LC, QSUM and QSUM, these learning curve cumulative summation charts, use a mathematical model to determine when an individual has achieved competence. And that may be more meaningful and more robust, rather than just working on an arbitrary number of tasks. Of course, an obvious and very well publicized risk in an ART laboratory is that of chain of custody. Ensuring patients' gametes and embryos are traced throughout the ART process to negate the risk of a mix-up. So we need a system for determining whose gametes and embryos are being worked on. We need systems if samples are produced off-site and so on. But although that's the obvious part of chain of custody, we should also think of traceability in terms of the consumables, what medium are we using, what transfer catheter is used in a cycle, and also which operator is involved. So who does what and when. And of course, all of that can be done manually. You can keep your manual records for traceability and manual witnessing, but the ART management systems that are built around electronic witnessing are largely more efficient and certainly more effective and reliable as witnessing systems that are considerably more effective than a manual system. Another risk, and particularly pertinent at the moment during the COVID pandemic, is infection control. And we've already mentioned air quality, but we also need to consider how we clean and what personal protective equipment we should use. So we've talked about the air quality and having good background air and perhaps positive pressure and working in workstations. But we need to think about our cleaning agents and so on. And as I've mentioned, it's best to have well-controlled background air, but protection also increases between the benchtop through class 1, class 2, through to fully contained systems where we're doing the critical steps in ART. And as shown here on the bottom right of this slide, we can also think about not only our cleaning agents, but where we pay attention to cleaning. And it's a good idea, for example, to use settle plates or something similar to identify hotspots where more attention for cleaning is appropriate. So, for example, pass-throughs and doors into procedure rooms are often a hotspot around our micromanipulators because they frequently aren't in workstations. And we should also adopt a policy of routinely using closed cups when we're doing centrifugation. We can also think about infection control when we're looking at shared workspaces. So for example, here we show two embryologists typically doing a manual witnessing check at a workstation. And you can see here that additional PPE and electronic witnessing would avoid some of the risks here. And again, particularly pertinent given current conditions with the coronavirus. So we need to think in terms of infection control and in terms of the staff welfare that we touched on, what additional PPE and what amendments we can make to processes in order to reduce the risk. So you might just about stop short of the full suits shown here that we use in our manufacturing sites, but we might reasonably consider additional steps above what we've seen previously, as shown on the left here. Moving on to equipment, the first concern with equipment is, of course, having enough, especially incubators, and then keeping them in good working order. But they must also go through the appropriate validation at selection, installation, and first operation, as well as then checking performance in real-world conditions before putting them into service. And then, of course, regular monitoring on a day-to-day basis. So in-house checks can typically include gas mix, pH and temperature, whilst all critical equipment should really be alarmed as a minimum and ideally continuously monitored. Similarly, all consumables should be fit for purpose, and hence ART-specific consumables are generally advised, or alternatively, additional testing using the mouse embryo assay, sperm survival tests, endotoxicity testing, and so on, should be performed in-house. And that applies to all of our consumables. Again, traceability allowing surveillance of performance of products and specific batches should be undertaken. Now, much of the initial testing in the consumables we typically use in an IVF lab will be done by the manufacturer, as shown here, where we have the quality assurance certification from the notified body and the thing that we see in the laboratory, which is the certificate of analysis. But it's still necessary to have some traceability in-house. Steve Fleming has dealt with some areas of KPIs with cryostorage, but suffice to say there are continuing debates regarding the relative merits of vapor versus liquid storage, open versus closed devices, and possible use of sterilized liquid nitrogen and so on. So all of those need to be considered when risk assessments are performed when deciding how to implement your cryostorage system to manage or minimize the risks. In my mind, however, there are no real debates when it comes to the need for alarms for the critical equipment and, of course, appropriate safety measures for the staff. And that might include low oxygen alarms, appropriate personal protective equipment, and careful risk management of transport of liquid nitrogen, particularly in large volumes, unless piped directly into the cryostorage area. Again, Steve talked about KPIs for vitrification. And of course, these are essential for all monitoring of lab performance, as well as evaluating the impact of changes and assessing adverse events. So they can be retrospective to look at performance, but they can be prospective in planning control changes to lab procedures and then assessing the impact. All backed up, of course, with managing risk. And we generally recommend using control charts for your well-chosen KPIs as part of ongoing assessment of lab performance. Part of your monitoring, of course, is the risk assessments that we began with, and this is a typical risk assessment chart. And we can add in additional tools, such as root cause analysis, as demonstrated here with the classic fishbone diagram, which is more typically used for investigating adverse incidents, but can be used prospectively to assess and investigate risks when implementing procedures. And bear in mind, it's an essential element of ISO certification, as an example, that learnings from adverse events and near misses are demonstrated and recorded. So this also feeds into amended risk assessments and the overall management of your risks. This is all emphasized in, for example, the ESHRA guidelines of good practice, where it's stated that non-conformities need to be recorded, they need to be resolved, and preventive and corrective actions documented and implemented in full. And again, all of these should be discussed regularly, typically annually, and reviewed regularly to look for themes or trends in the adverse events or errors that are seen in the laboratory, so that it can be addressed more fully. So that's a whistle-stop tour of risk management. Let's now just summarize. So it's important, again, to emphasize that risk management applies to all areas, all procedures, and all functions. So we tend to focus in on the laboratory, but it will disseminate out around the whole IVF unit. It's fair to say that some functions are perceived as being involved with the highest risk, and typically the chain of custody and witnessing is one, because the consequences of errors there are so profound and far-reaching and significant, particularly to the patients. But also cryostorage. You only have to look through the literature, but also in popular media to look at the number of reports of errors involving cryostorage, and particularly tank failures that can impact many, many patients. I hope I've reinforced the message that the whole part of risk management has to be underpinned by carefully performed and meticulous risk assessment. And the risk assessments, together with details of incidents and near misses, and the corrective and preventive actions, should all be fully documented. So the risk management system is all fully documented and understood. And finally, as just mentioned a little while ago, that there is a clear system for review of non-compliances and incidents, as this is a core element of quality management. So I'd like to thank you for your attention, and I look forward to the question and answers.
Thank you, Dr. David Morrell, for the wonderful talk on the risk management. Let me check the question session. Yeah, there are a few questions. First one to Dr. Steve from Dr. Priya Kannan. While withdrawal of ET catheter does not show any benefit, does it have any detrimental effects?
It's a good question, and I think there is some evidence that withdrawing the catheter too quickly can be detrimental. And ideally, what's recommended is that as the catheter is removed, you turn it through 90 degrees and then withdraw the catheter. So again, it's very hard to put figures on it, but of course in a controlled manner. It's the same with injecting the the embryos in the first place. There's no standards that we can use, but of course we don't want to push too vigorously to cause the embryos to be expelled from the catheter too quickly. May cause damage or may go to parts of the uterine cavity that we don't want them to go. And certainly withdrawal, we don't want to withdraw the catheter too quickly, but there is no evidence that leaving it in situ for any length of time is any beneficial. So just generally rotate the catheter to ensure that the embryos are not going to follow the catheter out of the cavity once you move it. And those seem to be the sort of key factors to success, really.
Thank you. Another question to Steve only. Do you think blood in the outer and inner catheter are equally detrimental to pregnancy outcome, if at all?
Again, another good question. And if the catheter is used correctly, then the only part that should enter the uterine cavity is the inner catheter. That's what it was designed for all those years ago. And the outer sheath, particularly those that are non-bulb tip catheters, are very sharp on the end. And so these, if they're used on their own, can cause trauma. And one of the most common mistakes that I notice when I'm looking at embryo transfer is that people use the outer sheath when it doesn't have a bulb tip to get into the cervix and potentially through the internal os. And this is what will cause damage. So it depends on the type of catheter that you have and how you use it. But ideally, the only thing going into the uterine cavity is the inner catheter, because that's what it was designed for. That's what's soft and has an atraumatic design to enable, positive outcomes.
Thank you. And one more question to you from Dr. Bindu Chimote. What is the optimal time for embryo transfer procedure? If anything is there, like any optimal time?
Of course, it really depends on when you, I don't know whether you mean in terms of timing, so when you do it or how long it should take. In terms of timing, of course, it depends on embryo development. So we're looking at the appropriate time for embryo development to indicate when the time of transfer. One of the interesting studies that was done early on when ultrasound was still a little bit of a debate was done by Professor Correlu in Barcelona, and he timed how long it took from the laboratory to get the embryos deposited in the uterine cavity using a clinical touch technique versus a technique using ultrasound. And he found that using the ultrasound, of course, diminished the time it took from the laboratory to getting the embryos in place. And that, for him, had a positive outcome for his patients. The problem with his study was because he didn't do it as a blind study, he started to see that there was some benefit, and then he stopped the study because he felt it was unethical to not use ultrasound on his other patients. So the rule of thumb, of course, is as controlled and without rushing, then you need to get the embryos inside the uterine cavity as quickly as possible. So most people have switched to doing what we call a two-stage technique, where they get something in place first, and then only when they know that they're going to be able to get into the cavity easily will they bring the embryos. In the very early days, we just used to load a catheter and bring it through into the theatre and try to do the transfer, and sometimes it could take several minutes just to get into the correct position. So again, technique is important as well as timing.
Yeah, thank you. And the next question is to Dr. David Morrell. Is there a recommendation on the duration of consumables kept for off-gassing?
Oh, yeah, good question. I'm not sure there are any reliable recommendations, and I think it may well depend on the sort of consumables that you're talking about. And I'd be interested in my colleagues' views on this. I think the general approach is to off-gas plastics, for instance, maybe for 24 to 48 hours, not typically longer, but certainly overnight before using a dish for dish preparation, for example. It will vary because some dishes have complete plastic wrapping, whilst others have plastic on one side and paper on the other. And my understanding is that the paper allows some degree of natural off-gassing even before opening, whereas the fully plastic can keep VOCs contained. I don't know whether Steve has any additional comments.
You've covered it well. Obviously, there's two factors to take into account. One is obviously the off-gassing, and the second is maintaining sterility. So the longer you off-gas them, the better, because as soon as you put plasticware into a higher temperature, there's a potential that it will off-gas more. And this was one of the reasons in those early studies why they found the highest levels of VOCs in the whole IVF clinic were actually inside the incubator, mostly from the gases, but also from plasticware as well. And from the incubator itself. Often a mistake people make is they install a new incubator and they don't leave the incubator long enough to off-gas as well. So yeah, no hard and fast rules. It depends on the type of dish you use, but being cautious and leaving it longer to off-gas is often beneficial.
Thank you. And
maybe worth adding also that some manufacturers of culture dishes actually enclose the dishes in packaging that allows off-gassing as well. So I think that's maybe helpful. But otherwise, I would agree with what Dave said, that typically in practice, most embryologists are off-gassing typically for 24 hours, maybe 48.
Thank you. Next question to Dr. Stephen Fleming. Any KPI for vitrification of ovarian tissue?
Not really. I mean, vitrification of ovarian tissue hasn't been used anywhere near as much as slow freezing of ovarian tissue. So I think it's a bit premature for any publication of any KPIs. But of course, with all these procedures, there are two aspects to look at. One is cryosurvival of primordial follicles within the ovarian tissue. So normally a sample of the tissue is thawed to check for that. Should be checked. You can't just assume that this tissue has survived for a patient. And the other, of course, is when that tissue is hopefully grafted back into the patient. And in fact, that tends to be pretty successful in terms of restoring endocrine function and fertility. But as I say, there's very little data on vitrification of ovarian tissue.
Thank you. I hand over to Dr. Bindu Chimote. She will continue and close the session.
Just one question to Dr. David Morrell. In the present times, in the COVID era, where we are all supposed to wear protective gear, be it PPE kits or the shields or gloves and all. So there is no restriction or control as yet on the quality of these gears that we are using. What is the risk of transmission, not just of infection, but of VOCs wearing these protective kits in the IVF laboratory?
Yeah, good question. Yeah, I think the use of PPE, again, it will boil down to risk assessments. I think gloves are fairly straightforward, because I think it's quite easy to find nitrile gloves that are relatively safe to use in an IVF lab. The hats and masks, I think, are relatively common, so should be straightforward. I think when you introduce visors, and the main risk will come from reusable equipment like that, which means that inevitably you need to clean it. So the risk is more around your choice of cleaning agent rather than the choice of equipment, I suspect. And I think at least with equipment like that, you can take it out of the critical areas and clean it. And of course, you can be careful about your choice of cleaning agents, avoiding the ones that we know are potentially detrimental, such as the ethanol.
So much. I think there's another question. For Dr. Steve, what do you think is the pregnancy outcome in cases where we notice movement of air bubble down after embryo transfer? That is, when we do an ultrasound guided embryo transfer and post transfer, we see that the bubble has moved, say probably after an hour or so. So is there any evidence to show that the movement of the air bubble might be an indicator of pregnancy outcomes?
There's no data as far as I know relating to that. I would just be very cautious to link the movement of air bubbles to the movement of embryos. They're completely separate things. And you know, I've heard many clinicians say when they do the embryo transfer, "Oh, there are your embryos," when they see the white flash of air. So of course the embryos are going to sit in a relatively small volume. The endometrial surface is not like a smooth table. Of course, it has all sorts of nooks and crannies, and generally the feeling is that the embryos will sit where they are. The fluid will disperse, and then they will continue to develop. So I would be very surprised if there was any relationship between the movement of air bubbles and the movement of embryos. I think they're two separate events.
Any other questions? We don't see any more questions here. Jasneet, can we end this session then if there are no more questions?
Yes, ma'am, we can. We have 15 minutes, ma'am, in case we want to continue the discussion.
Yeah, Dr. Swaminathan, if he wishes to add something. Yeah, Dr. Swami, any more questions?
For Steve, is there any limitation for the KPI, like number of factors or number of things you have to consider? Any limitation for that, or you can keep as much as possible?
Is this to me?
Yes. Yeah.
I think like Dave said, that you have to validate your KPIs like you validate everything else. So I think, you know, the way I would answer that is to say that would be the limitation. So providing that your KPI can be validated by the available evidence, then that, you know, can be included as one of your KPIs, and you can build up your KPIs. But again, as you know, Steve beautifully demonstrated in his talk, and one of the other things I was hoping he was going to mention was doing an embryo transfer in the dark, because that in the early days of Bob Edwards, you know, they used to stumble around in the dark, which is crazy when you think about it. But you know, so again, it's not allowing yourself to be swayed by opinion, but relying on the available evidence, and that's very much our policy. You know, when we are teaching, we only rely upon the available evidence. So yeah, that would be my answer. Can I ask Steve a question, actually? Because I remember that there used to be a lot of interest in Viagra for patients and to increase vascularity, and I don't know whether you know, Doppler ultrasound is used by anyone when they do an embryo transfer. Has that kind of died a death, that approach?
I think in terms of in embryo transfer, it has. I think it was mostly used, certainly in my experience, during the stimulation phase, when potentially patients had poor ovarian response, to try to increase you know, the blood flow to the ovaries, to see if that would make any difference. I think in terms of increasing you know, blood flow, we really want the uterus to be fairly benign at the time we do the transfer, and some of the early studies, and certainly my experience when we started to do embryo transfer, when you used to use the clinical touch, you know, the problem was that the person doing the embryo transfer had no real knowledge of where to go. So the standard practice was to touch the fundus and then move back. And then, of course, that's one of the reasons why ultrasound works, because we know touching the fundus is a detrimental practice and should be avoided. So again, I don't know that Viagra is used in embryo transfer. It may still be used for ovarian stimulation.
There is a question to Dr. David Morrell. What is the significance of incident reporting analysis in the lab, and is troubleshooting required for the same incident reporting?
Yeah, I think that's one of the key messages really, is that using incidents and perhaps more importantly near misses is really useful. And in essence, it's about building a culture within the unit, within the laboratory, whereby people are confident enough to report things that nearly go wrong, and certainly they have to when things do go wrong. And then using any of those incidents as learning opportunities. And the learning opportunities really depend on some way of investigating and looking at the root causes. And of course, that then feeds into troubleshooting what went wrong, whether it was procedural, whether it was training, whether it was some other confounding factor. And you know, it's like anything in life, you learn from the mistakes, but the important thing is that you do have a robust system for reporting, investigating, and then communicating the learning from any of those sort of incidents.
One more question. Why do companies still sterilize disposables by ETO and not by the gamma irradiation? Can you describe more on custom chart?
I think they're two separate things. So I think the second one is probably a control chart. I shall leave that to. I'll leave that to. The reason for ethylene oxide is very straightforward. Is that most of the plasticware that we use in IVF, and particularly with embryo transfer catheters, are very sensitive to gamma irradiation. Gamma irradiation changes the nature of plastic. It tends to make it brittle. It can also discolor it. And I've always worried or wondered why people are concerned about ethylene oxide, because I hear many people say, well, it's embryotoxic. Well, it's a sterilizing agent, as is gamma irradiation. If you expose embryos to gamma irradiation, they don't do very well. But all of the companies who manufacture all of the plasticware that we use have a system in place to check that the ethylene oxide has been dispersed, and they're obviously not put out for clinical use until that level is below any that may cause any impact. So the main reason is the nature of the material. It's affected adversely by gamma irradiation. So ethylene oxide is perfectly safe and has been used for, well, certainly in the case of Wallace catheters, for 42 years now, and we've seen no detrimental effect. So it will continue, I suspect, as the sterilization agent of choice.
And the next question to Stephen Fleming. What is the impact of collapsing the blastocyst prior to freezing?
Good question. So when you collapse a blastocyst, you are effectively removing fluid from the blastocele, so-called cavity. You're removing fluid from that area. So any cryoprotectants that need to traverse, especially into the, we've got a three-dimensional blastocyst, that the cryoprotectants to traverse into those cells further into the blastocyst, then theoretically that should happen more quickly. So the impacts are, for a given period of equilibration, there's probably greater likelihood that you've completed the equilibration of all the cells in the blastocyst. And in terms of if you wanted to reduce the equilibration time to speed up the process, then you're more able to do that if you've collapsed the blastocyst than if you haven't. And in terms of outcomes, Some studies have shown, for example, higher rates of blastomere cryosurvival, lower rates of apoptosis, but then other studies have shown no difference between collapsing and not collapsing, or at least, sorry, I should have said that other studies have shown just as good success rates with cryosurvival and viability of blastocysts without collapsing. So again, as often is the case, it comes down to how you handle that particular system. So if you don't collapse, then you simply have to make sure that your equilibration time is significantly longer than if you do collapse.
You have to
And
unmute.
you'll have to unmute yourself.
Unmute. Bindu. You have to unmute.
Okay. So one last question probably to Dr. David. What parameters to be entered to monitor LC-QSIN chart?
Oh, that's a good question. It will depend on what training you're undertaking, and I'm desperately trying to remember the details of the embryo transfer training that was described. But the sort of I'm trying to remember. Just bear with me. I'm desperately trying to remember what the statistical analysis was based on. They had a mathematical formula, as I remember, that was based on the likelihood of success or failure, and they defined an acceptable failure rate and an acceptable deviation from the acceptable performance rate. So they have to set predefined criteria and then use a mathematical formula to produce the LC, QSIM and QSIM charts. But the actual criteria used, as I understand it, are set by the training lab based on what they perceive as adequate performance. Does that ring true with Steve and Steve?
Thank you. And just need one last question maybe?
Yes, ma'am, we have 4 minutes left.
Okay, so one question. Does flushing the uterine cavity with the transfer media really help? Or is it advised to flush the uterine cavity with normal saline? Because there are some clinicians who flush it with normal saline. So how good is it to flush the uterine cavity with normal saline or with the transfer media just before embryo transfer?
I'm trying to get to grips with flushing the endometrial cavity. There is a removal or potential cleaning of the cervix, but I don't know that people inject into the uterine cavity. And there was at one time, there was a real focus on removing every last bit of mucus from the cavity. In fact, we had things like Archimedes screws and all sorts of devices were coming onto the market to try to remove every last bit of mucus from the cavity before transfer. And actually over time, it became obvious that these things were actually detrimental. So a clean is required if there's a great excess of mucus, but gentle cleaning and using the catheters in the right way should avoid any mucus being transferred onto the catheter and potentially then into the uterine cavity. So cleaning is very important, but not to be too harsh. And certainly you don't want to be getting fluid into the uterine cavity itself, because that would potentially be extremely detrimental, I suspect.
Because there are people who use the IUI cannula to remove the mucus.
Yeah, and again, there's just no evidence that that's beneficial, and potentially if you're going to cause trauma doing it, then it's best to be avoided.
Sorry, ma'am, we are running short of time. We'd like to end the session.
Yeah, we are done with the 3 lectures and the discussions. It has been really wonderful. Dr. Swami, would you like to end it?
Thank you. Thank you. Thank you all the faculties. It's a great pleasure being here. Thank you.
Thank you,
Thank you for your
everyone.
time.
Thank you,
Thank you.
speakers. Thank you,
Thank you.
chairpersons, for such an interactive and knowledgeable session. Thank you, everyone.
Okay.
Good evening, everybody. On behalf of Fertivision 2020, I welcome you all. So we'll be starting with the panel discussion. The moderators for the same are Dr. Gaurav Majumdar. He's a chief embryologist and lab director at Center of IVF and Human Reproduction, Sir Gangaram Hospital, Delhi. And Dr. Sujata ma'am, she's head of embryology, Nova IVF Fertility. I'll also be welcoming our esteemed panelists, Dr. Sarabpreet Singh. He's a senior consultant and clinical embryologist at Artemis Gurgaon. Dr. Sudesh Kamath, lab director and embryologist at Bloom IVF Mumbai. And Dr. Keshav Malhotra, lab director at Rainbow IVF Agra. Also, Dr. Naval Shah, Head Q&A Training, Ashray Young Ambassador 2019, Indira IVF Group. Dr. Parag Nandi, Scientific Director and Clinical Embryologist, Cradle Fertility Center, Kolkata. Dr. Akash Agarwal, Scientific Director and Chief Clinical Embryologist at Hegre Fertility Center, Hyderabad. Over to you, the moderators.
All right, so we're going to share our screen. Right, so we're good to go here. I'd like to thank the organizing IFS body to give this opportunity to myself and Dr. Sujata Ramakrishnan to moderate this panel today, and we have about 50 minutes to do so. The topic is very interesting, and it says something not right, obviously in the IVF laboratory, and so there's a need for root cause analysis and CAPA. CAPA stands for corrective and preventive action. So in simple terms, this refers to troubleshooting in the IVF laboratory, where something may not be right. And Dr. Sujata, just you address the panel and then we'll take it forward.
We cannot hear
And you'll
her.
have to unmute yourself.
Yes.
Thank you, IFS, for this opportunity. Now, see, in an IVF lab, patients are involved. There are more than several thousands of parameters which are involved. And because of that, many a times things they do not fall in place. And when such a thing happens, what is the structured approach to address that? That is the intention of this panel. It's not like, we shouldn't be too quick to blame a particular thing, like say media is not okay, the incubator is not okay, or any individual factor. How do we go about identifying what exactly is the problem in a very structured, in a methodical way? That is the intention of the panel. So Gaurav, you can start with the...
So again, some basic understandings before we get on to the questions, that when something does go wrong in the laboratory, and believe me, it will, then one must understand that it affects every single patient in an entire batch of patients being dealt with. So these are not anecdotal situations that we are discussing or we'll be dealing with. These are systemic problems in the laboratory that will affect everyone, all patients. So that's why it is so important to address this issue. And in most cases, troubleshooting is is an act which occurs once a problem has already occurred. So we are not trying to preempt situations here. That's the job of the people who are maintaining quality control. But the purpose of this panel is to troubleshoot, right? And also troubleshooting does not work for the patients who've already been affected. So we are trying to troubleshoot and taking preventive action to make sure that future batches remain all right. And hence the focus also on preventive as well as corrective action. So we are also going to talk about preventive actions. And we know that in the IVF laboratory, prevention is better than cure, right? Because like I said, that once trouble has occurred, then there's no turning back for those patients. And believe me, when we say that things can go wrong, despite all the quality control measures which are taken in an IVF laboratory, they will go wrong at some point or the other. There'll always come a time when things will go wrong. And so I'm very excited about the group of panelists that we have to discuss the issues with. So we have Dr. Sudesh Kamath and Dr. Sarabpreet Singh, and I have grouped them into one. And then the next group has Dr. Naval Shah and Dr. Akash Agarwal. And Dr. Naval Shah is the head of quality control for Indra. So I'm very excited to hear from him. And then, of course, last but not the least is Dr. Keshav and Dr. Parag, again heading their units. So we will address questions to these three groups of panelists. So we start with the fact that, all right, how do we even recognize that something is not right in the laboratory? Because it seems there are numerous laboratories which are merrily working away and who might not even know that something may not be right in the laboratory. So to Dr. Sudesh and Dr. Sarabpreet, what is the first prerequisite to even understand that there's something wrong in the laboratory?
Thanks, Gaurav. Can I start? Can I just start?
Yes, please.
Yeah. What I would look for is 5 parameters. I'll do it very briefly. First, I look at the oocyte, whether the oocyte recovery is as many oocytes you are getting as per the number of follicles aspirated, at least 70-80%. And also I try to look for the number of oocytes, how many are metaphase 2, and the quality. Next, most important is the fertilization rate. If a fertilization rate is lower than what we normally expect, then definitely there is something wrong in the lab. Also, I'd look for whether there is, abnormal fertilization, like there's more 3PN and all.
Okay,
Next,
so sir, Dr. Sudesh, so what are these? Basically, what are you looking at?
Key performance indicators. I'm looking at these main indicators, the 5 indicators.
Okay.
First I mentioned is the oocyte, then the fertilization. Next, I'll come to the cleavage rate. I look for a day 2 and a day 3. What is the number of embryos I am getting? Is there higher incidence of maturation arrest on the day 2 embryo, on the day 3 embryo? And also very, very important is you look for the quality of the embryos.
Yes.
Is there fragmentation happening or anything else is going wrong with the embryos? These are 3 parameters. Fourth,
Dr. Sudesh, so would you give a numerical value to these parameters? And if you want to do that, on what basis would you give those numbers? Say, for example, your fertilization rate, and you want to, would you give, say, if it falls below this particular number, I assume that there is a problem. Would you say so? And if you want to determine a numerical value, on what basis would you do so?
In our lab, what we do is what I'll tell you. We look for, the fertilization rate. At our lab, it is between 80 to 90%. If it is going below 80%, the fertilization rate, this includes even, many times the testicular sperm, Pfizer sperm, which is being used. If it is lower than that, then we'll definitely think there's something wrong. We'll try to look for it because we are getting good fertilization rates.
Agreed. So we will get to the nitty-gritties, but do you agree? And I'm sure you as well as Sarabpreet have been consulted at numerous occasions by other labs where they might be having problems. But do you agree with us here when we say that unless they're not measuring their KPIs, how will they even know that there is a problem with fertilization? So have you ever encountered laboratories where there's very poor data keeping, there is almost no KPIs ever been calculated, and so troubleshooting becomes difficult? Have you encountered such labs?
No, we do encounter, but when we go to help them, we give them all these KPIs. Like every weekly you have to follow, monthly you have to follow.
Sudesh, I have a question here. So the KPI which works in your lab, okay, would it work for somebody else also?
No, there may be variations. But
so
it should not happen,
for example, when you are saying that, okay, you have a fertilization rate of around 80% in your lab, okay, but another lab may not have 80%, maybe it falls in the range of 70 to 75%. Then would you say that there is a problem in the lab? Or, the question is, how do you set these KPIs? On what basis do you set these KPIs?
In our setup, it may not be same everywhere, but what, like I told you, we include everything, and ours is more related to ICSI. And also we are seeing the percent, based on number of M2s, not total number of oocytes, how many were retrieved and how many. That's why, in IVF, your fertilization rates will be lower, because that way you see the overall how many oocytes we get. But here we see more on the number of M2s and how many embryos, how many are fertilized. That is why we have kept it slightly higher.
Sarapreet, you want to comment?
Actually, if we look at the Vienna consensus, there are few KPIs which they have mentioned, which are dependent in turn on the reference indicators which Dr. Sudesh has been mentioning.
Yeah.
So what we do is, when we troubleshoot a lab, we have divided these KPIs into 4 basic groups. One is the procedural group, if anything related to the procedure being carried out, like ICSI damage rate, fertilization rates. So ICSI damage rate should be less than 10%. Fertilization for IVF ICSI should be more than practically 70%, but then the Vienna consensus says 60%.
65, yes.
If there is a failed fertilization, then we have to think about purely technical or rarely biological factors. Okay. And if you have to look at the culture conditions, then day 2 and day 3 and day 5 embryo development rates, which are 50, 45, and 40% as per the Vienna consensus, respectively. Okay, and if I have to look at the vitrification KPIs, then I will look at day 3 and day 5 embryo survival rates, or cleavage or blastocyst embryo survival rate, which virtually should be more than 90%. If I have to evaluate the system as a whole, then I will look for implantation rates, which again should be more than 25 for cleavage and more than 35 for blastocyst. And to further evaluate these, I have to look at the reference indicators, which is percentage of oocytes recovered, as well as the proportion of M2 or mature oocytes available for ICSI, if you're doing ICSI. If you're doing IVF, then the second one is rudimentary.
Right.
That is how we methodically we kind of evaluate a lab. We have to look at these indicators and under those headings.
Great. So that's a great message from Dr. Sarapreet, that there are so many different types of KPIs, not just the endpoints like blastulation rate and fertilization rate, but as per the procedure which is being done, there are procedure related KPIs. There are even structure related KPIs which may come into question, and obviously there are outcome related KPIs according to the process which is being done. So now let's move to the next question, where Dr. Sujata, you take this.
Okay, so see, this is okay. Now we have a set of KPIs. How do we find out that there is a problem? What is the method to say that there is a problem in KPI? With just one time the value dropping, would you say that there is a problem, or how do we do that?
So we'll give this to group 2.
Yeah.
So can I answer?
Yes.
Yeah, Dr. Akash.
What we are doing when we are seeing at a KPI, we are looking at a point in time. That's like a snapshot what we are looking at. So what we should be more looking at is the overall picture, how the KPI is going. Say your KPI at the right now might be, say, for fertilization rate, for example, say 60%. So it falls below what is your competency value of 65 or 70%. But say your KPI earlier was 50%, so you're definitely on the improving trend. So what I would like to say is we should see the overall picture where it is going, first thing. And what we should be more worried is what is the deviation we are seeing it. Like you have seen the standard deviations. So if you are falling within 1 or 2 standard deviation, which is the normally accepted criteria for even clinical things, parameters, 2 standard deviation can happen by chance if it happens once in a while, if it is once in a while. So that is acceptable. If you have to obviously do a sub-analysis for all these things, but still 2 standard deviation can happen by a random chance itself. And anything which is very grossly fluctuating, say your KPIs for the month.
So Akash, you can see the control chart. So just can you explain this for the benefit of the audience?
Over this, what we are doing over here is we are taking the average of here. So the mean is being calculated and we are seeing the monthly fluctuating chart over here. So the problematic area would be indicated in the August one, what has been shown in the August, where it drops very dramatically below it and below the 2 standard deviation, I would say. So that is where we need to look into what went wrong. And we have to do a subgroup analysis. First of all, when we are seeing, definitely see there's a problem over here, right? There's a fall in the KPI. So we are sure that there's a problem over here. Then we should look into the data collected, which obviously shows that it is less. And then we should look into the details. We should do a subgroup analysis over here. it could be like what were the number of patients, like what kind of patients profile we had, what were the mean number of
we'll get to
insights.
that. Akash will get to that.
Okay,
And
no,
Naval,
okay,
yeah, we'll get to that in the next slide. That actually, how do we then tackle this situation, right? That's a great
I'm not
point.
going into the nitty gritty of it.
Yes.
And once we do a subgroup analysis, and then what we do is whether the problem actually exists and what is the true problem, we should come to it. We should come to the real actual end of the problem.
So I think the take home point from this is it's just not enough that you record your KPIs. You also need to analyze it. Graphical representation is useful. It helps you to identify dips below the mean.
Now, Naval, do you do this since you are heading a big chain responsible for so many centers? So do you want to comment on this?
Definitely, yes. So that is something which we are into. Recently, we have launched a digital dashboard in which at the just point of mouse click, we can analyze all the centers at one particular go, and the entire 1 year history has been taken into consideration. Now, as also Dr. Akash rightly suggested, there is a problem evolving, like over here, there is a problem evolving in July, and then it is going down in August, which is below standard deviation second.
Yeah.
Now, your mean can actually be your benchmark. Your first standard deviation below can be your competency rate. So you always have to between the competency rate and the benchmark, which is called as desirable value. This has to be set individually for different organizations, centers. Like for us, I have taken 6 months data, which has more than 45,000 blastocyst embryos and more than 28,000 embryo transfers. But when it comes to small standalone clinics, then for them, Vienna consensus also specifically say that there should be at least a set of 30 pickups or 30 cases which you should analyze, and then you can have these charts which can actually further lead you to how you can do the troubleshooting required in your setup. So that's how actually it has to be done. And you have to do a monthly review meeting for all these things, because just making the graphs is not actually what you can do. So to have a complete control, you need to analyze it on month basis. So every month we have a review meetings in which we discuss every center with regards to their previous performance of quarters. And then we understand, is there a drop in there or there is growth? So if there is continuously below second standard deviation, we need to act. And if they're going above second standard deviation, then that's the time when you can shift your benchmarks and make it all the more higher. So that's how this control chart actually works and helps us.
Probably why the line here is going up and down and fluctuating so majorly is maybe because there are fewer cases for this particular center. And if there are maybe more cases, then this will flatten out to a greater extent.
I think here we need to actually, like take that point what Dr. Akash mentioned, that a subgroup analysis is needed. Right. That means you have a set of patients, which do not change, like first timers, less than female age, less than 35 years of old, and then no testicular biopsy samples used. Maybe that could be your standard group of patient for whom you can analyze the data and compare it.
Right, right. So that will be our next. So that's when I want now Akash and as well as Keshav and Parag to now tell us. And obviously now it's evident that you're going to start with the patient population. So this is a real life scenario that you have to now troubleshoot. This is for about 100 patients in that particular month that you just saw. The ICSI fertilization rates has gone below 55% in this month of August. And now as the chief embryologist or the head of embryology, you have to fix this major dip immediately. So as we have heard, you want to start by looking at the patient population, yes. But Keshav, we'll begin with you. How do you suggest all the different sequence of steps that you will find it necessary in the correct order of importance that you will take to troubleshoot?
Okay. So thank you for this question. First of all, thanks to Fertivision. Now, when we have such a scenario, and like Dr. Sujata was also mentioning, that we do a subgroup analysis, we take in the normal patients, we take in like donor cycles, etc., etc. And if we still see such a phenomena, it's very, very important that the embryologist goes ahead and does the RCA in this particular situation. Now, how I would begin with such a scenario is I would want to see whether firstly there is a particular embryologist who is facing these issues, or is it throughout all the embryologists who are working in the laboratory. Then I would move on to basically the equipment. If the temperatures of the stages, etc., all of those things are sorted or not. I would also want to look at the sperm factors and the egg factors at this particular point of time, whether it's balancing out the situation or not, or whether again it's a cumulative thing which is happening within the laboratory. This is where culture conditions also come into play. So when were the calibrations and validations of the incubators, etc., done? All of those things will be taken into account. At this particular point, if I don't find anything, I would move ahead with analyzing the air quality. I would also check for, let's say, the cylinders that are coming, if I've changed vendors, or if like there's been a delay, or we've taken a cylinder from some other vendor, etc., etc. All of those things also need to be checked. So
Great,
basically
great.
what,
So
yeah.
that's an awesome thought process, and your sequence of thought process is really good, because we seem to concur on how to go about it. Now, Parag, there's one more thing. Now, Keshav has already checked. There is no difference in temperature. There is no fluctuation. The pH is fine. He has checked the gas. He has checked the vendor, that there was no change in gas. The air quality is also okay. There was no spike in VOCs. They've also done infection control because they could not find anything else. So they said, okay, let's do an infection control. Let's take swabs. But that was clear. The staff performance was uniform. So there were 4 different operators, and everybody still was performing at the same level, but everybody's performance went down together. So what is the one extra thing here that now could be a reason for such a massive dip in your ICSI results?
See, when the fertilization rate is going down, I am considering that there is no denaturation of eggs, particularly on day 1. I am seeing that there is no fertilization. The PN PN has not developed or something like that. So as already Dr. Keshav has pointed, like all the measures has been taken to confirm that there is no instrumentation problem. Like instrumentation problem means like the stage warmer is working fine. The environment, the air where I am actually doing ICSI, the outside, the ambient, that temperature is not too much down, and the air quality is perfectly fine. So these things has been checked out. Now the interpersonal variability, he has confirmed that like the interperson, everybody is facing the same problem.
Yes.
If everybody is going through the same problem, like no fertilization, and confirming that particular incubator where the ICSI embryos or ICSI eggs have been kept and no fertilization is coming. So in that case, there is a interpersonal variability also, like the procedural also is there, like the ulema is properly broken or not, and the entry point where the sperm is going injecting that portion, like it should not be the sperm should not be in the vessel, not in the cytoplasm. It should be going to the cytoplasm properly. It should not touch to the other part of the the egg. That procedural things have been taken care. And as I am also seeing
Parag, in this particular case, actually, we found that a new lot of dishes, the ICSI dishes, which were used, a new lot had been coming. So please comment on that.
So if the disposables we are particularly using, that particular disposable lot is to be checked also, that this disposable, is there any particular problem is there or not. That particular batch has some problem, or that particular particular sleeve that is having some problem. So this kind of problem may happen, or the denudation timing and procedure, that to be taken care also, like the if that thing is being done before time, or too much early, so that may give a wrong a perception about the ICSI fertilization rate. And I think that all these aspects, like the instrumental aspect, the procedural aspect, both things to be taken care.
Right. So that's great. That's excellent. And I just wanted to highlight that the procedure generally tends to remain the same. So we come to the procedure right at the end, once we have checked for all these parameters. Dr. Sudesh, any comments? If you have faced times when ICSI fertilization rates go down, what has been your experience?
I think most of it has been explained by Keshav. Parag. So all that we analyze, why the rates are lower. Similar, we keep on going step by step.
Any person who's actually faced this and they found a quick solution in their experience in the panel, any anecdote to share, or we move to the next question?
In a center, we found that on change of position of the ICSI table, the results dipped.
Oh yes.
And then they kind of recovered again because of vibration and all.
Right, and also
vibration, AC setting, all these things comes in consideration, because the AC, if it is too much close to the AC or the the vent where through the air, AHU air is coming down, if that is too much close to the ICSI table, so that may affect the overall quality of the ICSI. And another thing I would like to mention also, like if it is a procedure also, there are lots of newcomers, embryologists, junior embryologists that seeing this. So I would like to comment on also the sperm crashing, that also to be properly done, because that should be properly immobilized and neck should not be touched at all. So those things to be taken care also. Yes.
Yeah, I think we even have to start looking at the sperm preparation. If there is any change in the sperm collection containers, because there was in one center, when they changed the sperm collection containers, the ICSI fertilization dropped, embryo quality dropped. So I think we have to start from that point onwards.
So which means that the utensils or the consumables which are being used at every point are so critical that in case they become cytotoxic, then it can rain havoc.
So I would like to just comment one thing. But very recently, in our IUI, pregnancy was going down. So when we kept on checking all these things, we found like the particular tube which we are using, actually that tube was being changed, and on that particular conical tube was having some problem. So we shifted to another one, and immediately that spiked up. So that is, yes, Dr. Sujata rightly pointed out.
Yeah, Keshav.
And this is where documentation is very, very important. So, right, each and every consumable that you're using, please note down the lot numbers with your patient list, so that whenever such a scenario happens, you can just go back, okay, these patients I use this consumable, lot number, these patients I use this. So you will be able to find like common factors quickly, and that will actually help you in finishing off the exercise in a faster fashion.
Taking Keshav's point further, I would like to ask Naval this. So how do you track, because you have a very big volume, do you track these lot numbers in Indra of consumables and media? And do you analyze them?
Definitely, yes. Yes, we do it. We have a set system, we have a checklist, and whenever there is a drop in a batch results or any small variation also, we have a complete checklist of around 20 indicators which is being followed, which has been given to every embryologist and center heads to be crossed. And all those things are later on analyzed along with the batch and lot details. There have been instances previously where we had to ask for a change in lot of media. There have been instances like also, as you mentioned, with the sperm washing technique also, we have been finding some kind of infection or contamination in the density gradients, which is very surprising. But then these are the things, if you mention the lot numbers, you have those with you, and then immediately you can pass on message to the entire group that whatever lot number of this particular batch you have to replace it out, and we'll get the new one for you. So there have been instances, and we have the documentation for this particular purpose, and we do it very meticulously, as I said, month on month in every reviews.
Great. So, you do this within your chain, and we do this between clinics, where we may call up friends and other people in the city and find out if a particular batch of a culture media is working or not working. So this is a very important tip.
And one thing I would like to add is we should not forget the paramedical staff as well, because I had faced an issue where there was a change in the staff nurse who was doing, and she was properly not trained. She was not trained properly the importance of switching on the heating blocks 1 hour prior to it. She had found it anecdotally that once you switch it on, the indicator shows it within 5 to 10 minutes that it has reached 37. But we actually know that it takes around half an hour to 1 hour to stabilize. So paramedical staff also definitely that. And whenever we are changing anything, like I make it a point that whenever there is a change of anything, that has to be noted specifically, separately, anything, let it be a consumable, a staff, or a procedure, or SOP, anything.
Yeah. So everything lies in recording every single procedural. Okay, great. So that I think the discussion is going really well. Sujata, you can take the next question.
Okay. So after ICSI, you realize that the damage rate is, above 15%. How would you handle this situation?
So we go back to Sarabpreet and Dr. Sudesh Kamath.
Yeah, you know what I will do? 15% is very high. So there are 4 different reasons this can be. That is what we check normally. One is external, that is like something like vibration, where there isn't much control you have. You can of course have vibration, anti-vibration tables and all, but sometimes, when you're doing the ICSI, somebody drops something, the damage occurs. So that is one of the biggest problems. Most of the damage can happen because of the vibration. It can be anything, because some drilling going on far away or some generator is switched on. Second, you have to come to the manipulator, entire manipulator itself. Kesha also just now mentioned about a stage warmer, but more important, the damage can be if your joystick, is not smooth. There are jerky movements. That is where the damage can occur, even with an experienced embryologist. And second is your syringes. If there are bubbles inside, there is a time lag. You move it here and there is a time lag, then there are problems. The damage rate can be high. Third, I'll come to is the embryologist, the technical skill itself. Many times, if you inject, most important thing is, one is the damage can occur when you break the ulema. If you aspirate more, the higher chances of that, the membrane coming back to normal is less. So you're aspirating more cytoplasm or more PVP is injected. All this can lead to higher damage rate. And finally, sometimes, it is the oocyte itself. There are oocytes which are very, very fragile. Even in very experienced embryology, you just touch it, the needle, and the cytoplasm starts leaking out, where you can't do much. So all this we note down, we try to find out where is the damage occurring.
Great. So that's our ICSI expert talking. And he's given
few more
all,
tips.
Yeah, you've given all possible. It's a very, very in-depth analysis of, damage, and it comes from experience. Sarabpreet, any comments you'd like to make here?
I think he has covered everything. One point I would like to add is that if you are getting, the high days concentration can be looked into. Or any change of brand, the high days expiry, the exposure time in high days. These things can be looked into. Other than that, I think Dr. Sudesh has covered virtually everything.
Would anybody like to comment on the maturity of cytoplasm, the number of oocytes retrieved, the number of mature eggs? What is the cohort like, and does it have any effect on this post-ICSI damage? Would anybody like to comment on that?
So you would obviously want to look into oocyte factors like Sudesh sir just mentioned. But when we're talking about a complete dip of 15% in most of the cycles, then that's something that, according to me, unless and until a drug has been changed in the stimulation protocols, it might not happen with all of your patients. So here also a subgroup analysis would be beneficial, where you look at your damage rates in good prognosis patients and good responders, normal responders, like you mentioned early on. And again, you can think of one more point which I wanted to add was that if you get a recording of the ICSI procedure and if you store those recordings, maybe it would be a nice idea to go through those recordings, whether something is going wrong with the procedure or the technique itself. So that's also something that an embryologist would probably like to analyze.
So do you think that over time, because at the end of the day, ICSI is a very robotic procedure, and you keep doing it over and over and over and over again, then over a period of time, do you tend to become lax?
Absolutely.
And that may actually cause more damage. You may end up aspirating more, and you may think it's all right. And you may be more aggressive when you have a lot of pressure, you have a lot of eggs to inject, and you are very, very tired and busy. Do you think those are factors?
Absolutely, 100%. I completely agree with this fact, because even when we talk about general errors, this is the main problem, because we get so accustomed to doing the same procedure again and again over so many years that we tend to actually become complacent. We don't look at those finer aspects which we were looking at when we were younger. So I think this is something that I think all of us should be aware of, and this is where having another person sitting behind you, checking the egg quality, checking your like technique, etc., becomes important. And that's where I think double witnessing of these procedures is also something which is really, really important.
Gaurav, I think
Gaurav, I can just add something.
segregation
Yeah,
of
that's why. Sorry, Saraprit, please.
segregation of workflow is very important. If somebody can collect the eggs for you, somebody can denude it for you.
Yeah.
You know, segregation of workflow. You should try to teach your junior embryologists and technicians. It always helps you. You know, it takes a lot of work off you.
That's a great idea. Yeah, Dr. Sudesh, you'll have the last.
No, that's exactly what I wanted to say. Same thing. Like, see, I even do 10, 15 cases a day, but only thing I do, I'm being given the denuded oocyte, I just sit and inject.
Yeah.
So, then the load comes down on you. There are lots of other employees who do all the other work.
So that's an important message. Okay, so let's move on from ICSI damage rates. Now, this is another situation that we've chosen to discuss here, and then we'll move on to other issues. So now this is to do with pregnancy loss rates. And this I have heard from many of my colleagues, that suddenly everything is okay. Fertilization rate is okay, implantation rate is okay, pregnancy rate is still okay, 40%, 50%, 60%, but the pregnancy loss rate shoots up in a certain month. It goes through the roof. What could be the causes? What will you think of changing to fix this situation? We'll have group 2 answer this now.
Right. Can I take a lead?
Yes, please.
Yeah. So, I mean, I would like to put across over here a very kind of example which we have recently faced. And it's like we have already mentioned initially, there was a center who had around 70% consistent result. And then one fine month, it directly went down to 40%. And drop of a 30% is a huge drop. And we thought, what went wrong? So as we also discussed previously, we had a checklist which was formulated, all the answers were taken, everything was perfectly right from gas to temperature to operator, everything was perfectly right. Then we went to the media, considered the batches, checked the results across other groups, that was also right. Now, where did practically things went wrong that we had 30% drop in the pregnancy rate? And this is where we actually went into the personal audit, where we actually did the audit of all the staff over there. And we realized that just before the cases would start, the day prior, the media had reached in the evening, and there was a change in a pharmacist. And the pharmacist opened the box, counted the media. He was new, he didn't knew where to keep media. He just kept it in a thermocol box as it is, left and went. Next day morning, the senior pharmacist came. He put those medias into the fridge. Embryologist is unaware. Embryologist came, then he took that media and used it. And this entire media batch, which had a broken cold chain, was being used in particular batch. And we had a drop of direct 30% in a pregnancy rate.
So you were
and
saying
this is
that,
what actually gives you a message that you have to thoroughly look across.
So you're saying that break in cold chain actually caused the media to become cytotoxic to some extent. Is that so? Yeah, that's
because,
probably what happened.
Yes, because with regards to change in temperature, there is a change in oxygen reduction level in the media, and you cannot actually let that happen. So this is where actually your audit also comes into picture. So we have a 4-point audit system in all our process, which is covering personal, training, equipment, and process. And if there is anything, we actually directly put across an audit, we find everything. And then that is how we reach to a root cause analysis, that where the things went wrong.
So Naval, you gave an example of pregnancy rates going down. Can the same apply to pregnancy loss rates going up? Right? It can.
Yes, it can.
It can manifest even later, right? It can manifest later.
Definitely, yes.
Akash, any experience of this sort?
What would happen is, if the compromise is not to a very large extent, like something comparative, we can say with respect to DFI. So, it could not affect the initial stages, but it could manifest at a later stages. So definitely, I would say it would definitely have an effect on this. And like Dr. Naval has said, we would like to do a subgroup analysis. Whenever there is a problem like this, so it could be a problem anywhere. It could right from the starting from the patients who have been coming into the clinic to the.
Akash, it is unlikely. It is unlikely that in an entire month.
Yeah.
That
No,
all
I mean
patients.
to say that everything would be considered. It would. What I would say is we should consider that the problem lies in the lab as far as I'm the embryologist concerned.
Yeah.
It would be an analysis which would be done the clinical side by the clinician. But from my end, I would look right into from when the patient comes in, right from the oocyte and gametes comes in. Okay, so from that point till the point the gametes are the embryos are transferred. So I would say it could be anything and everything, like the Caro consensus says, it could be anything and everything could have an effect on this. And most important would be the temperature control. And I would like to see whether there's aneuploidy rates increase in the aneuploidy rate, that could definitely affect. Because if the temperature control is not proper, then you might have a good fertilization rate to a certain extent, might be, and even good blastocyst formation. But there might be just a little suboptimal conditions where you get good blastocysts, but there might be aneuploidy in the embryos. So I would definitely like to look into whether any PGTA transferred embryos were there, and even they had a loss in addition to what has been said.
Or even maybe look at the PGTA aneuploidy rate. Maybe that
Yes,
went
even
up.
that. Yeah, definitely. Temperature would definitely have an effect.
Can I just add something?
Yes, please.
Yeah, what Naval mentioned, this can happen drastically, pregnancy rates can fall down because of media. To prevent that, what we do in our setup, we use media from 2 different companies for each and every patient. So the damage is very minimized. Something goes wrong, we can spot it out. But half the embryos are in the other media, and our pregnancy rates are, that's why at a good rates.
So that's a smart thing to do.
Naval, what was the embryo how was the embryo formation? I mean, when you used that batch of media which got spoiled?
The embryo formation was good. We had actually checked across the blast rate and good blast rate also. It had a drip of around 5 to 10%, but it was not a large dip. So around from 60, it came to 50 in that particular batch. But overall, the things went quite well. But it was the ultimate
Didn't translate into a
pregnancy results, which actually dipped.
Yes. I'm so happy for you to say this, that actually, you may not be able to pick up the problem at the level of the embryo. The embryos may look perfect, and still you may have a big dip in pregnancy and in pregnancy loss rate. It is not at the level of embryo.
Yes.
Absolutely. I think in this particular scenario, you also have to look at the air quality, because there are certain months where VOCs might increase, especially in northern Indian cities, winter months, etc.
Okay.
Now, these are things that you should really consider, especially if it's happening for one particular month. I think that's also one more factor which can.
Right.
All right. Yeah. Naval, you want to say?
Yeah. Go ahead, Naval. Go ahead.
Yeah, exactly as what Dr. Keshav said. There's another example. There was a lab previously. I have faced this. That's just behind the lab. There are canneries which work only in 2 or 3 months of the year and not around the year. So around the year we see good pregnancy rates, and then immediately we see that there is a dip. Now it's also environment, as Keshav said. We have to look across, and it's not only internal environment. At times you also have to audit the external environment. That is where we found that there are canneries working outside only in those 2 or 3 months. That is where the results are getting affected. And then these are the things then you need to actually all the more streamline further.
Very interesting.
Yeah,
very interesting. So not only internal factors, but external factors also. Okay, excellent. We move on to the next question.
Gaurav, I think we should move on to
Yes.
the other
Sujata,
questions.
you take this question.
Now, shall we move from these real life situations to our other questions?
Okay.
Because I think we just have 10 minutes.
No, we have about 15. We have about 17 minutes, Dr. Sujata.
Okay.
17 minutes.
Okay, I think we will move from these troubleshooting, and then we will move on to the other questions.
Okay, so you take this then.
Okay, so Dr. Akash was mentioning about SOP. And then we all think that SOP is like the panacea for everything. People would tell you, follow your SOP, then you will not have problems. What exactly is an SOP, and is there any criteria for having a good SOP? Who's going to take?
So no, so we can let Keshav and Parag comment on this, and then Akash can come in.
Okay. Should I begin?
Yeah.
Okay, so an SOP is basically whatever you're doing in the laboratory, you just document it into a stepwise fashion that becomes your SOP. Now, whenever we talk about an SOP for an RCA, that also, I think that's something which is very important, because unless and until you have a plan in mind, or unless and until you have at least a mindset in or a mind frame in mind, so you will not be able to come to a conclusion. So what we want to do for RCAs is that you take out or you divide the parameters into subsets. So let's say it can be culture conditions, it can be lab equipment, it can be your personnel, it can be your consumables, etc., etc. Whatever your problem, whenever whatever problem arises, you just match it with whichever point it correlates to best. So let's say my FERT rate is dipping, so I will just see that, okay, it could be because of my culture conditions, it could be because of personal training, it could be because of consumables. So I will go into that direction first, and then check for the other parameters. So that's
So Keshav, in an SOP, what are the things which are mandatory?
okay. So you basically start with, so whenever we are writing an SOP, we start with an introduction to the SOP, because an SOP has to be framed in such a way that even if a layperson comes into your lab and reads the SOP, they will also be able to get an idea of what this is about. So it always has to be, it has to start with the introduction. Then you basically put in all the different points that could be affecting that, or that are involved in that SOP. So let's say I'm writing an SOP for ICSI.
So Keshav, refer to the diagram, to this diagram. This is a SOP for root cause analysis for poor pregnancy rate in FET. So we've done this for you. So you can just maybe refer to
So
this.
here also, like what I was saying is that you will have these different parameters like materials, training, protocols, instruments, environment, etc. And again, divide each of them into like when we're talking about materials, you can talk about the kits, whether they were at the correct temperature or not, whether the carriers were appropriate, etc., etc. So within that SOP, have all possibilities that could happen, so that whenever an embryologist is doing the RCA, they can just refer to these questions and just take a yes or a no and just keep moving on forwards. And this will actually help you in analyzing the cause much better.
Right.
Exactly, Keshav. I think, like that's a very important point, that all adverse effects or what to expect when there is an abnormal or when there is a adverse situation has to be mentioned in the SOP. It's a very valid point. Any further additions to this?
This would Parag. So this would make it easy, right? Put things in a perspective for the embryologist to think better and troubleshoot better.
Yes, exactly. I mean, whenever there is a problem, it may be an instrumental problem or the procedural problem. So you have to have a proper SOP. Other than you cannot exactly find out the root cause. That is the main thing you have to see. Like whenever you are, you have to see the certain parameters, KPIs, all these things have been taken consideration. You have to have a very easy type of SOPs, like everything has been properly mentioned. There are two types of embryologists are working inside the lab, like the junior and the senior. So the juniors are the communication between the two people, like what exactly he is feeling, or any kind of you are getting some smell or outside or something like that, nowadays during the corona time, that is also like the SOP. Some SOPs have been added extra, that to be taken care also, like if that SOP is not affecting the year wise SOPs, like it should not affect, like there are some procedural changes have been taken place, changes of gloves, the air disinfectants and all these things have been happening around your building. So that may anytime affect your the year long SOPs that we have been seeing. So those things to be taken care in consideration. And the the cold chain that is also be taken care of. I have given particular 2 people I have appointed in my clinic. Other than their job, I have appointed for them to check every day that like the freezer temperatures, whatever the fridges are there inside, those things have been properly noted down. Any changes, any door closing problem or something like that, all these things to be taken care. So communication is a very, very key thing for this. Yes.
So this is an example here. Who had mentioned changing the position of the ICSI
Saraprit.
Saraprit. Yes. So this is the same example where they found poor ICSI embryos after changing the position.
Save some time now.
Yeah, yeah. And I'd like to share an anecdote. During these Corona times in the beginning, there came a point where we started seeing a dip in our FET pregnancy rates. And then we were just going through every single detail, and we realized that too much sanitizer and all these disinfectants was being used. And from next day onwards, we said, okay, enough of these disinfectants, even though they were all cleared, and but staff was using them outside in the non-sterile areas, and there was just too much disinfectant everywhere. And so we realized that it's not helping us at all.
Yes. That is what we have.
Corona. Sorry.
Yes.
Sorry to interrupt, sir. Just 10 minutes left.
Yes. So, Sujata, we are on time now, so we can just take now. So this was good. This was great discussion. That having these detailed SOPs can help in troubleshooting. And now we reach something which is which Dr. Sujata is very passionate about. That in addition to certain systemic changes which may lead to changes in quality parameters over time in a laboratory, it is also important to understand another form of troubleshooting which goes on with respect to sudden changes or errors, so to say, in an IVF laboratory. And this is what she refers to as incident analysis. So I want you to elaborate on this, Dr. Sujata.
So, like when we are talking about something going wrong in an IVF lab, it need not necessarily be related to the outcome, like poor fertilization, poor pregnancy, right? It also could be something to do with the mistakes. It could be human errors, it could be equipmental faults, it could be anything. And this actually can have an impact on the quality of the embryos. So how do we deal with situations like that? Nawal, would you want to comment on this? What do you have these kind of incidents, and what would you do when you face such incidents?
And what is the significance? Why should I report an incident? How does it matter?
So with regards to incidents, incidences actually have to be recorded. Hello?
Yeah, we can hear you. Yeah.
Okay.
So just Saraprit, you can come in after Naval.
Okay. So I was telling you that we have a portal called as Incidents Reporting Portal, which is made up of JIRA. And any incidents which is happening, there is a structured way by which all these incidents are actually getting reported. As I said that, like even we have a problem of gases being come in. We've seen that there have been change in the gas cylinders locally by a vendor, which change just the entire results. And with regards to change in gas and the results coming down, we also record that as an incident where the change of the vendor was done without informing the head office. Such kind of things also get into incidents, and thus have an impact on a system. We have an annual log of all these incidents, and we actually check the centers with regards to how many incidents have been reported from all these centers in an yearly basis. And that's how even all the centers are created. So incidents reporting becomes an intrinsic system, and it has to be there available with every unit, with every organization. You actually cannot miss out on this. It is very crucial.
Excellent. Would anybody like to mention about any other incidents which they have faced, which actually would help everyone?
Yes, if I can go in here, I don't know, Saraprit wanted to pitch in.
Carry on, Keshav. I'll come in the end.
So we also use, we don't use a software, but we use manual incident reports in our laboratory. And most of them are focused towards like serious risks which can happen in the laboratory. So if there was a near miss, then that I would want the embryologist or whoever was responsible for that to fill in an incident report, and then we sit with our managing director and the whole board sits together to discuss why that error happened or why that near miss happened and ways
So
to
even
actually.
you are classifying a near miss also as an incident?
I do it in my laboratory because I would want to stay vigilant. I don't, because it's these near misses which can actually result in fatal errors later on. So just because of vigilance, we tend to actually discuss these. There were very few which have been reported. If I give
What
an
do you
example,
discuss? What do you discuss? I
how
mean,
to how to
why the near miss took place and what
why
led
and
to
how
it?
to prevent it in the future.
Okay.
That's that. So we basically focus on preventive strategies for the future. And because we are all humans, I think this is one thing we have to understand, and errors can happen from all of us. So we don't just go ahead and chop the heads of embryologists in our laboratory, but we try and figure out whether this can be prevented in the future. And if there are multiple incidents happening from the same person, then obviously there is some corrective action which needs to be taken with regards to that person as well.
Retraining.
Dr. Akash, would you like to mention any particular incident which you think is...
Yeah, there was I would agree with Dr. Keshav that we have to come out with the incidents. Once it should not be a blame culture. It should be more has to do with honesty and integrity. That obviously at an individual level, and as an organization, what do you promote? See, if there is, say, suppose there's some problem of the dip in fertilization rate. So I had an issue where one of the cases there was continuous dip in the performance of the embryologist. Like continuously, I was seeing a dip in the fertilization rate plus slight increase in the lysis rate. Because otherwise it usually would be about 80%. It dropped below 70%. Still very much in the capable.
Akash, still you are talking about systemic errors. Say if it was a mix-up.
I'm coming to that.
If it's a mix-up, then also we should be honest and report the incident.
I'm saying is the problem was the embryologist was too much stressed out. It was like there was too much of problem. Even personally, stress can play a role. When you are having a stress at a personal level, the person was having some issues at home. That is the time when you need to take a call. So this is like would not be, I would call, a systemic error. This is like we have to consider the person as a human being, and his mental and psychological well-being also will definitely have an effect on the results what he's giving. So that's what I wanted to say.
No, I want someone to comment if there's a mix-up. Then what do you do?
Once the guidelines are in place, becomes a law, you'll be behind bars.
No, even now, so does it mean that the embryologist, do they report this mix-up? What would you encourage?
I don't have any experience with mix-ups, but definitely you should report it. So, see, supposing you come to know by, okay, maybe you realize it later, maybe a wrong sperm you're, added or used it for ICSI. If you realize it, and you inform the chief of your lab, you can do some corrective measures you can take. So very, very important to report it. Okay, you realize, okay, you may be thrown out or whatever, but at least I say you can avoid transferring that embryo into a patient if you're frozen it. So most important is to report. Even sometimes, okay, you may think, okay, by mistake I have done this, but very, very important to just inform that.
Yeah, and I think what Keshav said was very important, that to make sure that it doesn't happen again. So you have to figure out what
so it should never happen.
Yeah,
exactly.
Yeah, mixing up and then not reporting is something like hit and run kind of thing. Like if you have encountered with some kind of accident, you just report it, and accordingly we can take that particular. So there should be a proper.
This happens accidentally. Nobody does it on
exactly.
So when you don't realize it, that is the biggest.
See, actually, like we can't say it happened accidentally because like if you have an SOP which says that at this particular stage, 2 people have to check. That too, there is an SOP for 1 person checking, post that another person is checking. So only when you do not follow your SOP, these mistakes can happen. So when you identify such incidents, then what we do is we actually make them follow the SOP. And then, you just make another revision of SOP with them so that these kind of mistakes, they do not happen.
Okay. All right. So thank you very much, Dr. Sujata. We have finished dot in time. There's still 2 minutes to go. And
Okay.
yeah, I would like to thank you, Dr. Sujata, and all our learned panelists. And it was an excellent discussion, and it was really, really, we got great take-home messages. So it was really nice.
Thank you,
sir. Thank you, ma'am. Thank you,
so
all the
much.
panelists for such an excellent and scintillating session. Thank you, everyone.
Thank you, everyone. And I would also like to thank Team IFS for inviting all of us for this panel. Thank you, everyone.
It's a
Thank
great
you so
honor.
much, sir.
Thank you.
Thank you. Thank you.
Moving on to the next session, I'd like to invite Dr. Ritika to please introduce the chairpersons for the next session.
Ma'am, please unmute yourself. Dr. Ritika, ma'am, please unmute. Dr. Ritika, ma'am, please unmute yourself.
Is the screen visible?
Yes, ma'am. Please continue.
Yeah. Good evening, everyone. So now we move on to our next session, session C9. To chair this session, I would like to invite Dr. Krishna Chaitanya. Dr. Chaitanya is Scientific Director, Oasis Center for Reproductive Medicine, Hyderabad. Our second chairperson is Dr. Charulata Chatterjee. Dr. Chatterjee is Senior Consultant Embryologist at Yashoda Fertility and Research Institute, Secunderabad. And our third chairperson is Dr. Nitin Lad. Dr. Lad is Scientific Director and Consultant Assisted Reproduction at Dr. Lad's Navjeevan Hospital, Nashik. A very warm welcome to all our chairpersons. Over to you now.
Thank you so much, ma'am. So let's quickly move on without wasting much time. So with a lot of pride and honor, let me take the honor to introduce our first speaker for really need an elaborate introduction. A very famous personality, very learned person. Everyone has Dr. Jayant, we can get started.
Thank you very much for the introduction, Dr. Krishna. If I can share my slides. Good afternoon, good evening, ladies and gentlemen. It's good afternoon here in London. I bring greetings from London to all of you. At the start of the, I was asked by the organizers to put in a short CV of myself, but obviously the chairperson, Dr. Krishna, has done an excellent job. Thank you very much for that. The organizing committee, the scientific committee, has asked me to discuss microfluidics and sperm preparation. And before I start my talk, I would like to confirm that I have no conflict of interest to declare. I would also like to appreciate and thank the scientific team for Fertivision 20. Your thought patterns, and also that it will allow you to think of microfluidics in the ART laboratory. Why are we considering looking at sperm preparation using microfluidics when we have already established two techniques which has been there for quite a long time, the swim-up density gradients, and now in some laboratories, magnetic activation cell sorting. The simple reason behind that is that all of these techniques require centrifugation. The ideal sperm separation technique should be quick, easy, and cost-effective. Isolate as much motile spermatozoa as possible from a heterogeneous sample, not cause sperm damage or non-physiological alterations of the separated sperm cells. It should also eliminate dead spermatozoa and other cells, including leukocytes and bacteria. It should eliminate toxic or bioactive substances like decapacitated factors or reactive oxygen species, the ROS. But most importantly, it should allow processing of large volumes of ejaculate to be processed. None of the techniques that we currently have meet all these requirements. We certainly use a combination of techniques which is mandatory to obtain an optimal functional competent spermatozoa. The question that I would like to ask, and also you should be asking, will the microfluidics help? Well, by the end of my talk, hopefully I should have an answer for that. What we all know is that paternal factors influence negatively the development of the embryos. And here I talk about the late paternal defects, impaired development of the embryos, and possibly no implantation and miscarriages. And this is all due to the sperm nucleus defects. I'm not going to be talking about any of these factors because the speakers after me would cover them adequately. Apart from just to mention that these microfluidics does help reduce the percentage of the DNA fragmented sperm available for treatment. We also know that migration of sperm through the female tract is highly dependent on sperm motility. The factors that influence the journey of a sperm cell, which starts with ejaculation and ends up with egg fertilization, are also poorly characterized. However, the sperm undergoes a lot of physical factors, temperature gradients, rheotoxic effects, and molecular factors which include chemotactic gradients, interactions of ligands on sperm with receptors on the wall of female tract, and hopefully having negotiated itself to the point of fertilization to development of an embryo, we may end up with a live birth. I've used some terms here which I would like to discuss with you and define them so that as we move forward in my talk, they will become easier to understand. Rheotaxis is a process where an organism swims against a flow. Studies shows rheotaxis plays an important role in sperm migration through hydrodynamic interactions, whereas the chemotaxis is a process whereby cells or organisms move up a gradient of a chemical attraction. There is also thermotaxis, which is a process whereby an organism moves up a thermal gradient. So let's understand what is required in microfluidics. Well, microfluidic devices had a period of hype from 1990 to 2009. And this was due to the photolithographic technology first being developed in silicon industry for miniature electronic components and was later adopted by the biologists like ourselves to make molds of microfluidic devices from soft, transparent, and non-toxic silicon polymer fluidic, commonly known as PDMS. This material provides physiological platforms to recreate the channels and fluid flow in living systems. It has the ability to control biophysical and biochemical environments at a quantitative level. Furthermore, this particular material is chemically stable, is not hygroscopic, and allows gases to diffuse to and from the media. I'm sure you'll all agree that diffusion of the gases is an essential part. What is also important is that this microenvironment, which we have now created with the microfluidic devices, allows us to study how motile cells and microbes detect and respond to microenvironment. Again, looking at the chemical gradients, surface morphology, the fluid flow, and what is also very critical is that sperm do not stick to PDMS, as this is something which we require. Here I got a diagrammatic representation of what a microchip would look like. It would have two openings on the left-hand side of your screen and two on the right-hand side. And this raw semen sample is introduced at the upper end of the left-hand side opening, which runs parallel to the two channels which are present here. as demonstrated in this diagram. And then you have your media being introduced in that channel, which will flow along with the semen sample, and you will have the filtration taking place, whereas you get the motile sperm coming into this area, collected as shown here, and you'll have dead sperms plus all the other cellular debris collected out here. Look at, remember the surface area here is much greater than the channels, what the channels offer. And that is something which they've made use of. At this stage, I would also like to introduce a Reynolds number. Rn is measure of inertial force versus viscous force, defined as UL divided by V. U is the swimming velocity, L is the length of the swimmer, and the V is viscosity. Why do we need to understand this? For the simple reason that if the Rn is low because of the size of the sperm, we can ignore the inertial force, and studies have shown that the sperm tend to swim near the surface, i.e. at the top of the surface, nearer rather than middle or at the bottom, allowing the separation to take place very easily. Rotation of the sperm body leads to viscous force around the body, which is lower on the head of the sperm than the surface. Obviously, a very important characteristic. And therefore, the non-zero net force leads to the torque that guides the sperm to swim in a circle on a surface vortex. Let's look at what the microfluidic sperm selection techniques have been used. The most important thing, the first technique that was required was to improve selection of high quality sperm population by targeting highly motile sperm, i.e. using the surface area across which the sperm swims to allow them to be separated and only motile sperm to be collected. This may be the natural way to separate from somatic cells and debris in semen sample. Cho et al. Obviously was the first one to, in 2003, demonstrated this using the chamber that I demonstrated earlier. And they were also able to separate the dead and damaged sperm cells, which were selectively collected in different chambers. What is important to understand here, the studies that have been reported so far have shown that it allows you to collect highly motile sperm, which are needed for IUI or IVF. The studies have reported 100% motile sperm and as high as 3 times the normal form of morphologically normal sperm. Sirota et al. In 2016 went one step further and demonstrated that the DNA fragmentation reduced to only 1% value from the original raw sample. So therefore, I'm sure you'll all agree that when we have this kind of drastic changes, a very enriched population of sperm, we may start considering using this. So let's look at the chambers that have been devised so far. The chamber A, which is what I demonstrated earlier, you have motile sperm can be selected from immotile sperm due to the ability to swim across channel width. Here you have the sperm sample coming into this particular chamber with the media going in there. And look at the sizes. This entire chip is 5,000 micrometers with the channels being 400 micrometers and the thickness being 50 micrometers. So it's a very small chip that you're using. So allowing us further processing of the sample. The other chamber, the chamber B here, is used based on the swimming speed used in, as sperm population have different speed that are available. So you're funneling the highly motile sperm coming into this area and separation taking place on that. This was the study reported imposed by velocity gradients by Wu et al. In 2007. But what is interesting is another chamber by Noserati in 2014 used a series of parallel long narrow channels to select motile viable spermatozoa. And that is represented here in the diagrammatic representation in panel C. If looking at all this, they are dependent on the motility of the sperm and how fast the sperm would swim through, and you're able to separate all this based on the motility only. Let's now discuss some of the results that have been reported. The first study that I would like to report here is from our own Delhi center, the Dr. Kedi Nair's group, Kansha IVF Center. They looked at normospermic samples which had more than 25% DNA fragmentation. They looked at grade 3 embryos when they separated the sperm using microfluidic techniques as opposed to the density gradient separation technique. And they found that 60% of the embryos were obtained with microfluidic as opposed to 38% of grade A quality. Even the clinical pregnancy rates, you had 62% versus 41% in favor of the microfluidics. And moving on, when you look at the live birth rate, it was 46% versus 29%. What is also significantly important to realize that they reduce the miscarriage rate to 12% from 25% in the density gradient separation group. Another study reported from the Canary Center at Stanford confirmed higher motility and higher percentage of morphologically normal sperm with high DNA integrity as compared to sperm sorted in swim-up. Obviously, here they're only doing a swim-up and unprocessed semen sample. So even with the swim-up techniques, you are able to enrich it further using the microfluidic techniques. This study, published in 2018 by Quinn et al., again, they looked at microfluidic separation, comparing density gradient centrifugation with swim-up in split semen samples. And the results down here in table 1 show that you had 100% motile spermatozoa, motile sperm present, as opposed to 91% in density gradient. This is the density, the DNA fragmentation percentage index is what I'm very much impressed by. And that is that from 20%, they reduced to 1%, almost 1% in this study. This, I think, allows us to rethink what we are achieving here using this technology. Last year, in 2019, Alexandra Perel's group looked at a different device where it's called Zymote multi device. It comes in 3 different sizes. And here you actually have 2 compartments separated by a porous membrane of 8 micrometers. I mentioned earlier, because of the RN number being low, the sperms swim by the surface. And therefore, utilizing that RN value, we are able to allow the sperm to swim into this sperm collection media, which would have been added initially up to 250 microliters. I have used non-bicarbonate-based media, add my semen, raw semen sample in the bottom channel. The sperm would then get aspirated, swim up into this collection media after leaving the chamber in a humidified environment at 37 degrees for 30 minutes. I have seen similar results when you leave them at room temperature for almost 45 minutes. But that is debatable, and obviously each laboratory have their own different techniques to follow through. So what are the results? Here are 3 tables, 1 graph and 2 tables that I would like to share with you. The first one here is looking at the progressive motility. And as you can see, again, it has been confirmed that with microfluidics, you have much higher progressive motile sperm. Morphology, again, twice the value from 2.5 in the raw, but DNA fragmentation, again, from 20.7 to 1.8. Very encouraging. This particular graphs demonstrated further where with the raw semen sample, the SCF values are much higher, but when you look at the microfluidic, this value is almost reaching 0 in 23 patients that tested. Having achieved the fertilization through ICSI in the study, they were able to generate and identify euploid in both the groups. They found that the euploid that was identified was equal in both the groups, but when they tested for the PGTA and of the frozen samples that they identified that the clinical pregnancy rate was 100% for the microfluidics as opposed to 20%. Pregnancy losses was 0%, and ongoing or delivery cells was 100%. I'm sure, ladies and gentlemen, you will agree with me that with this kind of results, we are onto a newer dimension of looking and preparing the sperm and enriching our sperm population for our patients and getting better results. Excuse me. The other technique that have been reported, but there's still a lot of studies that need to be generated for it to allow us to think moving to that direction, is using the design of microfluidics where we are not dependent on the motility of the sperm. We rely on the sperm size, shape, or the charge for sperm sorting, low concentration of sperm cells relative to other material. We separate from epithelial cells, for example, in forensic analysis, and also from white blood cells, which may be present within a semen sample. And most recently, they've suggested that we may use this particular technology for testicular biopsy. This is only achievable by designing a microchannel with functional structures, the hydrodynamic interaction between fluid flow and cells, which allows separation of different size cells. Here is a diagrammatic representation of what actually takes place. You have the isolation of a spiral microchannels to isolate sperm from the pyrosperm semen sample. The samples are injected at the inlet, which is in A here, and based on the size and lateral migration, part B and C would allow the white blood cells to be collected in different outlets. D, that is where the sperm would be selected, and you would have the another outlet, which is the inner outlet for the white blood cells to be collected. So here is a technique which allows you to process a very dirty sample, if I can use that, where the sperm motility is limited. There have been several chambers that have been designed for using micro-TZ with low sperm concentration. The list is long. The time doesn't permit me to go into all of this thing, but what I would like to do is select two, just as an example. For example, the microscale filters. The working principles behind here is the restriction by incorporating microfeatures or fluid physics. And the advantages have been simple in concept and design, easy to fabricate, integrate with other microfluid systems. But the disadvantages is highly likelihood to clog up and not result in what you want to achieve at the end. There are several
Dr.
comments.
Jayant, I think I would request you to wind up if you don't mind, please.
Sure,
Sorry,
sure.
we're running out of time. Yeah.
No problem. Thanks. So in conclusion, ladies and gentlemen, the answer to the question that I raised is yes, microfluidics does help, and improved selection of highly quality sperm subpopulation by targeting highly motile sperm. You have achieved 100% motile, 3 times the normal forms, and also achieving 80% improvement in DNA integrity. It allows separation of low sperm concentration from epithelial cells, white blood cells, and testicular biopsies. Will also allow us to understand sperm kinetics under controlled microenvironment, which has not been possible so far. Although the microfluidic technology offers many relevant applications for ART and male infertility, it has still not been developed commercially to bring it into our clinic because of the technology and the cost implication. And finally, I would like to leave a thought with all of you, and maybe this is something that you can consider, is there has been a lot of talk about using microfluidics in embryo cultures with continuously changing and sampling media. Is the time right? maybe yes. And that is something that we need to do. I thank you for listening patiently, and also wish you all a very happy Christmas and Happy New Year. Stay safe. Thank you very much.
Thank you so much for this informative talk. Now it is indeed my great honor and privilege to invite Professor Sheena Lewis. She is a chairperson for British Andrology Society and founder member for Irish Fertility Society. She is going to talk on interesting topic of making man fit for fatherhood. Over to you, Dr. Professor Sheena.
Dr. Sheena, please unmute yourself.
Good. Thank you very much indeed for inviting me to speak today. And it's a great privilege and pleasure for me to be here. And I think this has been a wonderful conference to date. And I hope I'm going to add a little bit more that will be of interest to you. What we're going to talk about for the next 20 minutes is making men fit for fatherhood. And the reason that, oh gosh. Yeah, the reason that that is so important is because it is such a huge problem for fertility. I have a few potential conflicts of interest. I'm a member of the executive committee of this Associated Reproductive and Clinical Sciences. I'm a member of the HFEA committee and an ad hoc reviewer for the Science Media Centre. I'm also the CEO of a university spin-out company. So the learning objectives today are to understand the limitations of current male infertility testing, the ways to identify treatable causes of male infertility, and then I want to talk a little bit about the link between sperm DNA damage, which we've been researching here in Queen's for the last 20 years, and idiopathic infertility, recurrent pregnancy loss, and the relationship between DNA and ART outcomes. Then I want to talk about why antioxidant treatment doesn't work for everyone, as I'm sure everyone listening to my talk will have that experience as well. And then finally, I want to talk about donor sperm, or whether we should change to use surgically retrieved sperm. Now, until very recently, we haven't really taken male infertility as seriously as we ought. And yet a couple of years ago, the HFEA in the UK showed that the most common reasons for IVF were male infertility or unexplained infertility. And as you know, a lot of unexplained infertility is due to the male. The second reason I think we ought to be thinking very seriously about this is because last year, the European pregnancy rates in ESHRE were shown to have reached a peak or even a slight decline in pregnancy rates. Now, I find that quite shocking. We've been working in IVF for over 40 years and we are not getting any better. And I would suggest that the reason for that is because we're not looking as we ought at the male. Of course, we continue to use semen analysis, which we know has a very limited diagnostic value for male infertility and very little value whatsoever for as a prognostic test for ART, certainly none in ICSI. And I think we need to move to molecular testing. There's much greater accuracy in molecular testing. Semen analysis has always been a blunt instrument, and with the last WHO parameters that came out, the criteria for normality dropped in every single parameter, which doesn't seem a very reasonable thing to do, but that's the way it is. Many fertile men have poor semen analysis and many infertile men have normal. As you know, 25 to 30% of idiopathic couples can have normal semen analysis. But if we look at something like DNA, and in our lab, we used a number of different tests before we decided that DNA was the best test to use. We have shown that sperm DNA has much lower coefficients of variation, both between spermatogenic cycles and within spermatogenic cycles. And of course, following fertilization, the DNA of the sperm is the only thing that matters, nothing else does. There are a number of different tests, as you probably know. There are basically 4 that people use around the world. There's the COMET, the Tunnel, the SCASA, and the HALO test. And if you look on the left here, you can see that the ROC curves, or the area under the curves, show that the comet and the tunnel come out best in terms of being a diagnostic test for male infertility. And similarly, the relationship with clinical pregnancies, comet and tunnel are much more sensitive than halo or SCASA. And these are from 2 systematic reviews, one from America and one from Australia. Now, because it's so important to get the quality of the DNA measured correctly, we, by using the COMET test, we have brought in new parameters. And because we look at the sperm DNA damage per sperm, we're able to give you a histogram of percentiles. And here on the right, you can see these are 100 fertile men. And you can see that the vast majority of them, if you think of the green bars as being the fertile bars, the vast majority of a fertile man's sperm are good DNA. Now, you know, if you looked at a semen analysis, it might be a high count, a low count, a high motility, a low motility. Depends very much on the one sample to the next. It changes all the time. That is not the case for DNA. The DNA quality of a fertile man's sperm remains the same. And if you go outside these parameters, with the amber ones are the ones which are sort of not very good. The red ones are the ones that are really bad, full of DNA damage. And we have now got the average COMET score, which is all of the sperm together, the green, which are the very good sperm, and the red, which are the very bad sperm. And I'm going to show you some of the data to show how these relate to patient outcomes. You can see that all of these parameters are very robust as male infertility biomarkers. Look at the ROC curves there, and they're all 0.9. The sensitivities and specificities are very high. So it looks as if this is a really sensitive test. When you look at the DNA damage differences between fertile men and couples who have idiopathic infertility, again, you can see we had 76 fertile men and we had 166 couples with idiopathic infertility, and the difference in the DNA damage between 14% in fertile men and 30% in couples who had normal semen. And again, the high COMET score is very low in fertile men, much higher in couples with idiopathic. And the number of good sperm, again, fertile men, 90% of their sperm were really good, and only about 50% of couples whose semen looked perfectly normal. Now, it's taken quite a while, but I'm very glad to say that it's now becoming embedded within the guidelines of a number of societies that DNA testing is being measured as well as semen analysis. And this is from the European Association of Urology, where they're saying that, yes, you need to have a comprehensive andrological examination, you need to have a semen analysis. However, it has become clear from studies that more complex testing on semen analysis may be required. And this is particularly true if couples have had recurrent pregnancy loss, either from assisted conception or from assisted conception, and also for men who've got unexplained infertility. And there's cases, there's a good reason for looking at DNA damage in all of these men, and you can see the full details of that below. Again, in terms of the European recurrent pregnancy loss guidelines, which came out in 2017, I was a co-author of this. And for the first time ever, we brought the man into the equation of recurrent pregnancy loss. And you can see the recommendation here that in the male partner, it's suggested that his lifestyle factors ought to be considered in the whole situation of recurrent pregnancy loss, as well as the woman. There was no relationship with semen analysis, but the guidelines suggest that assessing sperm DNA fragmentation in these couples can be considered, even though the evidence at the moment is quite slim, but it's sufficiently strong for us to think that that is a good idea. Now, this is a paper which we published just last month, and we were looking at sperm DNA fragmentation with the COMET assay as a novel biomarker. And what we found was that men whose partners had either had sporadic or recurrent miscarriage after both natural or assisted conception had twice the amount of DNA damage as those couples who had a live birth. So this is a very exciting paper. It was based on 76 fertile men and over 200 couples who'd had recurrent pregnancy losses. And the data was very tight, lots and lots of damage, double the amount of damage in the couples who had recurrent miscarriages. If you look at the COMET as a predictor of IVF, you can see that both the average COMET score, the high COMET score, and the low COMET score are all significant. But if you look at the bottom, there's some very interesting data here as well. And what we did was we looked using a logistic regression analysis to see what the individual predictors were. And we looked at male age, female age, AMH, and of course the DNA parameters. And what we found was that the high COMET score, when we looked at it, and the female age, those were the two most important parameters influencing live birth. And what you can see here is that the high COMET score was much more important in terms of a live birth with IVF than female age. Now, when we looked at ICSI then, as you probably know, all of the tests to date have shown that there's no relationship between the average COMET score and live births with ICSI. But with our two new parameters of the high COMET score and the low COMET score, we found that there were significant relationships here. Again, if you look at logistic regression at the female age and the high COMET score with ICSI, the female age is much more important compared to the high COMET score. In the past, the high COMET score for IVF was 7, and here it has dropped to 2. So, which treatment will give you better success if you've got high DNA damage? And of course, it's very evident that ICSI will give you a better result than IVF. Now, I think the reason for this is because if you have a lot of bad sperm, which have got free radicals in IVF, and you put them in to fertilize the egg spends the whole night basically firefighting and doesn't have an opportunity to repair the DNA damage in the sperm that has fertilized her. It's entirely different in ICSI. There's only one sperm, there are no free radicals in the medium, and so the egg is a better opportunity to repair what damage there is. Does that mean that we should use ICSI for everyone? I think the answer is most definitely not. This paper came out last month from, it was highlighted by ESHRE, and it was talking about the increased risk of birth defects using ICSI. And here you can see, and this is an enormous study of 135,000 ART children in America. You can see that the risks of major non-chromosomal birth defects were much higher with ICSI. They were 42% in men who had male factor issues and 30% if they'd had ICSI, but there weren't male factor issues. So that is a reason, I would suggest, for trying to improve sperm quality, whether we're going to use IVF or ICSI. And so what I would say is that a male diagnosis should include much more than just a sperm check. We need to be doing a clinical examination and a clinical history of the man himself. Chronic pelvic pain is one of the most common factors, and yet we never really ask men about this in the fertility clinic, either from UTIs or STIs. Prostatitis is very common, and that, of course, those infections lead to bacteria in the semen and have a huge impact on the quality of the sperm. Varicocele, which again, we're very neglectful of varicocele in men. 41% of men with primary infertility have varicocele. 81% of men with secondary infertility can have varicocele, and yet if the man has a normal semen analysis, none of these investigations are ever taken. There's a lot of data that's come out over the last few years on varicocele sperm quality and ART, and there's no doubt that correcting varicocele leads to an improvement in semen, or improvement in DNA, and an improvement, most of all, in pregnancy rates. Now, what can we do? If we're going to improve men's quality of sperm, what are we going to do? Well, lifestyle choices can be sperm enemies. Some people eat too much, some people work out in the gym too much, and both those are very bad, because a lot of men who take protein shakes in the gym, which are filled with nandrolones, these are anabolic steroids, which are bad for sperm. There's a relationship, as you're probably interested in India, between gutka, and it can have, there's a big study that was done. You can see that it has a bad effect on sperm as well. Cigarette smoking, again, associated with reduced sperm count and motility, and even more worrying with childhood cancers and paternal smoking. Sexually transmitted diseases, bacterial infections are declining, but viral infections are increasing. Of course, these lead to DNA damage and poor sperm, and then the STIs can also be passed on to the woman, causing tubal obstruction. So that's a bad news for everyone. Male age, well, there's not a lot you can do if a couple comes to you. They are the age they are. But I think we should be encouraging couples and even educating children to realize that men need to become fathers early in their lives, just the way women need to become mothers. And a couple of really large studies, one of them which has come from India, from Secunderabad, which I know one of our panel is from that area as well. This is a huge study that came out just a couple of months ago. And these are showing that after 35, counts, motility and DNA quality all go down in men. DNA strand breaks can occur in two ways. You can either have single strand breaks, which are from oxidative stress, or you can have double strand breaks, which happen during spermatogenesis. Now, it's only the single strand breaks that can be protected by antioxidant supplementation. The double strand breaks can't. And we have shown a study here for men who were presenting with cancers. One was a lymphoma, which was a non-reproductive cancer. The other was a testicular cancer. You can see that using two different types of the comet, one the alkaline pH, you look at double and single strand breaks. But if you use the comet assay at a neutral pH, you can measure double strand breaks only. And what we have shown here is that even though these men had normal semen, the DNA damage in the two cancer groups was much higher than in the donor group. What are we going to do to treat men with double strand breaks? If we can't use antioxidants, what can we do? And then this, of course, is where testicular sperm may become the way forward in the future. The rationale is that a lot of the damage occurs by oxidative stress in the epididymis. So if you go back to either the head of the epididymis or even better to the testis and get the sperm from there, they're much better quality. And here's the last piece of data I want to show you today, and this is one that I find very exciting. What we have looked at is the ejaculate and testicular sperm. You can see that in the testicular, which are the orange ones, the comet score is much lower. The low comet score, which is the good sperm, is much higher, and the high comet score, which is the poor ones, is much lower. And that converts into much higher clinical pregnancy rates. So I do believe, along with many other groups who are working on this at the moment, that the way forward for men who have very poor sperm DNA, the way forward will be to go to source and get testicular sperm, because that appears to lead to much better success. We have two choices. We can keep on ignoring men, which is what I'm afraid around the world, which is what a lot of people do, and make fertility treatment completely female focused. Or we can embrace innovation in male fertility testing and try to improve success rates. I leave you with the question, which is the greater, the risk or the benefit, and which is in the best interest of the couple? And thank you very much for listening.
Thank you, Dr. Sheena Madam, for your excellent presentation.
My pleasure.
Now I take this opportunity to introduce our next speaker, and he is Dr. David Mortimer. Dr. David, he is president of Uzua Biomedical, and he is consultant in reproductive biomedicine. Dr. David, he is member of Canadian Standard Association. It deals with quality and competence in the medical lab. With this short introduction, I request Dr. David to start his lecture.
Thank you very much indeed, Mr. Chairman. Can everybody hear me fine?
Yes, sir.
Good. So it's a pleasure to be here. It's a cold, dark and very early Sunday morning here in Vancouver, but it's a pleasure to be able to speak to all my friends in India. My topic for today was to talk about moving from a descriptive semen analysis to a more functional assessment of sperm in ART. I suspect this talk might have been better at the beginning of the session, but that would have been in the middle of the night here, so I'm grateful for having been able to give this a bit later on. You've heard who I am. I just want to point out, as down here, that no commercial or financial interest influences this sort of presentation, regardless of whatever I do as my own business or work for whichever companies. These are my perceptions and beliefs as a reproductive biomedicine scientist. So as you heard from Sheena, the man is not just a source of sperm for ART. We do have other purposes on the planet, maybe negative on some occasions, but we are not just a source of sperm. And it's important that a male factor, whether it's in isolation or combined, is present in at least 50% of subfertile couples. And we do have to look at those coexisting underlying medical issues in the male partner, which can affect his future health. And if we're just ignoring those things entirely and just seeing him as a source of sperm, we can miss those things. So as part of the infertility investigations, apart from the history and physical examination, a descriptive semen analysis does remain the first step. But you need to remember that the plastic jar, well, how safe it is not the natural environment for human sperm. And this assessment of a routine semen analysis tells us nothing really about actual sperm function. If we think about all the processes leading to conception, obviously getting eggs to the site of fertilization in the female, and the man making a sperm ejaculation, which we hope will relate to insemination in this case, if we want to achieve conception. And of course, everything after that occurs in the relatively inaccessible environment of the female reproductive tract. Sperm have to penetrate cervical mucus. There is sperm transport and storage with the reservoir concept, which is probably within the mucus itself, sperm capacitation, hyperactivation, and then all of the other clever things that sperm have to do to interact with the oocyte and fertilize it and make a zygote. Now, of all these things that the sperm have to do, the only things that we have as lab tests in terms of looking at the sperm that are done routinely or were done routinely are semen analysis. Postcoital tests are still done in some places. Sperm mucus interaction tests in vitro are rarely done, but they can be informative. And I will come back to DNA and other things later on. This is a cartoon that was drawn from many years ago by a good friend Tony Bramley. And in the semen sample, there are the
Sir, sorry to disturb you. Please speak more louder or nearby the mic.
Okay, I can't. I will
Because we can't hear you, sir.
Okay, I will need to just get out of the presentation to go and adjust the microphone. For some reason,
Still,
I have to get to it first.
sir, please try to come near the mic.
I can, but I'm trying to fix the actual thing. But it's not letting me get to it. Audio. Microphone. Audio settings. Now that should be better. Can you hear it better?
Yes, sir. It's fine now.
Yes,
Thank
sir.
you, sir.
Fine.
You gotta love Zoom and it adjusts things for you. Okay, so let me get my pointer back and we'll get back into this. So in the semen sample, there are the handsome, well-swimming sperm mixed up with the immature sperm, the ugly sperm, the dead and dying sperm, agglutinated sperm. The only sperm that get into the female tract in vivo are these handsome, well-swimming sperm. And the important thing to think about this is that in biology, these are the only sperm in the semen sample that are of any biological consequence. The rest are junk. So good fertility in vivo depends on a high concentration of sperm with the correct kinematics for penetrating cervical mucus. And we have a pretty good idea what these things are from old studies on sperm kinematics. Sperm morphology, which of course does relate to fertilizing ability, is improved with the mucus. But the mucus doesn't select the good sperm. The mucus is the environment where selection against sperm with midpiece and or tail defects happens because they have poor motility. They just can't get in. So in truth, what we really want to know about a semen sample is, are there enough good sperm, ones with the right stuff, to get into the female tract? And this is what you need to think about as a biologist if you're thinking about what a semen sample or a semen analysis should be telling us about the sample, but really about the man. We know that in vivo, cervical mucus is the first thing that sperm have to penetrate. And this has been known for many years. This is from Jan Kramer's thesis back in the 60s. And we know that with poor motility, you've got more poor, bad, or negative sperm mucus interaction tests. And from looking at these things within older photographic methods even, we were able to determine back then that The sperm that get into cervical mucus or good mucus penetration tests relate to a certain concentration of progressively motile sperm, a good velocity, and wide ALH, which means they've got good flagella kinematics, flagella beating. And these sperm, the ones that get into mucus, are in fact a subset of the WHO grade A sperm. So grade A motility is important. Other people have mentioned the semen analysis reference values from WHO. There's the manual and there's the reference characteristics that were published in the big review article. Both publications are certainly widely cited, but both are also widely criticized. The lab manual, the methods contain numerous errors and inconsistencies. And the important thing to remember is that these reference values are derived relating to in vivo conception endpoints only. It is of no surprise whatsoever, or should be of no surprise whatsoever, that these have got nothing to do with ART. And even when we think about in vivo endpoints, Lars Bjørndal did this excellent review almost 10 years ago now, showing that reference ranges and reference limits are actually not much use. They're mostly misused and abused in terms of semen analysis. And his review is critical of both of those WHO publications for some obvious technical things, that they failed to properly recognize subject population differences, biological and methodological variability, and other artifacts. And they ignored a lot of technical issues in terms of the quality of the data that were used in this meta-analysis. So really, we have not, for us ourselves, worried about the WHO manual since this 5th edition was published. A 6th edition is in the works, I believe, and is expected sometime late next year, perhaps. What we've been using for the last 10 years is the handbook that was produced by the Escher Andrology SIG members of the education and quality subcommittees of that SIG, and what people who run these basic semen analysis courses. This handbook provides detailed, logical, unambiguous SOP type methods that are designed to be robust, to minimize technical errors, and avoid unnecessary effort to facilitate QC. The courses employ a comprehensive, structured training approach that leads to substantial immediate reductions in intra-observer variability in semen analysis through establishing a goal-oriented training protocol. And the reference values in this section of this handbook, they define the prerequisites for valid interpretation of those characteristics, cautionary notes regarding the characteristics, and considers the in vivo and in vitro significance of each characteristic separately. So this was designed to be not just related to the more traditional use of semen analysis, but to lead it into a more intelligent use in ART. I'm going to mention this fairly quickly. The WHO says there's no need to assess grade A motility. So it's too subjective, cannot be established reliably by eye. Well, I'm very sorry, but yes, it needs to be, and it can be. This is a statement from John McLeod, published before even I was born. The quality of sperm motility is a prime factor to be considered in semen analysis. Not as a percentage, the quality. And he noted that achievement of intra and inter-observer standardization is essential in any method used to assess sperm motility, and observers must be properly trained. If you don't train people to do motility assessments, they will not give you reliable answers. So if you want to train people, it is very easy. We can use reference video recordings in a calibrated grid, 25 micron squares on this grid will actually tell you how to do grade A very simply. And we can train people. This is just results of one person being trained. And over their training, yes, they can be within 5% of the reference value for percent rapid, the grade A's, within a few training series. So it can be done. But if you don't put the effort in, of course, they can't do it. Sperm morphology. Everyone sees these sorts of images from different textbooks and whatever about all the different weird and wonderful shapes that can exist. There are, for some time now, there's been a perception that the Tygerberg strict criteria and the WHO were different. That was brought together more closely in the 3rd edition in 1992. Tygerberg strict criteria defined the normal, which is now called a typical form, and it just counts the number that meet those criteria. And since 1992 in WHO, the focus is to look for defects in the sperm that can affect sperm function in each region of a sperm. These normal sperm are sperm that have no recognizable defects. So instead of looking for perfection, you are left with a normal sperm because they don't have defects. And this is a much easier way to teach people to do things than try to just look for normal. People said, this is terrible, now two different approaches for doing the same thing. Well, Rolf Menkveld, who invented the Tiger Word criteria, and I, who actually wrote this section of the 92 manual, did a direct comparison between Cape Town and Sydney in those days and found there's actually very little difference between the perceptions of the two different approaches. But the problem is that the 4% normal, or in fact, we're now saying these are ideal forms, because how can the normal be such a very small proportion of the sperm? These ideal forms, this is not useful diagnostically unless you've achieved or you've assessed at least 1,500 sperm, because otherwise the sampling error and measurement uncertainty make it impossible to distinguish between 3% and 5%. So a 4% cutoff has assessed on 1, 2, 300 sperm even, is of no real value. It is not a robust number. We also face the problem that almost all men have got values below 10%, so we have a very small dynamic range in results. It's a long, long time since you saw anybody with 30% normal forms. The thing to remember is that sperm with abnormal head shape have at least twice as many coexisting midpiece and or tail defects as do sperm with ideal head shape. This is, of course, why you get this apparent selection for sperm with normal head shape in cervical mucus, because the ones that can't swim very well just don't get in there. But this means that we need more information than just the ideal forms, and this is where the teratozoospermia index comes in. And this is looking at the head, neck midpiece, tail, and residual cytoplasm, looking for defects in each of those regions. So each abnormal sperm has between 1 and 4 defects, and the more defects, the more likely it is the sperm is going to be dysfunctional. There's a study that was done in Paris in the 1980s. They called it the multiple anomalies index, very similar to TZI. But look at the difference. If it's below 1.6 or above 1.6, treatment-independent pregnancies, 64% or 45% of the couples achieved a treatment-independent pregnancy after 3 years. But if the TZI or MAI goes up above 1.8, it drops to 25%. Above 1.9, becomes 11%. This study had no difference in sperm count, sperm motility, normal forms, or whatever. And this, in fact, between less than 1.6 above 1.9 is the biggest significant difference we've ever seen in anything to do with laboratory andrology. Antibodies are largely out of favor these days, but it needs to remember that according to the WHO manual for the standards of investigation, diagnosis, and management of the infertile male, it is still part of the basic workup. The important thing really in ART these days is if you've got high level of head antibody binding, you need to go straight to ICSI. You will have a risk of poor fertilization. Janet talked about different methods of sperm preparation. The method still used by the vast majority of labs around the world is density gradients, but they're done very variably around the world. I've audited many, many labs and seen many, many variations of the so-called standard two-layer gradients. There are many tricks to the way it should be done properly, including how you harvest and recover the pellet. Many people overload, put too much semen on the layers or use too small layers. They don't stick to the standard gradient speeds and therefore affect their yields. But here's the very important feature. The gradient media and the wash media must both contain EDTA, because the manufacturer of the colloid does have the inherent risk of heavy metal contamination that can promote free radical generation. So you need EDTA in the media to be able to protect the sperm from those potential free radicals, and the pure sperm family of products has always had it in there. In your final preparation, what you have is the most dense sperm, because it's a density gradient. These are fully condensed nuclei, no excess cytoplasm. You've got more morphologically ideal sperm, and these sperm tend to have lower DNA fragmentation. Typically, your final preparation from all normal zoospermic samples should be at least 95% progressively motile. If it's not, then it's either diagnostic of likely sperm dysfunction or tells you that somebody did something wrong in the process. For us, for our uses in these conditions, if we get less than 85% progressively motile at final prep, we'll consider using ICSI. Less than 80 will definitely use ICSI. You will see studies, Janet showed one, where the gradient preparation had only 65% progressive. Those are either very poor samples or poor methodology. It is important to have a negligible seminal plasma carryover less than 1 part in 10,000 is important, because even at 1 part in 10,000, it can affect fertilizing ability at IVF because of decapacitation factors. And of course, doing this method, we end up with minimal or no microbiological carryover, which is important. Sperm hyperactivation is essential. It happens in all eutherian sperm as they capacitate, and it allows the sperm to push through the zona pellucida. It's essential for fertilization both in vivo and in vitro, and if it doesn't happen, it can lead to or predict IVF fertilization failure. So this is just one sperm that Sharon tracked over a number of seconds, and this area is clearly hyperactivated, this area isn't. And if you look at the beating of the tail in these two sections of the track, and you plot those out to get your beat envelopes, you can see that the beat envelope is enough to classify the sperm as hyperactivated or not. So if you wonder why this pattern of beating is important, imagine these sperm attached to a zona. This pattern of beating generates more than 10 times the force required to break covalent bonds. Sperm push through the zona pellucida. Yes, the protease, the acrosin might soften it, but it doesn't dissolve it. You don't see at electron microscopy a big hole in the zona. So hyperactivated motility is essential. And hyperactivation analysis is possible, but the robust algorithms for identifying those cells based on the kinematics were set up based on flagella analysis of tracks, and then looking at the kinematic values to classify them. So these purple tracks are hyperactivated, but they are hyperactivated not just because they've been classified by the CASA machine. The original definitions were based on how the tails were beating. Problem with hyperactivation is different men show different levels of hyperactivation, and it takes different amounts of time to achieve their peak hyperactivation. This is just part of biology. We know that hyperactivation agonists include both progesterone and pentoxifalin, and back in the mid-90s, we developed this HA-Max assay, in which case a 1-hour incubation with an agonist, which is both of these agonist compounds, induces within 10% of the maximum spontaneous hyperactivation that would have occurred regardless of the time point in more than 90% of men. And we can use this assay very effectively, and we use these sort criteria. I'm showing Hamilton-Thorne machines and IVUS because these are the only machines that these criteria are valid for. Other machines, they will give you results, but they won't give you the correct results. In many cases, they will underestimate, for example, with the SCAs. So you need to be able to use machines for which the algorithms are validated. We can use hyperactivation measurements as part of a diagnostic workup on that trial wash preparation, where we incubate under capacitating conditions. We can look at hyperactivation. We can look, if we see low hyperactivation, we identify possible sperm dysfunction. So you might need to go for poor prognosis for IUI, because if you can't hyperactivate, you need to use ART. If you've got likely dysfunction, you've got to use ART. And on the day of IVF, you can even use them again on that final sperm prep before you inseminate the eggs, because if you've got low hyperactivation, perhaps unexpected low hyperactivation, and this of course will depend on your culture medium. For ones we use, it's less than 10%. This indicates like possible sperm dysfunction, hence a risk of low no IVF FERT. So we have a last minute check for conversion from IVF to ICSI. We would always prefer to do IVF rather than ICSI if we can. So our modern view of sperm assessments is that we can't expect to be able to predict pregnancy in isolation of the female partner. That's just silly talk. And in fact, we're not really interested in trying to predict the likelihood of treatment success, for example, fertilization at IVF. Our real interest is in identifying the risk of specific failure using a particular therapeutic modality. So really, our sperm assessment is to say, is gamete approximation and interaction going to work in vivo or in vitro, depending on your endpoints? So we have this thing called a structured management concept, where we use the protocols to use simple testing to allow us to use resources more effectively. And this has been around for many years. The WHO Manual of Clinical Management 2000 actually uses this same sort of approach in its own identification of what sort of forms of treatment should be used. So we have this assessment we do, semen analysis, trial wash antibodies, CASA, and now we're adding in the markers for redox state. And based on the test, we can end up with men being identified that their sperm are okay for anything, IUI might be recommended, IVF might be recommended, or we say you need to go to ICSI. And those stratified treatment recommendations allow us to get people to the treatments they need quickly without wasting time along the way, without rushing to ICSI on everybody, which is more invasive, as Sheena showed those recent results, which I found were very impressive when I saw the paper as well. So we want to use ICSI as little as possible. Using this approach, we've at a number of centers over a number of years, we can show that the fecundity rate when we have recommended IUI from these tests is double what it is in the unscreened patients. It's not magically improving the sperm in these, it's just not treating those patients who've got poor prognosis. So you only treat the ones with good prognosis. And again, here, if we've recommended IUI or not recommended it, again, hello. So we give couples with good prognosis a good chance to achieve pregnancy at lower cost, and we help couples with poor prognosis avoid wasting time and money on repeated IUIs. We developed these concepts back when I was in Sydney, at which point more than 90% of our patients had male factor by then current WHO criteria. We still only did 35% ICSI, but our IVF had about a 5% fertilization rate. We could do a lot better than that now. This is something that Sharon did in the early 2000s, and among this large number of new referrals, almost half of those men with normal semen analysis according to WHO criteria had abnormal results in the other SFA components cause us to recommend ICSI. This meant that in the period before they did the SFAs, they did a lot of ICSI and had an active recurrent ICSI rescue ICSI program. But when the SFAs came in, cycle numbers had gone up, doing a lot of IUIs, and it reduced the ICSI to 40% and almost no rescue ICSI. So this was a much better managing the patients, and the lower FILT was now down to 1% of IVF cycles. Another study where we looked at this is the same approach. The low and failed IVF cycles were looked at in the IVF and ICSI patients, and we then looked at the background of those cycles. So if you look at the low IVF cycles, most of those occurred in cycles where we had large numbers of eggs or very small numbers of mature eggs. The ones with failed IVF fertilization, most of those occurred when we had very few eggs and very few mature eggs. In other words, most of our abnormal IVF fertilization outcomes occurred in cycles with abnormal stimulation responses. So these failures were not necessarily due to sperm factors, they were due to poor eggs. Within the SFA, we do not assess acrosome reactions, sperm donor binding, sperm oocyte fusion, milk pronucleus formation or syngamy, or routinely sperm DNA integrity by whatever method. These have a poor return investment for the patients. Acrosome reaction might be useful, it's rather more complex, and it's dependent on calcium fluxes and seems to be those abnormal sperm, which is all dependent on cat spur, seem to be picked up largely with the hyperactivation assay. I mentioned the Marxist test. We're looking at this much more favorably because we know that high levels of oxidative stress are linked to sperm dysfunction and hence failed IVF outcomes. Lipid peroxidation of the sperm plasma membrane affects motility, capacitation, acrosome reaction, hence fertilizing ability, and also oxidation of sperm chromatin, hence subsequent DNA fragmentation. So if we could measure this, this could be very useful. And this test does seem to give a fairly good way of identifying the normal sperm and abnormal semen quality with reasonable accuracy. The ROC curve is about 0.77 area under the curve. So we're looking at using this now as a screening test to identify the cases that will likely benefit from sperm DNA fragmentation so that we don't do it on everybody routinely. There are some men you'll pick from their lifestyle or from their work environment that may be good candidates for doing sperm DNA fragmentation, but you can also pick up some others where we've got other sources of a redox stress. It is also possible that this test may actually help us identify those patients for whom antioxidant treatment might be more beneficial. So the way we've been looking at sperm function or sperm assessment for quite a while now is a more functional approach. With CASA, we look at the semen sample and look at the concentration of rapidly progressive motile sperm, we get WHO 4 grade 8. We look at the concentration of good mucus penetrating sperm. If those are low, then you need at least IUI as a treatment. Simple. Look at the wash sperm, and we do it on a trial wash diagnostic, or the IVF inseminator as a last minute check. Look at the concentration of highly motile sperm, which would include hyperactivated sperm. The highly motile is not necessarily progressive. We look at the rapid progressive because that tells us about the quality of the sperm preparation. That Vienna KPI consensus says it should be over 95%. We look at hyperactivation. The other things we look at are sperm morphology, and we're going to continue with visual assessment until a validated CASA-based system that includes the entire sperm, not just the head, becomes available, because then we'll be able to get the teased eye, which for us is far more useful. Antibodies, we just use this to check and screen out those patients who've got high levels of head-directed antibodies and send them direct to ICSI. Marks is screening to identify risk of oxidative damage to sperm function or DNA, and then DNA fragmentation testing when it's indicated. So this is how we've been working for a while. I see this going forward. There are other possible tests. More molecular tests of sperm function just don't exist in a routinely applicable method yet. Microfluidics, in some extent, is a buzzword. It may be an alternative way of preparing sperm. There's other methods, as Jen mentioned, even by electrophoresis, using a method that John Aiken described a few years ago, that is going to be launched hopefully next year. It's been slowed down by COVID, called the Felix method. We have a great future, but we need to stop doing poor semen analyses and look at sperm from a physiological point of view. Or we can look at it from a pathophysiological point of view as well, but just not as a simple descriptive thing. We've got to think about what sperm need to do in vivo or in vitro and assess those characteristics. And then we'll start finding something that's much more useful about the semen samples and about the men who are accompanying their partners to the clinics, because most clinics are no longer fertility clinics, they're now ART clinics. And very few places will actually see patients as just a straightforward infertile couple. Those that do, I commend them enormously, but certainly on this side of the Atlantic, most places are now just IVF clinics. Thank you very much.
Dr. Chaitanya, we can't hear you. Actually, your voice is not audible. So your network connection is not proper.
Am I audible now? Hello?
Yes, please continue.
Wonderful. I was just saying thank you, Dr. David. That was a wonderful presentation. I think you just make the whole topic sound so simple. It just makes us more and more involved in andrology, and especially the QCs that you take and you explain, you just make it like a cakewalk. Thank you for that brilliant presentation. So let's just move on to the question and answer session. So Dr. Jayant, if you're there, I think the first question is for you. A brilliant presentation on microfluidics. And I've always been wondering, there's one question that, can microfluidics be done for a poor sample with a poor count and poor motility?
And the answer is yes, it can be done, but obviously there would be limitations to what you're looking for, especially when you're looking at a sample for ICSI and the chamber that you use. There has to be some motility. The first slides that I showed you uses motile sperm as a key principle for the sperm to swim through. And yes, it can be done. But the second slide where I was talking about the separation with testicular biopsy tissues, etc. Again, the principle used there is something that will allow you to separate the other cellular debris from the actual sperm. One of the section that the study that has been done, there is a risk of a lot of clogging because of other cellular debris. But the answer is yes, it can be done.
Yeah, you know, as a take-home message, is there, I know you've answered, but is there a basic count and motility that just makes it easier to have a good recovery to do either ICSI or whatever procedure we're planning to do?
The studies that I'm aware of have used less than 1 million sperm for separation purposes. However, the end result has been only few 100,000 sperms. So obviously the cutoff that hasn't been established. In different laboratories, it has a different preparatory techniques which has been achieved. So obviously there's no cutoff from that point of view.
Wonderful. That's brilliant. And indications, do we kind of extend the same indications with raised DNA fragmentation for whatever we have done, as in the recurrent pregnancy loss, or recurrent implantation failures, recurrent genital tract infections? Do we extend microfluidics to only these indications, or can this be a routine, regular practice for all ART couples if you're looking at microfluidics?
Obviously, microfluidics hasn't been practiced that frequently in many laboratories, but I don't see any reason why it cannot be applied to that. Obviously, we need more studies. This is not a conclusive answer, but all that I was trying to present in my talk was, yes, microfluidics does give you another opportunity to collect 100% motile sperm, good normal morphology, and a less DNA fragmented sperm population.
As a technology, it's brilliant. In Max, you need the bead, the magnetic stand, and all of that. But when we're looking at the technology of microfluidics, it's just kind of putting the raw semen into the chamber, and we have the motile normal DNA sperms being separated. So, probably clinically, this would probably have a better application. But as you said, time is going to tell us whether we could really extend it to the couples undergoing ART regularly.
I think the reason why it hasn't been brought into the clinical use at this present time is because of the cost implication of creating these chips. Until and unless we find a different material which mimics similar to the PDMS, then obviously there is a limitation. The cost implications is something which is a limiting driver here. So until we get into that and more clinics start thinking of using microfluidics, I feel we still have a long way to go.
Wonderful.
Dr. Krishna, you are not audible. Okay, meanwhile, I'll take a second. Next question for Professor Sheena. This question is from Dr. Sarah. He's asking you to check sperm DFI on a flow cytometry. What is the threshold above which intervention to be taken?
Yes, well, flow cytometry is when you're using the SCASA, or the sperm chromatin structure assay. It's not the COMET assay, which I was talking about, but the cutoff is somewhere around 27%. But that cutoff means that 27% of the sperm were damaged. We don't know how much damage they had. And the other, 73%, no damage was detected. Now, what we do in the COMET assay is we look at the amount of damage per sperm. So if you have the COMET assay telling you you've got 20% damage, that means that you counted 100 sperm and the average damage per sperm was 20%. So they're very different. And this is, I think, sometimes when doctors get confused when they try to take a DFI, which is the SCASA, which is the DNA fragmentation index. That is not the same threshold as the one, for example, that I was talking about today. And the other thing that concerns me is, even when we're talking about microfluidics, I mean, that Perella paper, N equals 5, as far as I understand in it. And I think that we have a huge amount of marketing in microfluidics, and it may very well be the way future. It'd be great if it were, but at the moment we have so little evidence base for for what we're doing that I would think it would be a very dangerous thing to change from a density centrifugation preparation, which is tried and tested, to something which is really a bit of an unknown quantity at the moment.
Thank you. My another question is that in your presentation, you said that oral antioxidant may not work for all the men.
Yes, well, the reason for that is because we understand that a lot of single strand breaks occur in the epididymis. And there's lots of damage happening in the epididymis from free radicals, from leukocytes, and from dead and dying sperm. So you can protect those sperm if you're taking oral antioxidants. But the double strand breaks, which are probably much worse in terms of outcomes, occur during spermatogenesis. And those occur before the sperm even get into the epididymis. Now, no amount of antioxidants are going to protect sperm from those. So that is why I think in most clinics, we find that some men do well on antioxidant preparations and that they don't help other men at all, because there are two different types of DNA damage.
In such case, is there any paper suggests that addition of antioxidant in a sperm preparation media may reduce the oxidative stress? Any comment on that, Professor Singh?
We published a paper on that a very long time ago, actually, showing that if you added a lot of ascorbate, when you were doing a density centrifugation, you could protect the sperm from the damage that David was talking about. But I don't think many other people have really picked up on that. Maybe it's something we should revisit.
Thank you.
We can't hear you.
I don't understand R2D2.
Dr. David, thank you very much for your excellent presentation. I just have questions for you. The first question is, what is how to calculate TZI?
When you're doing the sperm counts, we use 4 fingers: head defect, neck midpiece defect, tail defect, cytoplasmic residue. And you count each defect for each of the abnormal sperm. So the total number of defect regions you've counted over the number of abnormal sperm you've counted them in is the TZI. It's been around for almost 30 years. Work was done in the 80s on that sort of thing. So it's not new, but there was a WHO manual that had it wrong. Surprise. So that's how you calculate it. It just means that when you look at the sperm, since we train people to look at the sperm and say, why not, is it perfect? We'll say, why might it be abnormal? What defects does it have that might affect its functional ability? And I tried to explain a lot of that in a big review article I did in MHR a couple of years ago. And these defects that you look at are related to understanding the sperm that didn't get into cervical mucus, or the ones that don't bind to the zona, for example. So we're looking for things that are wrong with the sperm. And that's how so we define the ideal sperm by not having any of those defects. They're just the ones that fall at the bottom of the sort.
According to your vast experience, which etiology is responsible for which part of the sperm defect? Like for example, whether varicose is responsible for certain part of the sperm, or maybe
the varicocele doesn't specifically cause the defects. It just affects the environment inside the male tract that in most places, most situations, stops spermatogenesis functioning correctly. The differentiation of a round spermatid into a spermatozoon is one of the most complex cell differentiation processes in the body. And there are so many things that have to go on in series and in parallel. And if the environment is not supporting those things, then you see things going wrong, and those may be seen as obvious structural defects. But I think part of the reason why the TZI is so predictive in a negative sense is that there are also probably many other things that are going wrong inside the sperm that we just can't see at the level of the light microscope that we're using to assess the sperm. And something that Sheila mentioned, double strand breaks are a normal part of meiosis. Chiasma are formed as part of the normal thing. So the question is, how many of these double strand breaks are caused by oxidative stress? How many of them are just by chiasma that fail to reheal? And if it's a dysfunction in meiosis, rather than an oxidative stress, those patients or those cases would obviously be totally insensitive to antioxidants. So all this stuff all ties together, but you can't just simply look at it and pick a number here or a number there. What's the perfect number? What's the one thing that's going to tell me the answer? You have to understand the physiology and the world of the sperm to be able to really understand what we're looking at in terms of looking at the sperm themselves.
My next question is, what is the role of CASA in routine semen analysis? And in your lecture, you mentioned only about the motility part. Besides that, is CASA useful for a normal clinician?
CASA works very well on most domesticated species sperm, laboratory species sperm. Human semen is the most disgusting, dirty material you can think of, and patients are the worst of the worst. So sperm concentration values, in our experience, only come out correctly with CASA when all of the errors just happen to cancel each other out. I have not been able to validate a CASA machine to do sperm concentration values that come within 10% of our trained staff that have got reference methodology, go through EQAs, whatever. So I'm hoping this will improve with AI, that the new ways of trying to identify sperm and non-sperm will be much, much better. CASA machines, very few actually even look at the tail when they're doing the concentration. Some of them are validated by saying, oh, you can go back into each screen and deselect the ones that aren't the sperm and select the sperm that were missed. Well, that's fine, but nobody does that in routine. So it's not a validation. So we've actually published recently the criteria, or actually they're about to come out, the criteria that you should be using to validate a CASA machine as a semen analysis tool. But the ESHRE Andrology SIG published in the late 90s saying that sperm count or sperm concentration is not something to do with CASA machines for humans. Percentages of motile are not going to be accurate, because if you have too many non-sperm, which are obviously not motile, being included, that will change percentage of motile. And your differentiation of immotile, non-progressive, and progressive by eye is assessed by whether the sperm tail is beating for motility, or by a specific space gain for progression. The CASA machines don't look at it the same way. So they're going to give different answers. So what we need to do is say, what can the CASA machine tell us? What was it designed for? CASA machines were designed to analyze sperm motility. I was one of the people I did a postdoc in Paris, in Georges David's lab, with Pierre Jouanet and people, and in my own lab in Birmingham, then in Calgary. We were looking at sperm kinematics in terms of sperm function. And these things actually do have value, but not as population values, and not as a thing that will specifically tell you about the whole population, but it tells you about the subpopulation. So looking for the functional subpopulations is what we should be doing, and that's what we do. Mucus kinematic, mucus penetrating sperm, hyperactivating sperm.
And one last question. Can you just enlighten us a little more regarding the redox test, which you have mentioned towards the end of your presentation?
It looks like a good test to us. I'm not a biochemist, so perhaps Sheena can tell us more about the biochemistry, but it seems to be a very good way of assessing if there is a redox or if there's an oxidative stress. I've spoken with the guys who are the manufacturers, the people who supply it, and they tell me that in fact it can also define a reducing state as well, but they don't actually bother reporting that. And the reducing state is what you would get if you take too many antioxidants. So that can be bad as well. So too many antioxidants could be having a negative effect as well. So at this stage, we're just looking at this as being a simple way of trying to find out if there's oxidative stress in semen. We used to use luminometry back in the 90s. That's another very complex, expensive thing to do. This looks like a very simple test, and the initial studies are very promising. Where it's going to go in the future, I don't know. It's like microfluidics. I mean, for most of these microfluidics things, they're not actually microfluidics. Most of them are just swim ups with a stabilized interface. And you could actually do most of the same separation by doing a very careful swim up. And the device, that Zymot 850 thing, looks awfully like a thing that I used in my PhD thesis that was built for me by a guy called Rodney Kelly in Edinburgh. And it's just two chambers with a membrane between them. We use nickel mesh, they use a nuclear pore filter. You can buy those filters. We tried those a long time ago. In fact, some pharmacologists in London were using those in about 1980, I think it was, to test drugs on sperm motility, nuclear pore filters. So a lot of this stuff is not new, it's just being packaged, but it's very expensive. The devices are very expensive, and if you do your density gradient carefully, you can get good preparations with no risk of oxidative stress. If you compare your microfluidics device against poor density gradients, you will see a benefit. I've not seen many studies where they actually have gone in and carefully optimized the DGC method first.
Do we have a time? Can I take a question which is from the question box?
Sorry, ma'am.
Okay, fine.
No relation. Thank you so much, Dr. Mehta, Dr. Lewis, and Dr. Mortimer, along with our wonderful chairpersons, for this very informative session. I now request everyone to log into Hall A for the keynote oration. Thank you so much and have a good day.